Good morning, everyone. Good morning, everyone. Thank you all so much for being with us this morning. If you could start making your way to your seats or grabbing breakfast or whatever you need, that would be great. Welcome to what we hope will be the first annual Resilient Tennessee Collaborative Summit. My name is Richard Kennedy, and I have the great privilege to serve as the Executive Director of the Tennessee Commission on Children and Youth. The Commission on Children and Youth is an independent state agency. We have a very broad and specific mission, and that is to lead systems improvement for all children, youth, and families through data-driven advocacy, education, and collaboration. And one of the things that makes me most proud of the work that happens at the Commission on Children and Youth is the partnerships that we have across the state and the folks that we are able to work with within state government, within nonprofits, within the foundation community, within the faith community, within the business community, and others across the state. So I think all of you being here this morning is a testament to that work, and please know how much we appreciate you all and everything that you bring to the work that we do together to improve outcomes for Tennessee children, youth, and families. So as we were thinking about this summit and the first Resilient Tennessee Collaborative Summit, there were a couple of goals that we had. So as we start the day, I want to remind you kind of what we hope to accomplish today. And I'm not going to try to remember this from memory, so I'm going to read it to you verbatim. So we said this summit will inspire community connectedness, strengthen understanding of community engagement, resilience and positive childhood experiences, and further cross-sector collaboration with local, regional, and statewide partners to address challenges and improve outcomes for children, youth, and families across Tennessee. So at the end of the day today, we're going to want you to help hold us accountable to see if we fulfilled that, what we got right, and what you would like to see more of in the future. So before we get really started, there are a couple of folks that I want to thank. Today would not have happened without a lot of hard work of a lot of folks. So at the Commission on Children and Youth, we are governed by a 21-member commission. Each of the commission members are appointed by the governor, and these folks do incredible work to help oversee the work of the agency and really guide and direct the areas where we focus. So we are fortunate to have two of those commission members with us this morning, Randy Butler from Dyersburg, Tennessee, and Dr. Altha Stewart from Memphis. Dr. Stewart right in front of me, that you're going to get to hear from more today. The other group of folks that I want to thank are the planning team, the folks that did this work really with the leadership of Melissa McGee with us at the commission. I want to thank Sarah Sanders with the Department of Health, Hannah Diven with the Department of Health. I want to thank Julie Rotella, one of our friends at the Department of Children's Services, Jonathan Schoonover with Tennesseans for Quality Early Education, and then some fabulous interns, Teresa and Kate, that have been with us at the commission. So would you all join me in thanking all of the folks for their work in putting today together? So as we continue to emerge from COVID and evaluate kind of lessons learned of things that we all got right and things that we didn't even come close to getting right, one of the things that we continue to be mindful of is that Tennessee's a long state. And we have citizens and partners and folks who are doing great work all the way from Memphis to Mountain City. And for those of us that live in Nashville, coming to a meeting in Nashville is not that hard. But for folks that live across the state, that's challenging. And so building on the success that all of us have had with using technology to loop people into meetings, I want to thank folks that are joining us online. Specifically, I want to thank Catherine Bryan and Katie Spurlock with the Urban Child Institute, who are hosting a watch party in Memphis. I want to thank Stephanie Hubbard and Katie Spurlock again in Chattanooga, who are with United Way in Chattanooga, and the Urban Child Institute for hosting a watch party in Chattanooga. And I want to thank Stephanie Rollins, Lindsay Cody, and Rob Burke for working with McNabb to host a watch party in Knoxville. So to those of you across the state, welcome, and hope that you all find this meaningful as well. So as we are going to get started this morning, it is my pleasure to introduce to you guys a representative of Trevecca. I have a special place in my heart for Trevecca, and that I did my master's work here and had such a fantastic experience. In addition to the beautiful buildings and the beautiful campus, I really love the way that the university embraces and works within the community around campus and across the city. So it's my pleasure to introduce to you guys Dr. Tom Middendorf, who is the Provost and Senior Vice President of the university. So please join me in welcoming Dr. Middendorf.
All right, good morning and welcome to Trevecca Nazarene University. It truly is a pleasure to host the Resilient Tennessee Collaborative Summit, and I sincerely appreciate the opportunity to bring greetings this morning to you. What you're doing here today has such significance, and I've read about the summit and some of the goals, and I might repeat that just because I think whenever you hear goals like this, it's important to emphasize them, to inspire community connectedness, strengthen the understanding of community engagement, and enhance the collaboration among various stakeholders to positively impact children, youth, and families across the state of Tennessee. Friends, thank you for this good work that you're doing and the emphasis that you have on establishing this network, the first time that you've met together in this way. The broader community that comes together is significant as it relates to the success of children, youth, and families. I can't think of a better cause in bringing people together. So at Trevecca, we understand the importance of this type of collaboration. We just completed commencement where we celebrated over 1,000 of our students this past Saturday for meeting their educational goals and demonstrating resilience to be able to get there. And it's in these moments that we often hear people say within this community that it takes a village to be able to graduate students. And there are so many people within our community, both internally and externally here in Nashville, that invested time and attention in these students, whether that's professors, internship supervisors, employers across Nashville, and even the state of Tennessee, because we have online students, advisors, tutors, residence assistants. We can go on and on with the people that it takes. Here at Trevecca, I like to say that it takes a community. There's a significant value in the word community. It gives the impression that all have a place, that you belong. It means that we share something together. It means that we're building and maintaining something together. It means that we're joined together or interconnected. We are a body, a family. There's great power within a community to impact a person's life. We celebrate that reality every May at commencement, and today, represented here in the Boone Convocation Center at Trevecca Nazarene University, is a community assembled to do just that. A group that is in this building, where we come together, building something together and interconnected in a common purpose to impact children, youth, and families. So on behalf of the university, we welcome you, yes, but we also commend you for the good work that you're doing during the summit, and we pray blessings throughout this day, that it's going to be a fruitful time for you. So have a great day and enjoy our campus. Thank you.
Thank you, Dr. Middendorf. We appreciate you taking the time to join us and welcome us and bless our work as we start today. So, when we were thinking about folks that we really wanted to invite to make some welcoming remarks as well, one of the people that rose to the very top of my list was Commissioner Margie Quinn. And so this decision was for a variety of reasons. One is that since the start of the Building Strong Brains Tennessee work and now the Resilient Tennessee collaborative work, the Department of Children's Services has been a critical partner in helping raise awareness and helping spread the message and helping change systems. And so I thought, you know what, we need to invite Commissioner. The second was that when I think about leadership, and when I think about the skill sets that folks have that allow them to step into challenging situations, do the best work that they can do, and really start to see the results of that work, Commissioner Quinn is coming to mind for me as well. And so also when I think about a lot of the experience of trauma and awareness, Commissioner Quinn comes to mind as well. So I can spend time talking with you guys about how this lady spent a career at the Tennessee Bureau of Investigation. I can tell you how she led the work and pioneered the work around human trafficking in Tennessee. I can tell you that when she left TBI, she went to an organization, a nonprofit, I'm always butcher the new name, Ancora, that used to be in Slavery, Tennessee, and led that work. But what I really want you guys to think about as Commissioner Quinn joins us on stage to make some comments and welcome is really the thought of leadership. And what can you learn from her? What can you take from her willingness to step into a challenging situation and work tirelessly every day to make it better? So it's my pleasure to introduce to you guys Commissioner Margie Quinn, the Commissioner of the Tennessee Department of Children's Services. Commissioner Quinn.
Thank you, Richard. It's great to be here this morning. Good morning to everybody. It's great to be here and see old friends and meet new friends. I was thrilled to take this position, just to be back in state government again and back meeting and working with so many folks that I have spent really decades working with across the state on issues that are so important. When Richard asked me to come and make some opening remarks, I had our Assistant Commissioner, Julie Rotella, pull some data on the Building Strong Brains initiative, and here's some of the information that she pulled for me. It began as an initiative in 2015 as an interagency and public-private partnership to address and prevent and mitigate the effects of ACEs, with DCS and TCCY taking the lead. The primary focus was to create a marketing strategy to promote awareness of ACEs and to create shared language and a shared vision. The legislature first allocated funding to be administered through DCS in 2017 to support community initiatives through ACEs innovation grants. There were 13 grants awarded in that first year. In 2019, the funding for ACEs innovation grants became reoccurring funds, and there were 13 grants awarded. In 2019, the funding for ACEs, and it continued to be administered through DCS in 2019. In 2022, Building Strong Brains shifted to a more intentional focus, and it promoted resiliency for our children and youth in Tennessee, which led to the name change for this collective work to the Resilient Tennessee Collective. There's probably a better way to phrase this, but it went from BSB to RTC. We recently awarded 11 ACEs innovation grants for FY24, which emphasize a collaborative effort and systems of change approach to create a lasting and sustainable impact in the community for a total of $1.875 million. That's pretty good stuff right there. So Richard talked a little bit about my approach to trauma-informed, and I will tell you that that has evolved pretty significantly. I spent 21 years with a TBI and overall 26 years in law enforcement. I certainly didn't start my career in law enforcement with a trauma-informed approach. But in doing the work on human trafficking, I was the Amber Alert coordinator for the state for 11 years. I served over the Missing Children's Clearinghouse. And it was in doing that work on missing children that I came to understand that some of Tennessee's missing children were being trafficked. And once you know that, you can never not know it again. And I was fortunate to be in a position where I could do something about it. And so fast forward a couple of years, and I was running the statewide enforcement unit on human trafficking. And I decided to take a trauma-informed approach to that work. And I partnered with nonprofits across the state and had them with me in the hotel rooms and on the operations so that when I recovered a victim of trafficking, they saw the nonprofit first. And they went with the nonprofit from that operation. They didn't go to jail. And so that changed the way we approached human trafficking operations. And as a result of that, prostitution arrests declined 65% because law enforcement changed the way they approached prostitution arrest. And they changed the way they looked at the crime of prostitution and human trafficking. And that's how we know that something like training works. When you see a reduction in prostitution arrests by law enforcement, 65%. That's good stuff. That's what we call a trauma-informed approach. But when we look at a trauma-informed approach to management, we're talking about transparency. We're talking about mutuality. And when I took that approach to DCS, it took the form of a lot of communication, a lot of emails out to staff, a lot of transparency. When I communicate to the legislature in the 16 hearings that I've testified in since I took this position, it's about being transparent. It's about telling it like it is. It's about not sugarcoating the situation that we're in. But that trauma-informed approach also means taking care of staff. And it means doing things like putting in place peer-to-peer counseling. So we're training peer-to-peer critical incident counselors all across the state so that we're taking care of staff, because doing this work is really tough work. And we need to take care of staff so that they can take care of kids. That's really important. By the end of this year, we're also going to be standing up a chaplain program, because we know that individuals who seek counseling seek it in all kinds of different ways. Sometimes it's peer-to-peer, sometimes it's through traditional talk therapy, which looks like EAP through the state, sometimes it's through clergy or chaplain programs. We want to be able to offer all kinds of programs for our staff because this is really tough work. I know that trauma occurs in law enforcement, in social services. It occurs in all kinds of work. It occurs in your personal life, it occurs at work, and we want to make sure that we are able to serve our employees as they serve children. If we're not taking care of employees, they're not taking care of kids. So that's important. That's an important part of this work. It's going to come as no surprise that one of the first things that I did was stand up a human trafficking unit at our new agency, at the new agency that I'm working for. So we now have specialized human trafficking case managers all across the state. Now, that doesn't mean that I went out and got new case managers. It just means that I took specially trained case managers, took all of the trafficked youth that were spread out amongst case managers all across the state and concentrated them with these specially trained case managers. I'm going to let you in on a little secret. Once I did that, the feds paid 100% of their salaries. That's nice. So, as those cases grow, we will train more and more of our case managers. That's working extremely well. Those case managers are liaising with the TBI's Human Trafficking Task Force. That program is going to work extremely well because they're also working with the human trafficking nonprofits across the state to receive specialized case management. That's going to reduce the run incidents for these youth. It's going to increase the service delivery to these youth, and we hope it's going to reduce the number of times these youth become trafficked. It's going to reduce that revolving door. The younger we get the youth, the less time they spend in a trafficking situation, the quicker they become a recovered victim, and they're not a 25-year-old victim, a 30-year-old victim, a 40-year-old victim. Again, it's about a trauma-informed approach to serving victims. Just a couple of more things, because I know Richard only gave me 10 minutes, not 30 minutes. As you know, when I came into the agency, we had a couple of challenges. Just a couple. We had about 620 openings in the agency, and we had soaring caseloads, and we had a 13 finding comptroller report. We reduced the number of openings in this department by 48%. As of this week, there are no foster care caseloads that are over 20. There are only 2 regions that have an average caseload over 20, and that's Davidson and Mid-Cumberland. Those caseloads are reduced from when I hired in January, the caseload average in Davidson County was 96. It is now 39. The caseload average in Mid-Cumberland, which is the donut around Davidson County, is now 28. And the statewide average is 18. The comptroller very famously reported that the turnover rate for first-year case managers was 97% in 2021, and I'm glad to tell you that the turnover rate through the first 5 months of this year is 12%. There were 620 openings when I hired in for case managers. There's now 369 openings. The more people we hire, the more those caseloads go down. We're making tremendous progress. We're making tremendous progress. There are 1,128 foster parents in the pipeline to become new foster parents. We're making amazing progress, but we have a long way to go. We know we have a long way to go. So with our partners behind us, and that's you, this is a we issue, right? This is not an I or a you issue, this is a we issue. All working together, we are going to solve this problem. We appreciate the continued support of all of our partners. We know that you all have stood behind us through this long slog, and we know that you're going to continue to stand with us as we continue to make progress, because it's what's in the best interest of families and children. We have a new mission and we have a new vision at the Department of Children's Services. Our mission is to act in the best interest of Tennessee's children and youth. And our vision is children first, exclamation point. And as long as we're doing those 2 things, we're going to get it right. Thanks for having me this morning.
Good morning, friends. That was kind of wimpy.
Good morning.
Yeah, right, Dr. Stewart. Good morning. All right, we're so glad you're here, much like Richard welcomed you. Richard is somewhere, but he welcomed you in. I want to say thank you. My name is Melissa McGee. I get the privilege of working with the Commission on Children and Youth, as well as being part of the oversight of the Resilient Tennessee Collaborative. I think Richard may have mentioned this, but I need to say thank you to our intern, Kate Keese, with the University of Tennessee Social Work. She's way in the back. Like, this wouldn't have happened without Kate in our world. So we're thankful that she was able to be with us. And also, Teresa Sipes is another intern. I don't know where Teresa is, but she's been wonderful as well. And all of our TCCY staff and our planning team, everybody. So I just wanted to hear that from me. I wanted you to hear that from me to say thank you. One housekeeping note, I have a very attractive silver hoop earring. Now, if you've already had to take your hoops off today, we can work that out. But if this is yours, I'll be in the back wondering. You can come and see me and I'll have that for you. We are so excited that you're here. If you were with us at Children's Advocacy Days, a couple of our speakers will look familiar. They have invested their time and been very intentional with the work they are doing with us here in Tennessee. I have the privilege of introducing Dr. Christina Bethel. Dr. Bethel is a professor at Johns Hopkins University in the Bloomberg School of Public Health and School of Medicine. Her research focuses on building and translating the science of healthy development to promote early and lifelong health of children, youth, families, and communities. With roots in national and state healthcare policy, financing reform, and delivery system redesign to promote whole child and family health and integrated services, Dr. Bethel is the founding director of the Child and Adolescent Health Measurement Initiative, as well as the Data Resource Center for Child and Adolescent Health. She led the design and national use of adult, child, and family-centered quality and outcomes measures in common use today, including measures that you may be familiar with, like medical home, adverse childhood experiences, positive childhood experiences, family resilience, child flourishing, and the Integrated Child Risk Index. Her research has shaped policies regarding adverse childhood experiences, relational health promotion, including providing testimony to the U.S. House Committee on Oversight and Reform, and she testified about identifying, preventing, and treating childhood trauma, and the design of engagement in action framework that created an integrated systems of care. She has an MBA, earned an MBA and an MPH from the University of California, Berkeley, and a PhD in Public Policy and Health Services from the University of Chicago. Join me in welcoming back Dr. Christina Bethel.
Good morning. Thank you for your attention for the next 15 minutes, and hopefully we can have a little dialogue as well. The name of my talk today is We Are the Medicine, Building Relational Systems of Care to Take Child Flourishing to Scale. And I want to begin just by, first of all, saying I do not have any conflicts of interest to disclose, but also to thank all of you for being my dream come true. So when we started, literally back in 1999, designing what we would collect nationally, because we didn't have data on children, youth, and families back then. There was no national survey of kids, children's health, or anything. We tried to include at that time adverse childhood experiences, because the research was out, resilience, flourishing, families, and all the school-related variables so that we could tell a story. And it took till 2013 to be able to get that to happen. So we had our first data, and Tennessee was the very first state that I worked with at that time, with Lorraine Luzinski, if any of you remember her, and other people. So I've been coming to Tennessee since 2013, and I think this might be my 6th time here, but in different places and different faces. So I'm just really want to say that I hold you in my heart as a state that is really up to something and is leading the way nationally. So I want to thank you for that. I also want to thank all the people who've come before me who's really laid the groundwork scientifically. There was a day not too long ago when we didn't understand the neurobiology of healthy development and its link to who we are and how we are with each other, relational health. So we know that now, and the opportunities are absolutely phenomenal. So it's really, I want to thank all of the lineage of people who've built that step by step. But most importantly, I want to thank the children and youth and families that I've had the opportunity to work more closely with in my own journey. I do actually do some healing work and mindfulness-based stress reduction around trauma-informed care just on the side. And one person in particular, I call her Sweet Pea, has 8 ACEs, and this is a picture of her and a picture she drew in 1 minute. So one of the techniques that we use is automatic, sort of just art, just full expression right from your core. And in her, she says she had great heart, so she poured it all out. And then in the next part it says, it's lonely here without my heart. I know I'll give more. And slowly by slowly, she was draining inside. And it really came at a certain age to be able to start to get on her own side, not to see she had needs. And this is some of the things that happen with trauma, right? It acts out in different ways. But she wrote a poem explaining her experience of how she started to see it's not what's wrong with her, it's what's right with her, it's the strengths, and it's what happened to her, and how we really are affected through our experience, and how we can find that place inside that has the capacity to hold our lived experience from a place of presence and mindfulness and faith. And so she gave me permission, which she has not done for a long time, to share a little bit of a poem she wrote called Only Begins. And here's how it goes. I am in the world, and the world is in me. From my nose to my toes, to my belly to my knees. What's in is out, what's out is in. Endings can't be endings because there's only begins. And that's what she talked about, this emerging experience of being present, having never had that experience really of being here and then being able to take choices going forward rather than just reactions. So she explains, begins are like flowers that lean toward the light. When I'm aware of what is there, it's never really night. The scariest of scaries are just frights from before. I'm almost never afraid of what's actually at my door. And I could spend the next hour going through a debrief of what she meant by every stanza, but it's really the kind of things that you're up to every day as the medicine that we need relationally that makes that possible. So I wanted to just open by thanking Sweet Pea and also other children who've been on the journey of healing and give me so much hope. So I didn't disclose any financial disclosures, but I will disclose with you that my whole career has been really led by the opportunity that I see in translating the science of healthy child development into policy and practice in a very grounded way. What we value, how we train, how we spend our money, how we stay flexible and adaptable as we learn to stay in a learning mindset. And one of the conclusions that I've come to is that the best science we have would say we are the medicine. In other words, how we are with each other, how we are with ourselves, it really is the difference between why the best programs either succeed or do not succeed. And all of you know that it's our relationships with each other programmatically and with those we serve and in a community that are really the linchpin of whether we're going to be successful. But it's not just what's happening in our mind, it's actually in our bodies as well, like Sweet Pea said. This is embodied trauma that we're carrying intergenerationally and otherwise. So we are the people that are sitting with the wealth of information that get to push this forward, be that link in the chain. And so I want to commit to that, and I know you're committed to that as well. But if you can't go to good places in your mind, if you can't go to good places in your body, so that we have to really bring together the oneness that we are with ourselves, and I would say with all of us, in order to really succeed. So this is not about, fixing something. We have to go from fixing to connecting. So I wanted to just say that, I disclose that. When I was first here again in 2017, we talked about a national agenda to address ACEs and looking at, some of the 4 different strategies, and there's a lot laid out there. And it was very focused on adverse childhood experiences, but from a possibility mindset that really recognized that it's promoting the social and relational roots of well-being that is the real strategy for prevention. And that we needed to start to really think about what we were going to do in terms of building well-being and health and containing the ACEs agenda in a larger construct of well-being. And then the next time I was here, just how many people were here at the CAD meeting in March? Okay, some of you were here, and this was my last slide, so I'll start with it here just to summarize. Talking about a new science of thriving, which really is just the name we've given it, but requires us to focus on the capacity for positive human development and flourishing even in the face of adversity and illness. Advanced skills for well-being, which are learned, like Sweet Pea, you learn things through a relational process, through an internal process, but we actually can grow and change at any moment. But they requires enabling context and supports in order to rewire the impacts of trauma. It doesn't happen on its own. In fact, trauma can be continuous, where it has its impacts worse when you're older than when it happened, because it's continuously reverberating in your nervous system. So we really need to look at what are the contexts and supports that can come around to help us heal. To keep the focus, therefore, on the social, emotional, and environmental context and dynamics that we have to recognize we are co-creating. Now, we may inherit them, but they're co-created, and we can recreate. Might not see it all in our lifetime, but we have to commit to be that link in the chain. But we have to really look at how we can recreate our social norms and context, our emotional norms and context and capacities, and also environment, which Dr. Sege is going to talk to you a lot more about. Balance our conventional focus on negative development, which there's a risk with ACEs that could happen, but and risk factors with an explicit focus on what is already whole and where the strengths are, like Sweet Pea, for her to even get to the point of being able to receive support. What did she survive? What were her strengths? What's going on there? And to start and pull that out and build on that is so critical. And finally, to innovate, to really innovate in policy and in programs, to be in a learning mindset, which a lot of our programs don't necessarily let us be, because we get protocols and we stick with them and we don't adapt as we learn. But to innovate, to engage what I think are largely untapped capacities for healing, resilience, and well-being at the individual, family, community, and societal levels. And now is the time. So my objectives today are a little bit different than the last time I was here. I'm going to talk with you about a framework that we created very closely with Mississippi and the federal government agencies, HRSA and ACF and others, called the Engagement in Action Framework, ENACT. And it very much is based on positive and adverse childhood experiences science translation, but in the broader context of cross-sector collaboration across agencies and in communities that have a more complex process going on. I'm going to reground into the science of flourishing and the flourishing paradigm, because I think it's really important that I do that, because that's what this entire framework is about. And then as time permits, I'm going to go into some more detail, because the framework does include a policy playbook, what are the roles of all the different agencies as it relates to this, but those are resources I can share with you after. And I'm offering it to you as you enter into a more serious time of collaborating across agencies, which is very exciting for everyone, and seeing if this can help you. So, you know, we all know how many of you have heard the Eco-Biodevelopmental Framework, or the original, so the American Academy of Pediatrics in 2012 or so came out with a statement on toxic stress and ACEs, and used this diagram to represent what the science was of adversity. And I would just say what was missing at that time, what do you think might be missing at that time, was it was very focused on the bad things that can happen and the bad ways it can actually impact you and the bad things that come out of it. And so it didn't talk about, in any explicit way, what good could go right and what was intervening and why most people with adverse childhood experiences do not go on to have one of those conditions they're more likely to have, but most do not. It's the difference between relative risk and absolute risk. Most people with ACEs do not go on to have those diseases. They're just a lot more likely to. And so what is it that we can learn about positive health and positive deviance, all of that, what do we actually can learn about that? And that's what I was curious about. So our research, along with Dr. Sege and many other people, led to a body of work that in 2020 allowed the American Academy of Pediatrics to instead reframe and flip the dialogue from toxic stress and trauma as the problem to relational health as the solution. So this is the platform for the American Academy of Pediatrics now. And so I'm going to share with you for sure some of the research that was done that was contributed to that, and there's a lot of things that did, but that's a big deal. Don't you think that's a big deal for them to say relational health is the thing we need to focus on? And toxic stress is one of the things that gets in the way of relational health, which is the bedrock of our well-being. So part of our work, too, was to start to look at, so how many of you are aware of the term social determinants of health? And there's a lot of policy requirements to measure social determinants of health in states and even through the state innovations and things like that. But they mostly focus on economic hardship, housing, food insecurity, neighborhood situations and things like that, and haven't yet brought in some of the risk factors that are important to the well-being of children, like the well-being of their parents and the mental health of their parents, and also ACEs and coping and how well parents are coping and how their family's doing. So in order to inform some of this work nationally, we worked with the AAP leaders and others on a study to separate out what we had now in the national survey. After 25 years of measurement work, we finally had all the variables in one place where we could analyze this, looking at associations between mental, emotional, and behavioral health of children, developmental problems, special health care needs, and things like that, and the social and relational context that they lived within. And so I'm just going to give you a punchline, because this really, I think, supports the dire need to stay with a systems-oriented approach, which I know is what you're doing, and how critical it is that we have to work together to address medical, social, relational, as a team in the lives of children, families, and communities. So I'm going to be showing slides today that I just want to make sure you know I can share, and so don't get too caught up in trying to understand it all. I will tell you the punchline, but I do also want to share them because, first of all, it can be fun to look at something, but I just want to make sure you know that. So I'm going to go quickly through some of them. Okay, so this is basically looking at relational health risks as the social health risks and relational health risks. So children without either of these risks that I just outlined, the rate of mental, emotional, behavioral health conditions is 15.3%. Once you add one relational health risk in, and these are high bars, by the way, we've used 2 or more ACEs, severe mental health problems in the family, things like that. So it's a high bar that we used. If we used a lower bar, this would be different, was 18.5. But once you add in 2 relational health risks, it almost triples. And so this is cumulative, right? We know it's cumulative. It's not a magic bullet trauma or a magic bullet positive. It's really the accumulation that ends up being the effect. So that's a big, big impact that shows that even without social health risks, that having these relational health risks has a big impact on mental health. That's not surprising by the science, but I don't think we live necessarily realizing that 60% of children with these higher levels of relational health risks do not have social problems. So if we only look at social determinants of health and use a high-risk model to only address that, we're missing the bulk of kids in the country that actually have a lot of risk as it relates to their mental health. And so I think it can influence how we think about policy, and that this is an all of us kind of thing. And then just going along, it's similar pattern to the point where up at 2 or more of each of the social risks or the relational health risk is 61% of children in the country, using a pretty high bar for mental illness, meaning it was actually diagnosed, so we know how many aren't diagnosed, right? Having a mental, emotional, behavioral problem. That is astounding. And so there are a lot of communities and neighborhoods, I'm sure in Tennessee, where this is the case, where there's a lot of kids with 2 of each. And this is just what the national epidemiologic data is showing. So this paper goes into a lot more depth. We have all the data for Tennessee, so you can get everything you need from this kind of analysis for Tennessee. So that kind of sets up why we wanted to create the engagement and action framework. And Mississippi was had the largest amount of investment from Congress for a 5-year project, $17.5 million, to really look at improving preventive and developmental services focused on early childhood. So this is focused on early childhood, but it was created to be relevant across age groups and across many other populations. So I'm going to just go through it, and also, for those of you who want to learn more, there's a possibility. But this is just a one-pager. You don't have to look at all this, but there's actually a one-pager that lays out the goals, the purpose and the goals, the approach to services across sectors, across 8 different state agencies, and some of the simple rules you would all agree to, because if you're going to work together in a complex system, you can't do it based on check boxes. You have to actually embody the agreements about how you're going to work together, because every interaction's emergent, and so on and so forth. So it also has principles for collaborative action, and what we call simple rules that everyone at every level can agree to so that they can be a force for good, that I'll share a little bit more in a minute. It has 4 different implementation roadmap actions with about 12 outcomes that at the end I hope I can go through with you a little bit more to ground it. But now I'm just going to introduce it and then share a little bit more about the science of flourishing. So we call this one big doable thing, which, it seems like, oh, if you're going to do a systems transformation, you might as well try to do everything. But we really wanted to focus it on something. And the focus was, first of all, on positive health equity is the purpose. It's not getting rid of something bad, it's creating something good, and it's doing it in a way that promotes equity. So positive health equity is the purpose. And the specific goals for that purpose is to catalyze child health equity, improve child flourishing, school readiness, and family resilience, which we now are fortunate enough to be able to measure for Tennessee and all states in the National Survey of Children's Health. And this data is available right now on our website, childhealthdata.org. So we can measure it. It's not a fantasy. We actually can track these things and have our sights on something positive. The goals, one of them is really to recognize we already have a lot of rich resources in the state. We have programs. We want to leverage that. So the design parameters for this, we're not starting over, but really how do we take what we've already got? So one of the recognitions is most of the state agencies, whether it's early care and education, Head Start, child welfare, early intervention, of course Medicaid and all the health plans that are contracted, all have similar accountabilities. If you read through their statutory grant requirements, their performance measures, which we did, they all have some accountability for promoting healthy development of children, prevention, and screening, and also making sure that there's resources available. So first is all in, making sure all children through any door, wherever they show up, and most of the kids who need to come in for, say, well visits with providers are not coming in terms of just the raw numbers, most of the visits are not occurring. We have to work in the community, and those community organizations like Help Me Grow and many of the other ones that I'm sure you have here are doing this kind of work. So all in. The second is real engagement. Not a billboard, we engage you, we partner with you, but real engagement, like creating an understanding that without me telling you I want help or here are my priorities, you could help me all you want and it may not be going in. If you're not listening to what I want, meet me where I am, and no matter where I am and what I say my priorities are, meet me there. That will pull the thread of trust and support for me that can then lead to something else that you might think is more important. So this is really important that we create mechanisms that establish real engagement and real voice for families, communities who need to lead the way. And finally, the seamless system. So how do we create the braiding and blending of functions, building on what we already can do, and then looking at the policies that can enable us to do more? So I'm not going to go into this too much, but I'm just showing you a quick slide that shows what the compelling need is, especially for early childhood, that about 1 in 10 children in our national studies are meeting one of 4 basic recommended services, like developmental screening, maternal depression screening, getting family-centered care, and so on. And only a third, after billions of dollars and years of it being paid for and in a performance measure, are getting developmental screening, let alone the follow-up piece. Receiving mental health services, if they're needed, also very low, 33%. Medical home, which is a model of care that really isn't just about medical, but working with the community, it's innate, schools and all of it, is still about half. And I, of course, naively thought when we got the measures, we'd share the data and suddenly it would get better, right? Because people will make it better. So we have to dig deeper because these figures have not changed in like a couple decades. And so we need to do what I think you're endeavoring to do across systems. And then healthy and ready to learn, which is a pretty, modest measure. If you look at how we score it, it's about 2 in 4 children in the country actually meeting criteria for being ready to learn at the age of 3 to 5. And that work will go on. That data will also be available very soon for Tennessee. So with 2 in 5 ready for school, about half of the estimated visits for preventive services and the ones that happen low quality, and only a third of children still being screened, the compelling force here was let's do this one big doable thing. Let's see if we can actually rise up to what we know we need to be doing, and that it's really shared as a commitment across most of the agencies to do early intervention and supports and prevention. So that's what kind of led to one of the pieces of this really is optimizing the resources that are going to healthcare for well as it's redistributing and being able to really create a through any door approach. That through any door approach really recognizes that families come to community services, they go somewhere, wherever they go, even if it's a church, there can be engagement where everyone's empowered with tools and resources where they don't have to become a medical doctor to do it, to engage a family, build the trust, make sure that they get connected and create a way to self-assess, pick priorities so that whoever's working with them can start to support them and then link them to where it is that they need to go. But if we don't all do it differently, we're not going to be able to communicate with each other. So there was a recognition that this needed to be a systems intentional process, and there's a lot more detail that we can talk about, but one of the things we did was interview each of the sectors. There's family, raise your hand if you basically consider yourself to be family support, community-based organization. Okay, raise it high. Government programs, which are there many, accountable for early childhood development and child well-being. That's obviously home visiting, early intervention, other high-risk home visiting, federally qualified health centers, Medicaid, human services, early care and education, Head Start, WIC programs, protective services, and so on. So raise your hand if you're from some of those programs. Okay, good. And then we just go on. And so what we did was we looked at all the players and looked at what they were already accountable for, what they were measured for, what roles they could play, and really did a deep dive in Mississippi. But it turns out that I think it's going to be really similar for other states because most of these programs, a lot of these programs are actually federal, and so you're sharing a lot of requirements and resources. Tennessee's way ahead of other states in terms of how you do early intervention and things like that, so you're already way ahead. But it's the integration, and with the Child Find program, if you're aware of that for early intervention, that's prevention. That's not just taking kids in once they are already have serious developmental problems or are already in the child welfare system. So that was part of it. So we've created these prototypes that I invite you to read to get grounded. It's like a story. So how many love stories? We love stories. So this was a story for every single partner looking at pediatric primary care, community-based, home visiting, early intervention, child welfare, faith-based organizations, obviously Medicaid and health plans, Head Start, and so on, and of course the early care and education program and resource and referral center is really important. What would it look like for them if they were to start to approach? So it was through that process that we designed the framework, so it was design-based. So we had ideas, went out, created these case studies, grounded it in how literally it could work for child welfare. Why is this relevant? How could it work? What could we do now? What do we need to change to do better? And so I want to make sure that I offer that to you, but also recognize how far along you are. So here's something from a case study on building strong brains. You've already named the layers, the philosophy and mindset, the policies and funding, programs and services, professional practice, all the different players. I would say that when I look at this, it's practically ideal. In terms of its inclusion also of healthcare, because a lot of these systems leave out healthcare, which has a lot of money, resources, and requirements that hasn't been necessarily connected to all the other programs the way it must be and is increasingly required to be. So I would say the Building Strong Brains and now Resilient Tennessee initiative is very far along, and I know that you're building on this. And you have all of these, grantees from the past and the future that all are on the train. To keep them together is also a big part of the engagement and action framework, is how do we keep people together in a learning mindset that as they learn, they start to train and support other communities, and that's really the wealth that's going to allow us to actually have transformation happen. So that is a quick summary of the engagement and action framework, and what I'm going to do right now is just do a quick pass through the flourishing paradigm, which this is based on. Obviously, we're trying to start where we want to end up, which is not just the absence of something bad, but the presence of something good. And so flipping the narrative, just like the AAP did on toxic stress is the problem to relational health is the solution, we're flipping the narrative here from not having a bad thing to having an actual good thing. So what do I mean by that? I'm going to go pretty quick, but mostly because I want you to have references, but I will speak the key points. The absence of illness is not the same as being well and flourishing. How many people can think of somebody in your mind who doesn't have a diagnosis or an illness, but you would not necessarily say they are flourishing? Does anyone know anyone? Yeah? Okay. So that's key. And why is that important? Well, first of all, I just want to say, when we look at adults, this isn't the prettiest slide, but there is a longitudinal survey that allows us to look at flourishing among adults in the U.S. that's been around for over 50 years. And Carol Riff, who's one of my heroes, put a paper out last year looking at the proportion of adults right now in the country, and we are the people trying to help our children, so this is important. We are the medicine, after all. How we are matters. There's two types of flourishing. Hedonic is flourishing of the remembering self, which is sort of up till now, how satisfied are you with your life, and also the wanting self. Like, do you get what you want? Like, do you have good experiences yourself? That's not a bad type of flourishing, right? But it's one type. The other is eudaimomic flourishing, which is a sense of meaning and purpose and engagement and commitment and contribution and mattering and all of those, and having an intentional process of looking at possibilities and staying in the game in the face of difficulty. And so these are two different kinds. And what the summary is right now in the country is about 23.6% are low on both of those types of well-being. About 15.7 fall into a group of high eudaimonic, lots of meaning, purpose, connection, not a lot of life satisfaction or happy-making experiences, but they feel their life has meaning and purpose, and there's a depth there. The next is somewhat on both, which is basically not that great, not that bad, and then about 19% on being high, mostly high on both of them. So about 1 in 5 adults in the country are meeting these criteria, and we are the people who are working with the families, so we want to pay attention to our own well-being. Another study is an early one on flourishing and positive mental health, which in many ways is positive mental health, right? Because you can be physically ill and still have some of these qualities. Looking at the connection with mortality, and so this is another study that was done, and there are many others that looked at death rates for adults that had similar levels of illness and problems and adversities, but who had somehow adopted these qualities of flourishing. And it was death increased as much as 62% over a 10-year follow-up for these adults in a longitudinal studies when they did not exhibit these qualities of flourishing that are within our reach, because they're mostly dependent on our relationships and our environment, which we can actually do something about. So the absence of flourishing was a cause of death, independent of all other factors. There's also a field called salutogenesis, which is the formal study of well-being and what makes us well, that's been around a long time. Also looking at decreases in death when we do not create this sense of coherence, is what they call it, which is being able to stay present, like Sweet Pea talked about, and make meaning out of our lives rather than staying in a completely traumatized state in life all the time, which is a healing process. Being able to have that emotion behavior regulation, not that you don't have lots of emotions and instincts, but that you are aware of it so that you can actually be responsive in life and not just perpetuate problems, and finding meaning. And so this was also associated with a 30% difference. So there's lots of ways we measure this, but I'm going to ask you to measure it yourself. So get your phones out. I'm going to ask you to to do a QR code, and let's do a poll as a group. Okay, so basically we're looking at sense of meaning and purpose. Think about yourself. Engagement with life and others. Belonging. A sense of connection. Supportive relationships. Possibility mindset. Looking for the good. Finding ways to stay hopeful, optimistic, looking for strengths, and then when the good happens, taking it in, not just passing it off. Seeking to contribute, even if it's your smile or your being, every moment matters, you matter every moment, we affect each other deeply. And then also an inherent sense of worth that isn't because I do something for somebody, but because I matter anyway. And that is actually one of the lowest that can happen, is people feel like, I know I make a difference in the world, but outside of that, I don't know if I don't have an embodied sense of my own self-worth. And so this is important. So because everything you do makes a difference, I'm going to ask you to scan this code. It might be easier to scan that one. and then I'll come back, and you all will have access to the results, or you should. So if you start to see results pop up, maybe after a minute here, somebody can call them out. And I do have the website open, but I'm afraid to move to it because I'm afraid I'm going to lose my place. So I would love it if somebody could tell me when they start to see a good amount of response. Okay. What are you seeing? I could actually do this, I suppose. Okay, can you see that? No, you're not seeing that because I changed. Okay, so I'm seeing 36% all 6, about 43 for 4 to 5. It's moving up and down. Some more of you are filling it out. About 114 people have so far. So I would say this group is higher than some of the other groups that I have seen, but it tends to be about a third or a little less that are in that all 6 group. It's usually about a third in the 4 to 5 group in my past, but you guys are up around 45 stable here now. About 1 in 5 of you saying 2 to 3. So, I would say there's opportunities for us here even to be a support to one another, because it's a little like the weather as well. It's not like you're born with a level of flourishing and it stays the same, right? Resilience comes and goes. It depends on the day. So if we can stay attuned to each other and how we are and to ourselves, we can build strategies to support each other and ourselves, and be aware of how important it is to have these qualities, because it can be a quick nosedive. When we start to go down to 2 or 3, it's easy to get to 1, and if we don't talk about it and make it important to you as a team, you as the people who are working with children and families, matter every moment. I talked a couple times ago here about limbic resonance. We are regulating each other's nervous systems whether we like it or not. I can feel how you are. It impacts me. And so I want us to be attentive to that. So we ended up with 28% all 6, 44% 4 to 5, 23% 2 to 3, and 5% 0 to 1. So I'll put this in the slide deck before I share it so you can have that. And now I'm going to go back to this. Can you see my slides now? Okay, good. So I'm going to go, oops, can you put my slides back up? There we go. Okay, so now I'm going to go more quickly than you would like, but I want to make sure we have some time to come back to the framework. But Bob's going to talk a lot more about this, so you're in for a treat. So I want to tell you that in the country, when we measure flourishing, it was very hard to do. There's a whole paper explaining it, but we looked at 3 key things parents could observe about their children. Being interested and curious in learning new things, being able to have body, emotion, behavior regulation, so that when everyday challenges happen, there's not either a meltdown or an acting out that is out of keeping with the issue. And this was I'm just reporting 6 to 17. It's measured differently for young kids. And then persistence and determination. So when I set a goal, if a child sets a goal, chooses a task, do they give up easily, or do they stay in a learning mindset? And so persistence and being able to be in a learning mode rather than, if you can't figure it out, kind of quitting quickly. So about 2 in 4 young school-age people and up to age 17 in the country met these criteria. It got worse as children got older. And there wasn't as big a difference as you might think across income groups, whereas we do see a lot of big differences in diagnoses and things like that. We don't see as much difference in well-being and flourishing among our children and youth. So this is what it looked like, and then I call this equally unequal, that once you bring ACEs into the picture, it's exactly the same impact on flourishing. So whether you're below poverty or 400% and above, the flourishing rates are exactly the same once you have 2 or more ACEs. So we know that ACEs are a big impact, but we also know we can do something to promote flourishing. And so, that leaves us in a place of opportunity, but still needing to very seriously look at, creating the context to reduce the exposures, right? So I wanted to make sure you knew this. I have a lot of equally unequal slides that show that across income groups and race groups, there's a lot of more similarity in these qualities that are not as inequitable, and in some cases even it's higher for groups that you would think are more disadvantaged, because what do they have to do? They have to find a way to survive. So we won't want to use that as a reason to not pay attention. But often it's the people with the lived experiences and the challenges that have the most to teach us about how to be well, how to heal, and we need to really bring them in, as you know. So in terms of this, all I want to show you is, remember I mentioned the social health risks and the relational health risks before. And the blue bar here, the bright blue bar with the red circles around it, are children who have none of those risks, none of the social or relational risks that we just talked about. But this is their sort of self-regulation capacity, one of those key factors in flourishing. And it's 79-80% if they, so 80% if they, what am I looking at here? Oh, school engagement. Sorry, I have another slide next. I flipped them. So this is the school engagement, which is, am I showing up to school? Am I interested in learning? So this is relating a couple different factors in the flourishing measurement set. So school engagement by self-regulation. And it's 79% are engaged in school if they have self-regulation. But if they don't, even without those risks, it's 26%. So this is to show that even without the risks, without ACEs, without social determinants, risk factors, that this capacity to build resilience, which is what you're all about, is very impactful in being able to help children like Sweet Pea stay involved and engaged while she continues her healing and not have an early life experience of not being successful in school. So the possibilities are great, but we need each other. That's what I love this picture. Someone sent it to me. It's not a picture from the internet. It's actually a picture of something. And the possibilities are great. So we have another study. This is the same one that I just showed you. Again, the blue bar are children with neither of the social or relational risks, looking at the impact of parent-child connection. Actually, talking about things that really matter, which is getting to a key positive childhood experience. And looking at the difference in children's self-regulation, which is so predictive of their school engagement, based on parent-child connection. So even without any risks, we have 25% of children who don't have strong parent-child connection showing that self-regulation capacity, and 55.7 if they do. So we still have a lot of issues with building that capacity in society, which gets at more of the environmental, community mattering, and those kind of things. But you can see that it's over twice as high. And these are in the studies. If you want to read them, there's all kinds of statistics that we can share with you. So I would just conclude that this is all of us, that eliminating risks is not enough to protect children, that children without any social or relational health risks assessed have a 71% lower odds of demonstrating good nervous system, emotion, and behavior regulation, which is how self-regulation breaks down, and if they lack stronger parent-child connection. So this brings us right into the heart of fostering family resilience, parent-child connection as a protective factor, okay, that could lead to positive childhood experiences. Okay, so we're going to talk a little bit about that, and then I'm going to leave a lot of it to Bob to go into detail on. But I wanted to just say this works in schools, so teacher-child closeness. There's studies showing that when a child feels, they have to feel it, okay? It's not enough for you to come in and observe and say, you're close to that child, or you have to really experience it, because that's what's knocking around in your nervous system and in your sense of identity, is you feel close. So when children feel close to somebody, their teacher, with every level of risk, it helps their, all these measures, things like inhibitory control, cognitive flexibility, working memory, reading, and math. This was all like hardcore school outcomes, not just flourishing, right? So that's really strong. CDC came out with a study. How many of you heard about the rates of, mental illness among youth going up. And I'm not going to talk all about this, but part of the study was asking about a sense of being close to somebody at school, which is another positive childhood experience. And what they found was that those on the left-hand side for you, those who felt close to someone at school, which was less than half, okay? So less than half of the youth in this CDC study felt close to somebody at school. Opportunity, really big opportunity, right? But when they did, they were much less likely to have reports feeling sad, hopeless, or having depression or other mental health problems. But less than half did. It was not as impactful if it was virtual. So virtual connection was hardly, really, on the all of it, not as impactful at all. It matters. There's ways we can optimize virtual connection, but it wasn't as big a deal. So the bottom line is there's no one thing and no magic bullet. Just like adverse childhood experiences, positive childhood experiences are cumulative in terms of their impact, which is great because they can come through lots of different doors. We have science that would say parent-child connection and attachment are there, but we were already dealing with a lot of kids who never had that. And so what are we going to do in the environments where we can impact and move toward healing? The first study we did on this was in 2016, looking at all the variables in the National Survey of Children's Health we were able to get, looking at that parent-child connection variable, family hope, and knowing they have strengths to draw on are two big things. And these are the adjusted odds ratios, which is basically saying what's the likelihood a child that does or doesn't have this is going to flourish. So this is based on odds of flourishing. And I'm just going to ask you to look at the pattern without looking at the numbers. But you can see that when we get to the parent participates in events and there's at least one adult mentor, they're impactful for sure. But we are looking at the more deeply relational pieces and sense of hope and family resilience that are packing the biggest punch. But the main thing is what happens when we combine them into a cumulative score just like ACEs, which, we didn't know if that would work like ACEs. That has to be validated. So when you look at those with 5 to 7 PCEs, like we just assessed your flourishing, let's say, it was much greater than 3 to 4 or 0 to 1, regardless of which of those factors were in place. And the next study was looking at something similar called the Family Resilience and Connection Index. This is a paper in Health Affairs. Again, showing that, first of all, about half the children in the country were living in homes where families practiced or exhibited 4 main qualities of resilience: feeling hopeful in difficult times, feeling they had strengths to draw on, feeling they could reach out to others in their neighborhood or community for help, and staying connected and talking to each other when things were hard. And about half the kids met the criteria for that, and when they did, they were much more likely to flourish, regardless of what level of risk they had of ACEs. So this is showing you in the blue bar that those with no ACEs at all, 26.8%, flourished if they were living in a home without family resilience and connection, and almost 60% if they did. So again, how can we take what we think is soft and what we've talked about as being soft, like hope and resilience and I have strengths to draw on. We have to look for it and take it seriously. If we had a medication that did this, we would all be prescribed it, right? But we do, because we are the medicine. So that's there. And then the last, which Bob will talk about more, so I'm not going to go over it, is we did a study which Bob and his colleagues were able to get some measures really focusing on safe, stable, nurturing relationship components, that sense of belonging and so on, into the Wisconsin Behavior Risk Factor Survey. And we did more analysis than you'd ever want to do, but showing that a similar cumulative positive effect occurred for reducing adult depression and poor mental health. This is back to you again, and you and me as adults, and also more social support. So at every level of ACEs, there was a higher level of, or a lower level of adult mental health problems and a higher level of social support. The one that is the biggest impact was families stood by them during difficult times. And then again, you see this 72% less likely to experience depression and poor mental health in the presence of 6 to 7 positive experiences, which happened for a lot of people who also had high levels of ACEs. And so you guys have started looking at this. I don't know if anyone's in the room, but I've been working a little bit with you on your own assessment of this. We're still awaiting research, however, linking adult-reported positive experiences to positive health outcomes. So hopefully I've convinced you by now that the absence of a mental health problem is not the presence of flourishing. And that if we keep our eye on that, which like we are in the ENACT framework, we will be better able to navigate to what's actually creating what we want, which isn't just the absence of something bad, given what you've seen about how we're doing in our society and the opportunities we have. So this is just a little graphic, and Bob's going to share more. So at the bottom line, when children experience positive childhood experience, evidence shows that it supports their early and lifelong health. The PCEs are supported by nurturing relationships, safe environments, caregiver well-being, family resilience, and connection, and that can lead to flourishing. So I don't bundle everything positive into one big group. Positive experiences, protective factors that can improve them, and then how that connects to flourishing. So it's basically taking positive, 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 but they're different things, and they have different, they need to be considered differently because you're in different positions in the state and in the programs you work in to be able to foster some of these. But again, be bold, because fostering anything is going to foster health. So I don't have a lot of time left. Actually, I don't know when I got started, but I think I'm going to start to wrap up. So mostly I'm just going to let you know, back to the ENACT framework, that it does come with a pretty clear approach to services and care that we created with the different agencies so that it made sense to all of them, whether it was home visiting, child welfare, or pediatric practice, to really commit to those goals and work together. And the 4 simple rules was everyone a leader. Everyone sees the leadership role they have, that every moment that you're interacting with each other or with a child matters, that you matter. And everyone's a leader at every level, no matter what your title is or anything at all. That's one thing, that we recognize each other as the leaders that we are. And through any door. So wherever a family is, people take responsibility for recognizing the probability that there might be something going on, being able to gain that trust, find out what priorities are, using something that's like a standardized way of thinking about that, which we have tools for that. In every encounter, making sure you don't say, oh, it doesn't matter if I'm not really engaging with this family, somebody else will. It actually doesn't work that way. If I'm in a system as a family or as a youth, and I get treated differently by different parts of the system, basically it doesn't end up creating that sense of safety, even if you happen to be the safe one. So we have to really commit together to create a community and a culture of safety and nurturance, and coordinate. And then the last one is no broken links. So no one leaves my presence without knowing what they're going to do next, and I take responsibility, and I'm empowered, hopefully through policy and systems change, to be able to make sure there is at least a next step and that there's a warm handoff for that. And finally, outcomes and equity-based measurement, which was a big piece of all this. So there's a whole report on measurement and how we can use measures we have, evolve measures to really measure positive health equity, and especially the equity component, which we have data on, but we don't use it, we don't report on it even when we have it. So it's not really useful to you and your community because it's not transparent. So we need transparent data that you can get your hands on to help give the feedback loops. So one of the tools that we looked at was the Well Visit Planner, which is something we created that gives an interoperable, standardized approach to engage families and share data across the systems. Those types of tools were essential. So if I'm an early care and education worker, I can actually engage a family in a self-reflection and identification of priorities and screening and share that data with the pediatrician without having to get 5 other people to work in the center. So these IT digital solutions that are based on family engagement are really key. They're available. We have something that we've created that's non-proprietary to be able to help with that ended up being pretty interesting to people, the Well Visit Planner. And then this is a toolkit, so when you're on the other side of this, you can access what Mississippi put together as a toolkit to support some of this, but there's a long way to go and everyone has to personalize. The implementation roadmap is not something that I can read to you completely, but I will say I think Tennessee's in a really strong place. So a cross-sector body has the structure, capacity, and influence to sustainably advance. So this has to be public-private, usually not so sensitive to every changing legislation, so a public-private structure, and also state leadership. There's a lot of state leadership that needs to happen to get agencies to take advantage of the possibilities for and the flexibilities needed to collaborate, and all the way up to policy. So just to give you a teaser for right now is we did look at all the measures. I don't know how many of you know that if you have performance measures that are reported, but a lot of agencies do, including Head Start, WIC, CCDF, the Early Care and Education, and of course, Medicaid, community health centers. So there's about 309 measures that are used to assess performance across all of these different state programs, and 13 of them exist as a shared measurement across more than one. Maternal depression is actually one that's shared by all 5 of these programs. Community health centers, home visiting, health plans, Medicaid, and Title V. But this analysis is available to you if you want to look at it, because one way to help direct behavior right is to, pay for and hold accountable in a way that actually allows you to do the right thing. So there's a lot of work to do there, and there's also a lot of work to do in policy. So we have 21 different policy priorities. Some are how do we organize and pay for things and hold accountable health plans, let's say, or self, like I just said. Non-financial ways to influence the system, making it easier to do collaborative work, providing resources to share data, and then many others. So back to you to end. Your being is critical to the well-being of the children, youth, and families you serve. Evidence-based strategies don't create transformation, people do. So I think you're on the right track around that. And my 6 wishes that I want to leave you with for We Are the Medicine are going to go quickly, but one is to free our brilliance by aligning our financing with our values and our vision, to take on transparency, to actually talk about what we're trying to do, make it transparent, be curious and interested in what's working and what's not, and remove the fear out of measurement. To become we ninjas, which is just my way of saying we're not that good at it. We have to be better at it. We need to take it intentional. We don't need to be defensive. We are obviously not a society that is excelled in collaboration, and when we do, it's usually at the hands of a couple leaders who eventually leave, and so we all have to rise up and know that we have the capacity, but take it very seriously as the most important skill. To prioritize possibilities, to maintain what I call an escapable habit of hope or unstoppable habit of hope, and to take on trauma, because I think when you have resources and you know what's possible, you can safely take on trauma. And that was why Sweet Pea was able to come along, because she knew there was hope and she believed in hope, so she was willing to go to the hard places, which we often have to go to in a container of a goal that is bigger than we are, that we have hope for. And so that's where it ends with brave being, your well-being. So I am done, except for if you want one more poem. So it's up to you. You want one more poem? Okay. Okay, so this actually is a poem that was inspired by that young boy that I didn't get to tell you too much about, but his conclusion was what was underneath all of the resistance that took him till he was 18, wanting to die almost all of his life to get help, was vulnerability and the mistaken dread. So this is a poem called Transfix that has about 8 stanzas, but I'm just gonna read the last, which is, and his favorite statement in life is, the resistance to the disturbance is the disturbance. Okay, so that's his motto now. So one day, the glacier said quite kindly to the sea, I would never want to be like thee. Like this, I can be my own earth, my own sky. Were I to melt, surely I'd die. Such powers you have, the sea answered back, and she meant every word, for there was nothing he lacked. Rather, he had just one thing to shed, the fear of the melting, the mistaken dread. So I wanted to leave you with that so we can all be brave. Yeah, I mean, I think it would be great. I don't know where we...
Dr.
Yeah.
Bethel wanted...
Oh, I don't think we can hear you. Yeah, if there are any questions, also, obviously, I'll be sharing a lot on the back end with the slides and resources as you want.
We'll take a couple of...
comments or questions?
Can we get a link and to share some of those poems? Because they were, even just the little snippets left me wanting more.
Thank you, yeah. I do. I have a set of poems that, yeah, it's called Thousand Pieces of Soul. Yeah, I will share. I'm gonna have to share it with Melissa, and can you?
We
make
can
it
share-
available?
yeah, I
okay,
can share it
great.
out.
I will share a selection of poems that really came through the work with kids. Yeah.
Any other questions? We have time for maybe Kate's on that side. She can catch you on that side. I mean, I'm sure you have 1,000 questions, but you know that we're on a schedule here. Yeah. Yes. Hi, Richard.
In Mississippi, you mentioned government leaders is an important part of that equation. Who were the leaders in Mississippi that sort of led this or initiated this?
Yeah, so this was through the Mississippi Thrive Initiative, which was $17.5 million congressionally funded through HRSA. And from the beginning, it was required to include agency leaders. So those are agency leaders, right? That's different than legislators. But over the process, legislators got pretty involved. When we had the charter signing, because we actually signed a whole charter for a public-private collaborative called the Early Childhood Development Coalition. It included sectors of the government, and both senators were in the room when that happened. So at the engagement of legislators, really educating them even and getting them excited about the possibilities and all the assets you're sitting on right now that can be that one big doable thing that then can lead to a bigger transformation. So it was really senators and testimony and then the agency leads. And I would say the hardest was Medicaid, getting Medicaid in the door, because they really focus a lot on adults. And even though they're required, and in 2024 they have to report on all the core measurement sets, this is a good time for them to do it. They do care. It's not, but I don't think they see the possibility of what they're sitting on for population health, which is why there is a big focus on health care integration with the other state programs. And can talk to you about that, not just me, but lots of other people who are involved. But Susan Buttress was the PI at UMMC, but it was very much a statewide effort. And it took a long time. The relationships were the hardest. Trust with community and family groups, that was a big job, you know, when in a state where they hadn't really done a lot of family engagement and community collaboration. Okay, lots more to share. I'm going to get off so Bob can come up and give you a deeper dive on positive childhood experiences. You are in for a treat.
Thank you, Dr. Bethel. We appreciate you being here. Hey, April, we're going to take like 5 minutes. I think we have a break on the schedule. Sometimes I make this stuff up, but hey, we're going to take like 5 minutes, stretch your legs. There's little snacks on each side. No, those are our snacks for the day. So you can grab your snacks for the day and hold on to them, or you can grab one now and one later. But we'll see you back here in literally like 5 minutes. So. Okay. Oh, that's right. Yeah.
Did the commissioner with DCS already leave?
She did.
Oh, man. I worked with DCS, and that was the strongest I've heard since Viola, and I wanted to compliment you.
Oh, nice. All right, friends, you have about 32 seconds, in the words of one of my favorite co-workers on the planet. We're going to get started here very shortly.
Okay. All right. Is this on? That's fine. Good morning, everybody. Welcome back from your break. I'm April Scott with Centerstone, and I just feel so honored to be doing this introduction in between two of my research heroes, and I'm so excited that they were able to come to Tennessee. I wanted to introduce to you Robert Sege, MD and PhD, who has come to share with us today, and I was happy that Centerstone, my organization, was able to sponsor him to be here today. He's a professor of pediatrics and medicine at Tufts University School of Medicine, where he directs the Center for Community Engaged Medicine and is a core faculty member of the Tufts Clinical and Translational Science Institute. Dr. Sege is also a senior fellow at the Center for the Study of Social Policy in Washington, is part of the Leadership Action Team for Massachusetts Essentials for Childhood team, has served on the boards of the Massachusetts Children's Trust and Prevent Child Abuse America, and on national committees for the American Academy of Pediatrics. He has received several national awards for his work, including the prestigious 2019 Ray E. Helfler Award from the Alliance of Children's Trust and the American Academy of Pediatrics. Using an evidence-based approach, parent-centered interventions, beginning with recognizing the strengths and stamina that families bring to raising their children, and then developing practical approaches that improve the systems that support them. He has led teams that developed a new model for primary care for infants in low-income communities and a new framework for working with children and families, HOPE, which so many of you have heard us sharing about across the state. And his extensive speaking and publication list includes contributions to the prevention and treatment of child maltreatment and youth violence and promotion of child well-being. He is a graduate of Yale College and received his PhD in biology from MIT, with his MD from Harvard Medical School. And he lives in the Boston area, where he and his wife Karen have raised 3 young children. I'm sorry, they're now adult children, but they were young at one time. So welcome, Dr. Sege. We're so happy to have you here.
So first of all, thank you for the kind introduction, and I have to say it's a little humbling to come right after Christy Bethel, but I'll try my best. She and I have known each other for many years, so you will hear echoes in the talks. So with that, what I want you to do, because this is personal as well as data-driven, so what I'd like each of you to do, and we're not going to ask you who this person is, think of someone who you know who had a difficult childhood and is now a thriving adult. And this person could be the person you see in the mirror when you wake up in the morning. It could be a friend or relative, or it could be a public figure. But I want you to think of one person, because we're going to go back and remind you to think about them and to put all the data and stuff like that into the context of a real person who you really know. So hold on to that person, and what we're going to discuss today is spreading hope. And I say spreading hope because this has really taken off. We really started the HOPE, Healthy Outcomes from Positive Experiences framework in earnest about 3 years ago. And we now have reached people in at least 32 states. Thousands of people have been trained. We have teenagers in Finland who told me I got it wrong, Actually, what they said, it's very cute. They said, we're talking about the building blocks of hope, and they said they're not building blocks. Blocks hold you down. Balloons of hope, and they sent me a picture with the balloons with these factors in them. Unfortunately, it's in Finnish, so I have to work with them to see if they're okay with translating it. So we'll talk about that today, and I just want to mention I had the pleasure of being here, but the work I'm talking about is so many people's work. You've already figured out that Dr. Bethel and I have worked together, but on our team, we have Dina Burstein, Amanda Wynn, Allison Stevens, Courtney Weber, Lauren McCullough, Laura Gallant, Isabella Pegnozzi, Quinn Tucker, and Daniel Choi, each of who do part of the work we're doing and contribute to everything that I'll be talking about today. And what I'd like to do, and I may need some help in the back, I want to start this video. Is there someone? Yeah. So let's watch this together.
Like a tree, we carry our past with us. The Healthy Outcomes from Positive Experiences framework is based on research that shows that positive childhood experiences help create healthy, thriving adults, even when there's been childhood trauma. In the past few decades, there has been a lot of research about the long-term health effects of childhood trauma. But HOPE provides a path to resilience and adult health through positive childhood experiences. The HOPE team has categorized these experiences into the 4 building blocks of hope. These building blocks include relationships within the family and with other children and adults that feel safe and supportive. Safe, stable, equitable environments to live, learn, and play. Social and civic engagement to develop a sense of mattering and belonging. And opportunities for emotional growth. HOPE works to shift the focus for anyone who works with children personally or professionally from one that is negative or deficit-based by only identifying risks and problems to one that identifies, celebrates, and promotes access to these critically important positive childhood experiences. HOPE promotes a culture of thriving and resilience.
So that was the voice of Lauren McCullough, and this is what we're talking about today, the HOPE framework, where it comes from and where it's going to. But first of all, hope exists, and I know Christy talked about this, but let's just crystallize this. Positive experiences help children grow into healthier, resilient adults. And what HOPE aims to do is to help us as providers in one way or another better understand and support these key experiences. And HOPE builds on a legacy of positive research and action around positive experiences. Many of you know about Jeff Lincolnbach and the science of the positive from the Montana Institute. Some of you may know about strengthening families, which is an approach which is widely used in child welfare agencies around the country and comes from the Center for the Study of Social Policy. Essentials for Childhood from the CDC looks at those cultural and political conditions that can create stronger families and reduce child abuse and neglect. We just introduced Dr. Bethel. We've done a little bit of work with the National Indian Child Welfare Association and have learned about the positive Indian parenting. Those of you who work with adolescents may be familiar with the Search Institute's 40 community assets. Those of you who are familiar with pediatricians may know that much of this is included in Bright Futures. And for those of you who are part of a spiritual home, you're going to recognize some of what we're talking about because faith traditions have been bringing people and communities together for eons. So let's dive in a little bit and see that. And I provide that because what HOPE does is we're trying to shift the narrative so that when an individual or a family encounters a service organization, whatever, we shift the narrative. We define people by their strengths as well as their challenges, and in doing so, create a presumption of strength. And compare that, and we'll go into more detail with current practice, where we use screening tools. And honestly, a lot of these screening tools incorporate bias into the way they are. and create a presumption of deficit because you walk in and you may or may not disclose some of these things. So that's all we're trying to do, just transform everything. And, and knowing that I come after Christy Bethel, still just quick show of hands, how much do you already know about positive childhood experiences? Anybody? Nothing. Okay? Anybody a little or more than a little would probably have a lot to learn. Okay? Excellent. Right place. People feel well versed in PCEs or they're an expert. Okay, perfect. And wherever Christy is through those lights, I hope she raised her hands on the I'm an expert. So I want to go into a little more detail about the study that we did in Wisconsin that was touched on. This was a 2015 population study in Wisconsin, part of the CDC's behavioral risk factor surveillance. We added questions about positive childhood experiences to the existing questions about ACEs, and then correlated those with mental health outcomes. So here are the 4 questions. Thinking back to when you were a child under the age of 18, how often did you feel able to talk to your family about feelings, feel your family stood by you during difficult times, enjoy participating in community traditions, feel a sense of belonging in high school, feel supported by friends, have at least 2 non-parent adults who took a genuine interest in you, and feel safe and protected by an adult at home. So these are items that were adapted largely by Jennifer Jones and her team in Wisconsin from the Child and Youth Resilience Measure. And I want to mention that because the CYRM was developed for the World Health Organization and has been used in more than a dozen countries. So these questions are not culture specific. They're things that people around the world can answer. And so here are the results, and you saw them a little bit before. Individuals who had all comers, if they had 0, 1, or 2 of those 7 positive childhood experiences, about half reported good mental health. And I should just say that for this slide and for this presentation, good mental health is simply those not reporting depression or poor mental health. It's not as high a bar as flourishing, for example. If they had 6 or 7 positive childhood experiences, 87%. 87%, 6 out of 7. 7 out of 8, sorry about that, reported good mental health. And what you like to see in a scale is middle number, middle results. So this was published in 2019. And now I want to show you this work continues. So in, sorry. I wanted to skip a slide, but I won't. Okay. Those people with 4 or more ACEs in Wisconsin. And those are 4 or more of the 3 kinds of abuse: physical, sexual, or emotional, 2 kinds of neglect, physical or emotional, and 5 kinds of family challenges, ranging from a parent who passed away, or child lost the parent, family member incarcerated, mental health, substance use disorder, intimate partner violence. Not little challenges, big challenges. So if you had 4 or more of those, and you had 0 or 2 positive childhood experiences in this Wisconsin survey, a majority of people had poor mental health, depression or poor mental health. If they had 6 or 7 positive childhood experiences, only 21% had depression or poor mental health. So what this shows is that positive childhood experiences can either make a person resilient in the face of ACEs or help them heal from ACEs. But regardless, it is not your fate. If a person has a high ACEs score, they're not doomed to all these bad things that can happen statistically from a high ACEs score. But having positive experiences can help mitigate the effects and explains some of the reason why I'm sure many people in this room have ACEs scores that are greater than 0, but still flourishing. The person you're thinking about may have some of these positive experiences that counteracted their difficult childhood. So this was published in 2019 based on 2015 data. Since then in Montana, they've done a similar survey in their state, and they're very interested in substance abuse, substance use disorder. And what they found was Montanans who had high PCE scores were less likely to smoke cigarettes, less likely to drink alcohol, less likely to ever have used any substance, and have lower lifetime odds of illicit drug use. So we are facing a complete catastrophe in this country with drug use and overdose deaths. But positive childhood experiences can make young people resistant to these things. And in Tennessee, and again, this is a little bit of what Christy touched on. Who was involved in doing the work in Tennessee? Anybody? Great, thank you. A really comprehensive report on the Tennessee Department of Health website. But in brief, higher PCE scores, lower rates of depression, lower rates of heart disease, including cardiovascular disease. And the #1 killer of Americans is heart disease. Positive childhood experiences prevent that or are associated with lower rates of it, right? Improved physical health in general, not just heart disease, and more likely to be employed. So employment is a marker of well-being. So this is data from Tennessee. And what they did in Australia, completely different. They had 4,000 or 5,000 kids who were born in 2004, 2005, and they followed them since then every 2 years, measuring all kinds of things about them, including their positive childhood experiences. And what they found is, first of all, the HOPE framework is valid in a prospective study. So instead of a person to recall their own childhood, you take babies and follow them as they grow up. Still valid, really works. And what they found when these children were young adolescents, they had improved mental health and improved academic skills based on accretion of positive childhood experiences at any time in their childhood up till adolescence. And there are a lot more. There are a lot more studies that are coming out. This is becoming something that people are talking about, which is, wonderful. So what we think about is that positive childhood experiences develop children who are resilient to either ACEs or other stuff that comes their way and have better health outcomes. And we draw this way because people have made diagrams about ACEs lead to bad outcomes. But we think, if you think about it, that these positive childhood experiences are what children need, and ACEs get in the way. So how much do you all know about ACEs? So who has a D or E? Feel like you know a lot about ACEs? Okay. And a little or more than a little? Have a lot to learn? Great. Anyone never heard of an ACE other than poker players? Okay. Yeah, when I play poker, I rarely get aces. It's a problem. Sorry, I couldn't help it. So what I want to point out is that we talked about how ACEs have been studied, but ACEs come from a very special population. It was in Southern California in the 1990s, mostly white people. All of them were employed, and they answered questions about their childhood. And it's been replicated around the country many times. But the study, and we'll talk about it in a second, because these are the original 10 ACEs that were studied in Southern California in the late 20th century. And I mentioned them, the 3 kinds of abuse, the 2 kinds of neglect, the 5 kinds of household challenges. But that was then, and this is now. And I think that we're coming to an awareness, and we're doing work now with the APHA and the CDC to look into what are the other experiences that are also adverse that can cause problems for children as they grow up. Things like bullying, community violence, natural disasters, people who are refugees or have had their lives disrupted that way, or witnessing acts of bias and discrimination. So in any event, what we know is that adverse childhood experiences are associated with lasting impacts for life, and we've kind of gone through this. It can lead to poor mental health, poor physical health, poor reproductive outcomes, reproductive health, substance use disorder, heart disease, cancer, other chronic diseases, substance use disorder, and sort of a lack of educational attainment. The other thing that's changed since the 20th century is now, there you go, now I can move a little bit, I feel less captive. So now we know that children and families grow in the context of community, right? So Wendy Ellis and her colleagues at George Washington pointed this out and developed something they call the adverse community environments. So ACEs, which are individual measures, grow where there's poverty, discrimination, community disruption, lack of opportunity, poor housing quality and affordability, violence. These conditions cause stress to families where children grow up, giving rise to the ACEs. So something to think about, that what you're doing in Tennessee with Resilient Tennessee is really working at literally the roots in Dr. Ellis's formulation. And we work also with people in Australia, and this is from Rebecca Grace at the Western Sydney University. And what you can see is she's added in green the protective factors. So there are protective factors, individuals on the tree and the leaves, and down in the roots, we know that opportunities for employment, access to health, access to education, all of these things can make a family more resilient. So the two things that have been added since the ACEs study are a better understanding of the environmental effects, the community environment, and a better understanding of the role of positive things. But the take-home lesson, and you've now pretty much plumbed the depths of my neuroscience knowledge, is that our brains are not fixed things. Our brains change. And all of these experiences change us. There are vulnerable periods or important periods, sensitive periods in child development, 0 to 3 and adolescence, where the brain is, we are specifically affected by these experiences. So I want you to recall the person you were thinking of at the very beginning. Think about that person and maybe make sense of the observation that they're flourishing as an adult, but had a lot of adversity as a child. And maybe some of these PCEs can help explain that. So that's all well and good, but it's pretty difficult to remember all 7 things. And we, together with Charlene Harper-Brown from the Center for the Study of Social Policy, is we look at the literature and we try to figure out what are the kinds of experiences that children need to develop optimally, to be resilient to ACEs, and for good development in general. And what we found is there are 4 kinds of positive experiences. There are relationships, safe and nurturing relationships, stable relationships, safe and equitable places, environments for children to live, learn, and grow, and environments is both physical and psychological. Social and civic engagement to develop a sense of belonging, connectedness, and a sense that you matter. If you're on the football team, you don't show up, your teammates notice it. If you're on the choir and you don't sing, other choir members notice it. This is how we know we matter, because other people depend on us. And finally, opportunities for emotional growth. And we'll talk about it, but emotional growth happens through child-centered play, through exposure to nature, through spiritual experiences. And these building blocks, some of you might be thinking, wow, that's really vague. What do you mean? And they are vague, and that's on purpose, because we live, fortunately, in a very diverse world, in a very diverse country, and people may have different ideas of what these 4 building blocks mean. And in our talks around the country and around the world, everybody knows what they mean for themselves. So this slide is just to remind me that families come in all different shapes and sizes, but the building blocks are important, and the interpretation and understanding of them depends on a person's values, experiences, resources, culture, all of those things. So relationships. So relationships where caregivers and children feel seen, safe, supported, and this can happen from parents, of course, but also coaches, the faith community, neighbors, playgroups, and a lot of the work that you all are doing with different organizations that provide family support. So now I'm going to show you, and I'll do this for all of these, what is going on here? Like, what does the hope transformation mean? Because these building blocks are not new. We didn't create them, but we're putting them together in a way that you can actually practice. So standard practice about relationships looks for dangers to relationships, right? If there's intimate partner violence, if there's mental health problems in the family, those can endanger relationships between parents and kids. But what we can also do is promote early relational health. We can ask parents really simple questions like, who helps you? And as kids grow older, mentoring, both formal and informal, has been demonstrated to help kids. We can ask about that. And we can help create conditions that make these relationships more likely to occur. Environment. Safe, equitable, stable environments for living, playing, learning at home and school. This can involve community playground cleanup, or community playgrounds just to begin with, right? Access to bus fare or transportation to go to the parks. Training for the school teachers to be able to respond appropriately to bullying. And I hate to say this in Tennessee, but gun lockers, so that when families have a gun at home, it's locked up. It's not available to the children. It's not available to the teenagers. Thank you. So the environment, standard practice, again, looking at dangers. And these are important. I'm not minimizing them. Housing stability and quality, intimate partner violence, which is the beginning of all kinds of things that make a psychologically unsafe environment. But hope-informed practice really looks at schools that can create a positive school environment, at recreational opportunities for kids, at family check-ins. You know, some families have dinner together. Some families, people are working too hard, or there's too much going on, and dinner doesn't work. But are there regularly family check-ins so that parents and kids interact with each other in between crises? And that's the idea. And finally, next, engagement, social and civic engagement, to develop a sense of belonging and connectedness. So play groups, parent-child groups, family volunteering opportunities in the community, family roles, like do the kids wash the dishes? Do they take out the trash? Do they feed the dog? All of those things are engagement because the child matters, right? If they don't feed the dog is hungry. So it's a responsibility, and they know they can handle it. And it took me until I started doing this work to really understand that my second grade teacher actually didn't need to have a second grader clean the blackboards at the end of every day. That what she was doing, that and other things, were creating a sense of community so that the second graders were part of the community and we mattered. Engagement, honestly, is really not exactly part of standard practice. Really good practitioners ask about this a lot. They kind of talk with kids and parents about it. But we should be also thinking about, does a child feel like they belong at school? That's different than what their grades are. Is their family structure such they have an opportunity to matter at home? What do they do after school, in the summer, on vacations? So how does that after school time promote engagement? Oops, and oh no. Oh, my computer wants me to go faster. Okay. Emotional growth happens through interacting with peers and for self-regulation. If you watch 4, 5, 6-year-olds play, they bicker, they fight over the rules. That is social emotional growth happening right in front of your eyes because they're realizing the other person has a point of view. They're realizing that they need to regulate their own emotions. Even if someone cheats, they still want to play, or whatever it is, right? You're seeing that. So it's that happens through peer growth. And we can model it by naming feelings, by providing unstructured, safe playtime, by practicing breathing techniques to help children handle their emotional dysregulation that comes when you realize that in a world with other people, you don't always get what you want. So standard practice for emotional growth is we do screening. That's a very popular screening, the ASQSE, used in pediatrics and in childcare. There's social emotional learning, anger management classes. But what we need to do is make sure that kids have access to safe playgrounds, that parents and the communities understand child-centered play. The purpose of playing soccer is not to become a soccer star. It's to be part of a team, to develop your skills, to develop your emotional regulation if you should lose or screw up, or win and not, pound it into the other person. We need green spaces that are well maintained and safe. And we need cultural and spiritual practice that are available to children so they feel connected to communities in space and time. So what goes into the buckets? really depends on who you are, what you believe in, where you are. Those buckets are fundamental. And it may seem sort of obvious, but this is a multi-generational approach. That we talk about adults who create conditions for children to have those positive experiences, and you can't do that if the adults aren't healthy. So we've been talking a lot about the children's brains, but I want to do something that we do in our training to talk about how our own brains as adults respond to cognitive reframing. Big word, we're going to do an exercise here. I want you just to shout out, what do you see in this picture? Risk factors, protective factors, anything you want to say. Okay? They got it? Yeah? Okay. 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 A lot of positive things. You guys are good. Yeah, things are all over the floor. Yeah. So, I don't know, it's just the front row where I can hear or what, but usually the first thing people yell out is there's bugs, there's cigarettes, the place is in disrepair, there's cleaning things that are in the reach of the children, right? And most of us are trained to first see those risk factors. And then what you all are doing is the next stage, seeing what's strong in that family. And when we talk with providers, what we're talking about is how our training for most of us really is about identifying risks and ameliorating them. And that becomes almost automatic, right? So when I got a new job, first I got my new job and I had to figure out how to get to work, and I left a little bit early, and I made sure I knew the directions and where to park, all those things, or other people maybe take the subway, know how to get there. And now I've been there for a while, and I'm daydreaming, I'm talking to the wife on the phone, I'm planning my day. I have no idea how I got to work, because it's become from what's called type 2 thinking, which is novel and problem solving, to type 1 thinking, which is automatic and unconscious. So when we talk about the hope transformation, we're trying to make what you guys did, thank you. I'm seeing the positives and the strengths as automatically as our training is to see the risks. But there's another part of this that's really important to understand, and that is that some of the type 1 instant thinking is how we assess another person, and that's where implicit bias enters. Because the first thing we notice about a person is their physical appearance. You know, are they male or female, or maybe in between? Are they black or white? All of those things. And those things happen quickly. And many of us through our lives have incorporated this as implicit bias. But type 2 thinking, we can see people, tall, short, funny, not funny, old, young, artist, poet, something like that. So we have a sense of that individual person. Training ourselves to do that, to see an individual person, reduces implicit bias dramatically. And that's what we do with individual hope training. And then with hope training for organizations, we talk about putting yourself in someone's shoes. So there you are, you're a mother of 2, you got a baby, you have a 2-year-old, it's raining outside, you arrive late for your doctor's office. What's the first thing you hear? You're late, right? What did you already know when you walked in the door, right? And so I used to run a primary care clinic at a Sapien hospital, and we did all these things because late patients are a nuisance from the point of view of how the clinic runs smoothly. And one mom told me, yeah, the front desk told me I'm late. The nursing assistant who weighed my child told me I'm late. And now here you walk in the door telling me I'm late. I know I'm late, you know? And then she explained, she had left early, she had tried to get there. So how do we make processes that don't embed implicit bias? Because a wealthier family with a well-functioning car that can pay for parking or whatever is less likely to be late than someone who has more to do to get there. So thinking about putting ourselves in other shoes, another evidence-based way of reducing bias. So we talk about that in all our trainings because it's important. And now, who here is familiar with something called trauma-informed care? Oh, excellent. Okay. Probably pretty much everybody, right? So we talked with Alicia Lieberman and her group at the University of California in San Francisco, and they developed an approach called triads. And I have to remember to look up what the TR and I stand for. But ADS is adversity, distress, and strengths. And this is how we put hope in the context of having people who care for other people, who know about trauma-informed care, and we're not asking them to unknow that. We're asking them to think about it kind of in a timing sequence, right? You come for services because you're in distress. Trauma-informed care, the central question is what happened to you, right? But it's also the strengths, and strengths go both ways. They go forward and back, like what do you have that makes you resilient, and what do you need to help you heal? So that's why when Dr. Lieberman and her group draw strengths is not linear like I just did, but it's part of a triangle, right? Because strengths can make you resilient in the face of adversity, and they can help you heal from distress. So I just want to make this a little more concrete and go through one case. And this is what we do in our trainings. Tara is a 15-year-old in adolescent intensive inpatient program for her drinking. She's in foster care and was referred to the program after repeatedly showing up to school drunk after lunch. Tara's been in foster care since she was a toddler due to parental substance abuse. She was recently moved to a new placement at the beginning of the school year, and when that happened, she lost contact with her peers and was pulled out of her gymnastics program when she moved homes. This sound like I don't know if anyone works with foster children, sound like a reasonable story? So let's look at it using the triads approach. So what adversity might Tara have experienced? Yeah, separation, absolutely. Twice, right? From her bio family and from her foster family. And maybe from her friends. What's causing distress? Why is she in this program that you're running? Not a trick question. She's alcohol, she's drinking, right? It's not normal, just to put it out there, it's not normal for teenagers to drink before lunch, okay? And then how can the HOPE framework help the child build strengths? And how do you start by acknowledging and identifying and celebrating the strengths she comes with? So when we go through this with the group, what we see, is that I pressed the wrong button. What we see is, look at the strength she comes in. She's showing up to school, right? She's 15. Some 15-year-olds don't make it that far. In her previous arrangement, she had peers. She had friends who she misses now, right? And she was actively engaged in her community. She was a gymnast. So those are the strengths that she walked into this case study with, right? And what's causing her distress? She was drunk after lunch, and then looking more deeply, she lost contact with her friends, and she lost contact with the gymnastics program. And adversity, and these are the kind of things that are really ACEs, right? Parental substance abuse, disruption when she moved to a new foster home. So as you think about that, you can begin to understand Tara by using both a trauma-informed approach and a way to understand her strengths and promote strengths. So one way to do this might be, I don't know how far she lives away from her old school, but is there a gymnastics program? Can she go back to a gymnastics program? How can she maintain some contact with her peers? Her bio parents had substance use disorder. They're not dead, or hopefully not. Are there ways that she can be helped to maintain some contact with a biological family? On and on and on. So you can build those strengths. It doesn't mean she doesn't need alcohol rehab. It does mean that that's not all you have to think about, and that she comes in with all these things. So it's really fun to use the triads approach with practitioners to understand that. But this is all, so far, I've been talking about the individual, provider, therapeutic environment, and that sort of thing. But what we're actually doing is we're making a bridge to hopeful practice. And what this means is that individuals work in organizations and care providing organizations. And I can't see very well with the lights, but I think there are a couple people here from Centerstone. Kim, there you go, Centerstone table back there. So the first step in transforming an organization is a leadership commitment. The second step is to examine the key policies. And we have an innovation lab. We call it the Hope Innovation Network. And last year, 12 organizations went through their intake forms to see, if you put yourself in the shoes of the person who's showing up, what happens first. And then staff capacity building, learning about hope, learning about these new intake things. And then it's not done. Then you use continuous quality improvement to get it better and better. And CQI is where parents and community can be systematically engaged. So the metrics that you use for quality improvement can come from the parents, they can come from the community, and help you get better and better. And people can be engaged on those CQI teams. This is not revolutionary. This is done. It's possible. It's not complicated, but it requires thought. And so I just want to close by saying that to make this happen, you need agents of change. So the first agent of change is you all, having a change in mindset. So when every time you think about ACEs, you also think about positive childhood experiences. So as Phyllis Nylon from the CEC says, you can't talk about ACEs without talking about PCEs. Change in mindset. Hope facilitators. So we have people who can be trained to be hope facilitators, who can do an introduction to hope and train staff in the language and resources. Hope champions, facilitators who are experienced to get more training, who go on to drive organizational change. And hope ambassadors, who really mostly come from program participants who can talk with other people in the community and the providers in the system about what hope actually means in practice. So this is how we're approaching the dissemination of innovation. Because we started with neuroscience, and that's great, you can read it in the neuroscience journal, but who cares, right? And now we're trying to change practice, and change practice happens through these things. And this is the approach that we're taking to develop capacity everywhere for everyone, all the time, to think about the positive. Because what we want is strength-based, child-centered, family-led innovating around promoting access to the 4 building blocks. And Resilient Tennessee is really doing this. And what I want to do I have time for questions? Sure. Okay, I have time for questions, and I'm going to leave you with a couple images. Oh, there are people in the back with their hands up pointing. There's a gentleman in the front. There's a gentleman over on the side. This is perfect.
Okay, I saw hands and now I don't see any hands. Oh, Kate, okay.
If I wanted to.
Did you want to say something? No. Oh, I thought you were going to ask.
We'll go up here and we'll come back, Kate.
I was curious to know if any of the, excuse me, allergies. If any of the innovations that we were exposed to today came out of some of the new PACE, the National Urban Partners Academic Centers for Excellence when it comes to youth violence. Because I heard some of this, some of the terms and things came out of those initiatives, I think, back in the early to mid 2000s.
Yep, absolutely. And one of the people I learned from is the late great Carl Bell, who did a lot of work on that, and I miss him. But thank you for mentioning that.
How long is the process for individuals that would like to be trained to be facilitators?
Okay, it's easy. It's I think it's 3 sessions. The first one is 2 or 3 hours. The second one is 1 hour, and then there's an individual practice opportunity, which is an hour or 2, depending on what's going on. So I've had a chance to watch people do their third session and do those. So you actually learn to do a hope training.
I think we have one right here. Dr. Did you have a question?
No, I was pointing.
I lied. Anybody else? Oh, right here.
I made a note here, you were talking about in your growth section about playgrounds and connectivity through that area. I wanted to find out about how you're moving forward with how this is going to be skewed in relation to the kids with their electronics.
Kids with?
The kids with their electronics. Nowadays, I kind of wrote down here that how they matter is based on their number of likes.
Yeah. And I think that the first thing we do is create a resource that they can use that's more fun, or at least as much fun, and then then there are other things. I think that what's happened is, particularly during the pandemic, people were not going out and playing with each other because it was dangerous. So we have to recreate that. It is not a simple answer to that, but part of it is clearly they just did a playground renovation near where I live, and it was out of use for a couple of years because they were digging up the dirt and pushing it around. And now it's always kids, it's always filled. So I think it's making attractive spaces and then encouraging kids to go to them. Okay, I want to show
Kate
you.
has one more.
One
We'll
more?
do one more up at the front.
I was wondering, have you worked? I'm over to your left.
Okay. Oh, thank you. Yeah. 'Cause the voice is coming from everywhere.
Are you aware of any home visiting models that are trying to incorporate your HOPE framework
Sure.
or PCEs
Yep.
intentionally?
So we're working with parents as teachers, and I was on the board of Prevent Child Abuse America, and a lot of this goes with Healthy Families America as well. So it is being embedded, and HFA's model really starts with understanding the family's goals. And I think a lot of the more successful home visiting models do this, and we're working with parents as teachers is labeling it with the HOPE, with the 4 building blocks, and HFA is doing it, but they're not restructuring they have a little model of best practices, which is, have you seen the HFA model? It's really big. So that's a big thing to overdo that. Yeah. Okay. So I want to leave you with an image. Okay? People are like trees. We carry our past with us. And unlike unlike man-made things, like I take my car and I scratch it or dent it, it's going to stay scratched or dented. But we're capable of healing and growing. Some of us have the opportunity to grow up in a forest, a multi-generational forest. Other trees like us, not so much like us. Sometimes we experience trauma, a lightning strike. It can be life-threatening for a tree. But if you look closely at any tree, you'll see healed trauma. You'll see places where something happened. Windstorm, thunderstorm, deer, somebody with an axe. But you look at the tree and you see that they're growing and thriving despite having experienced that. And some trees don't grow up in a native forest, but they're transplanted and they find conditions where they can thrive. Some trees get to grow up to be old, and old trees, they will show the signs of the trauma, but they've obviously thrived, and they become the object of admiration. But looking underneath, the trees all have roots. And one of the latest science advantage in treeology, whatever it's called, right, is that trees communicate with their root systems, and they communicate between fungi. They pass nutrients back and forth. Who knows what they pass, but they pass little notes back and forth to each other. And when the wind blows, that network of roots helps the trees not fall over. So it's their natural thing. And when you, with this knowledge and thinking about ACEs and positive childhood experiences and the building blocks of hope, look around and see the diversity of people, their experiences, some positive, some adverse, their genetics. Some of us are willow trees, some of us maybe bushes, whatever. Think about all that. It's a beautiful world, but it's complex. And understanding only the thunderstorms and the droughts doesn't tell you about a tree, doesn't tell you about people, and it doesn't tell you about the forest. So with that, I want to just remember that what we're doing is seeing people's strength before their challenges, building up practice, and creating relationships that are fundamentally based on respect for human dignity. And that's it. That's all it's about. So thank you so much for your time. If you want, you're happy to have you send an evaluation link, send an evaluation to us. And thank you so much for inviting me to Tennessee. And I hope this is the first of many visits. And really seriously, Godspeed to your work with you in developing Resilient Tennessee. Thank you.
Still, good morning. My name is Craig Hargrove, and I work for the Tennessee Commission on Children and Youth. And it is my pleasure and honor to be able to introduce Lizzie Schlichting. She is a policy consultant with the Herrera Health Medical Policy and Programs team, where she supports the Pathways to Resilience initiative, promoting healing-centered, trauma-responsive policies and programs throughout the nation. Prior to joining the health group, Lizzie worked as a policy fellow with the Center for Health and Gender Equity, focusing on sexual and reproductive health and rights and maternal and newborn child health. Before that and during that time, during the time as a policy fellow, Lizzie served as the programs and operations manager at Bridges to Wealth. That was a nonprofit seeking to reduce gender and racial wealth gaps in Philadelphia, Pennsylvania. In this role, she provided analysis and evaluation around trauma-informed violence prevention and poverty reduction programming for the Philadelphia school system. Lizzie has additional clinical therapeutic experience working with people who use drugs and people experiencing homelessness and low-income children and families. She's well qualified and fabulous at what she does. But I want to mention that in her spare time, she likes to get lost out in the woods and in fantasy books. She does a lot of traveling and brings home recipes with her. She loves caring for her dog, Dexter, and her cat, Simon, and she is busy gardening in Philadelphia with her many, many plants. I give you Lizzie Schlichting.
Hello, everyone. Can you all hear me? Okay. Let's hope that stays. Thank you for that introduction. I think it's safe to say that I have a wide array of experience, right? I've worked with a ton of different people in a ton of different sectors, and I'm really happy to be here with you today talking about Pathways to Resilience, which I think really brings that all together. Great. So like I said, I'll tell you a little bit about Pathways to Resilience, and then I'm going to jump into some national programs, policies, and practices that support trauma-responsive and trauma-informed, healing-focused, and resilient building activities. Can you all? Thank you. Fabulous. Thank you. So Pathways to Resilience is a national initiative raising awareness of the impact of adversity and trauma, and we work to promote cross-sector strategies for preventing and addressing toxic stress with an overall goal and mission to improve lifelong health and well-being. When I say I am a social worker by trade and a policy consultant by force, I wound up in this world after, as I'm sure many of you have, running into a bunch of brick walls in the social work field and in direct care, right? So after experiencing a bunch of burnout and, emotional compassion fatigue, I decided to switch gears and instead focus on building doorways through those brick walls, right? And so that's how I wound up in this world after a decade of direct care. And instead of smashing into brick walls, I'm trying to build doors through them. So just a bit of background, Pathways is celebrating our 1-year anniversary later this month. We got our start in May of 2022 under the leadership of Aurora Health Group. Aurora Health is a mission-driven national health policy and strategic communications firm, and we were heavily involved in the California ACEs Aware initiative. I'm not sure if you all are familiar with that or with the work of Dr. Nadine Burke-Harris. She was the former Surgeon General of California, and she led this work in California, raising awareness of ACEs and implementing easy, barrier-free or reducing barriers to screening tools in primary care and pediatric services. I was actually introduced to the work on ACEs through her TED Talk when I was in graduate school. She's really incredible, and it really did change the course of my life and my professional experience. Aurora Health, like I said, provided support for that groundbreaking initiative, but during this work in California, we realized sort of a national gap in initiatives that are helping bring the really incredible community and organizational level work to scale at the state, having that supportive infrastructure and capacity. So that's where we have decided to sort of step up and step in, helping states scale up activities that are working at the community level to statewide initiatives. We have the joy and privilege of collaborating with partners across sectors and at all levels, like I mentioned, from that community level up through state initiatives and national movements. And like our partners, and like many of you in the room, our goals are grounded in the recognition of trauma and normalization about conversations about trauma. We seek to promote collaboration across sectors, to invest in prevention, and we aim to highlight the importance of positive experiences, as Dr. Sege was just discussing, and protective factors. We know that great healing happens in community, and that should be brought to scale. And we work to prevent and mitigate systemic and intergenerational trauma, working towards a world where we perpetuate instead generational resilience and healing. So just some casual goals, right? A regular Wednesday, if you will. We are guided by an expert advisory committee with whom we walk hand in hand towards these goals, some of whom are in the room with us today. This committee is composed of thought leaders, state leaders, clinicians, researchers, and always folks with lived experience, direct care providers like myself and like you all in this room, all of whom provide strategic input, expertise, and advice, and help us advance evidence-informed and promising practices. They all donate their time to us, and we're really grateful for their support and guidance. We also have the support of a steering committee of governors' first spouses, right? So they use their platforms in their states to elevate trauma-responsive and healing-focused work in their states, and they really champion our initiative. It's chaired by Ms. Tracy Quillen-Carney out of Delaware, and we have representation from Arizona, Louisiana, Maryland, North Carolina, Oregon, and Utah. So we're really trying to reach out to states in all regions of this big, diverse, and beautiful country. One of the offerings that I am most proud of and excited about with Pathways to Resilience is our Learning Network. We host free monthly sessions on an array of topics, a really wide range of topics, where we're joined by state leaders, national experts, community folks, who tell us about exciting and promising initiatives in their states and leave the audience with concrete and actionable strategies to bring back to their own states and communities. We've been joined by some really interesting people. You can find recordings of these past sessions on our website online, and I'm actually really excited for the lineup of speakers and topics that we have for the rest of the spring. So next week, we'll be discussing trauma-informed design and architecture, which is a really up-and-coming, I don't know if it's actually up-and-coming, but I had not heard of the concept of trauma-informed design until quite recently. And so that's looking at the way that we can transform spaces to not only prevent re-traumatization, right, but to foster community building and support healing and relationships. So we're really excited about that. You can also see we have additional sessions coming up this spring, and you can register and find more information on our website. These are always free. They're open to the public. We're working on getting CEU credits for them, so keep up to date on that. Okay, that's enough about Pathways to Resilience. I'm actually really here to tell you all about some different policies, programs, and practices supporting resilience and healing across the nation. Because of our sort of national presence, we have the unique opportunity to have a bird's eye view of what's happening in states, and a lot is happening. So while I can't get into everything today, I picked out a couple key programs, practices, or policies in states relating to some of the sectors that you all are representing here today. It's really, really exciting to see what's happening in different places. And at Pathways, we're always trying to keep our eyes open throughout our work across the country for best and emerging strategies and cross-sector approaches to really help break down silos. The sectors that we primarily focus on are health and behavioral health, justice and youth justice, early childhood and child welfare, housing, and stable and secure housing, education, and then social drivers of health and social services. I'm going to share a few with you from the sectors we focus on, and we'll start off with behavioral health. So I wanted to tell you all about the California Department of Health and Human Services Children and Youth Behavioral Health Initiative. California is obviously a massive state, so this investment, which works to enhance, expand, and redesign their youth behavioral health system, is it's a massive investment, both of time, energy, and financial resources. The initiative prioritizes upstream preventative measures, and they're doing so by increasing access through programs like school behavioral health programs that are funded by Medicaid or federal dollars. They're also looking at other entry points like primary care and other systems that children and youth are involved in, and increasing the capacity for behavioral health support services through those touch points, through those entry points. They're also working to increase community and family engagement by providing culturally and linguistically appropriate materials and specific education around trauma, around ACEs, around protective and positive experiences. So that's a really exciting and massive investment for the state of California. And I think it's a really great example of state leadership putting their money where their mouth is, right? And putting dollars on the table to increase access to the system and the quality of the system. And as a practice, which I'm sure many of you do in your direct care practices and across the state, meaningfully engaging people with lived experience. So in the behavioral health realm, we talk about that a lot. It looks like peer support. It looks like in the substance use and misuse realm, it looks like mentorship and counseling. But we also talk a lot about involving folks with lived experience in policymaking and program design, right? So not just in the direct care, I've gone through something similar to you, so I can help you through it, but in designing the programs and policies that most impact them. This is particularly important in the behavioral health field because leveraging the expertise of people who have utilized these services is a great way to really reduce the risk of creating or perpetuating programs and policies that are traumatizing or can contribute to re-traumatization. Next up, we have early childhood and child welfare. Being here in Tennessee, I had to shout out the Second Look Commission, and particularly the policy levers that established this commission in, I think it was 2010. If you're not familiar, the Second Look Commission reviews legal cases involving second or subsequent incidents of child abuse, and it provides recommendations to the legislature about reporting protocols, investigative protocols, referrals, and other risk factors that impact survivors of child abuse entangled in the protective and legal systems. You guys have a really innovative and impactful commission here, and we're really hoping to see more states pass similar legislation and establish these commissions across the country. Additionally, I touched on this briefly, and child welfare practices when talking about our upcoming Learning Network session, but I did also want to reiterate that trauma-informed design is an emerging field, and it's particularly tangible and salient in child welfare and early childhood education spaces. There are an increasing number of studies and organizations that are looking at critical modifications to the spaces in which they provide their services, and this doesn't have to be like drastic renovations, right? We're not, buildings shouldn't have asbestos in them, right? I went to a high school that had asbestos in the ceiling. We all found out later. That's base level, but we're talking about letting in natural light. We're talking about utilizing natural spaces when we have them available and making thoughtful choices just to create calming and safe environments, which are particularly impactful for children who don't always have the language to tell us that, oh, these lights are really bright, or this chair is really not comfortable. And making these changes allows for better communication with their parents if they're in visitation centers, for example, or a safer and more secure experience in a foster care setting, right? So while we would love to, have the budget to allow everyone to make massive renovations and, everyone gets a comfy beanbag chair, making thoughtful choices about art on the walls that can lead to a conversation, right? Like little things can make a big impact in the child welfare and early childhood space. Moving on to education, I wanted to talk about Handle with Care, which I do believe is being implemented in counties in Tennessee. It's actually being implemented in over 33 states. It's a really simple, I think, and straightforward initiative. It's a partnership between law enforcement and educators. It starts by when a law enforcement officer notices that there's a child present at the scene of an incident, whatever the incident is, they notify the educators. There's no privacy infringement. There's no details about what happens. It's just 3 simple words: handle with care, right? And that lets the teacher, the school administration, whomever, know that this child might have seen something, might have gone through something, and might need extra accommodations and support. And that might look like, providing some extra snacks. It might look like giving them space if they're having emotional reactions in the classroom. And it's a low cost, low barrier way to support educators, give them the information that they need to better support the youth that they work with. I also wanted to talk about a policy out of Kentucky. I think it's Senate Bill 1, which was passed in 2019. And that required training for school resource officers, right? So like law enforcement officers on school campuses, to include education on youth mental health, on trauma-informed practices and protocols, on the impact of ACEs and trauma on development, and de-escalation, trauma-informed de-escalation strategies. This bill also directed all schools in Kentucky to adopt a trauma-informed approach to foster an environment where all students, even those who have experienced trauma, can be safe, successful, and known well by at least one adult at school. That really, really stuck out to me. Like Dr. Sege was saying before, the aspect of like really knowing a student and having that in legislation, I feel like is so incredibly powerful. We know that healing and resilience are born through relationships, and having legislation that names that is like really, really important. So I would love to see more states adopt that. The language that we use is so, so, so important, and naming that is a really powerful tool. Next up, I wanted to talk about social drivers of health, which is a massive, range of issues. They're really best addressed across sectors and in collaboration, but I did want to highlight two initiatives tackling different aspects of social drivers of health. And I use drivers instead of determinants because, like with ACEs, it's not, this is not your fate. Just because you experience some of these contexts, some of these conditions, it does not determine your health outcomes, but it does contribute to them in certain cases and at times. So again, language really matters, right? Washington State passed a bill, House Bill 1905, which was passed in response to the high risk of homelessness for youth being discharged from care, whether that's foster care, inpatient, group living facilities, justice facilities, etc. This act also acknowledges the high rates of traumatic experiences that young people who are experiencing homelessness are exposed to. And so it established a rapid response team which connects young adults transitioning out of those care facilities with much needed sources like resources like behavioral health and medication supports, housing resources, legal aid, peer support like I mentioned, and much more. Also wanted to discuss the Healthier Together initiative, which I'm really proud of. I had no part in it, let me just say, but it's based out of Philadelphia, where I live, the Children's Hospital of Philadelphia, and it addresses a wide array of SDOH concerns. They provide, for example, free home repairs to reduce asthma triggers in houses, right? Like, how big is that for someone who rents or perhaps can't afford to make, simple changes to their living environment? This will drastically improve the quality of their life and their breathing. They connect folks with legal aid related to housing and eviction and tenants' rights. They have a grocery delivery program to address the massive inequities and food deserts in Philadelphia. It is a really severe problem. And they've provided more than 600 youth and families with trauma-informed case management to access all of those resources. I will also add, it helps to reduce barriers by having the Children's Hospital of Philadelphia as a central hub. It's accessible by public transportation. They offer transit passes, SEPTA passes to get there. So having a one-stop shop where they can go to receive their case management, they can meet with their lawyers about legal aid, they can receive their medication, and go home with a bag of groceries is, I think, really critical. Next up, we have the justice field, which again is a pretty broad array of issues. Many jurisdictions across the country have adopted restorative justice programs for youth offenders as a way to address disparities and inequities and disrupt the prison pipeline for young folks. I know Judge Sheila Calloway from Davidson County here piloted the restorative justice program in Tennessee, which helps prevent youth from committing subsequent offenses by reconnecting them with their community and grounding them with folks who care about them. Philadelphia, as another example again, has a diversion program rooted in restorative justice principles. It provides mediation with the victims, as well as providing a mandatory career or life skills development training to offenders, specifically to nonviolent youth offenders. The goals of restorative justice programs are, generally speaking, to reduce recidivism and keep young people in their homes and in their communities, to retain that relationship, that community as a protective factor, rather than incarcerated. And I think that they're deeply aligned with trauma-responsive principles. Actually, the Pathways team, not me, but other folks, are headed up to Illinois later this month for the Trauma-Informed Mental Health and Justice Summit hosted by We Heal Us. It's a free event and has free CEUs for all you social workers in the room or anyone else who needs free CEUs. It's hosted online, and I'll tell you more about that in a minute. And last but not least, we have the ACE-informed bench card, which was born out of the Bolch Judicial Institute at the University of North Carolina and the North Carolina Chief Justice's Task Force on ACE-informed courts. That is a mouthful, but how significant I find it that there's a specific task force on ACE-informed courts housed within the North Carolina justice system. I don't have it with me, but it's a literal physical trifold card that judges can keep on their benches, that other judicial officials and officers can keep with them or at their desks. And it's a little cheat sheet for anyone in the justice sector providing strategies around courtroom procedures, around communications, de-escalation, and how to recognize signs of trauma in different age groups. So it's a really unique and physical resource that folks can take with them for people in a sector who might not be, clinically trained in ACEs, in trauma, and what that looks like and how it shows up for folks that they interact with. I blew through a lot really quickly, and if anyone has any questions, I'm happy to answer more. But you can find all of these programs, policies, practices, and more in our online resource library. It contains state action plans, legislative and executive orders, toolkits and learning modules, research. It's all free. You can search by state, sector, type of resource. We have a lot of good stuff on there. We also recently, I did want to mention, we recently launched a job board which features positions related to trauma, resilience, healing, adverse childhood experiences, positive childhood experiences, etc. So if y'all know open roles to support the great work that you're doing here in Tennessee and you want to share them with us, we will put it out to our network of like-minded folks. Also on our website, we have talking points for governors and state legislatures. If you want to try to get them to buy into an initiative, we have data, we have clear talking points, along with a variety of blogs and videos from experts on related topics of interest. And lastly, I wanted to reiterate the wealth of free information that is available through this incredible network of folks and other organizations dedicated to doing this work. I know that May is Mental Health and Trauma Awareness Month, and there are way more than just these two webinars I have up here. But you can tune into these. They're the next events we'll be at, and I hope that you will join us. It is such a blessing in this day and age, I really feel like, to have connection to so many different people and organizations. I know that tech, especially for kids, is there's a lot of controversy around it, but we are really, really lucky to be able to connect with so many different folks. I'm in Philadelphia, and I have such a unique perspective, I feel like, with all of the incredible work happening across this country and being able to bring it back to my own state, right? Like, that just feels so significant to be able to learn from you all. And I really encourage you all to take advantage of the resources that are online as well. And that's a wrap from me. It was short but sweet, right? So thank you all so much for having me out here. I think I was the last thing standing between us and lunch, so not complete. Oh, all right, let me not promise y'all lunch yet. Sorry about that. Didn't mean to get your hopes up. But thank you all so much for having me out here in your beautiful state. It's been a pleasure to learn from you.
friends. How are you doing? Yeah, lunch is coming. I'm not, because ask the people who work with me, they know I got to have some food about every 2 or 3 hours. When we get ready to go somewhere, they're like, do you have snacks? Like, I got it. But we're going to do one thing before we get to lunch. And part of our goal, as we've talked about it from our coordinating team, which is a multidisciplinary group, including folks like Kristen Davis, I think I saw you out here a little bit earlier, Julie Rotella from Department of Children's Services, Rob Cotterman from Department of Mental Health. I'm forgetting all kinds of folks, but there's plenty of people on there that help us guide this work. One of the main goals in the Resilient Tennessee Collaborative is to become more of a state-supported effort and help you support the work you are doing in your communities across the state. City, county, region, whatever it looks like. And the key that you've heard through all of this is the collaboration, the conversation. That's why you're in affinity groups, what we call affinity groups. You're sitting at tables with persons who identified similarly to you that this is one of my priority areas. We kept it very broad. And so like for my education friends, I know that you go from very early childhood all the way up through postdocs potentially. And so as we move forward in our work, we're going to break down into your more specific affinity groups. But today you're kind of broad. So just know that that's how we intended it today. The fun thing about that is we want you to have intentional conversations at your tables. And so for the next 20-ish minutes, I will come back and talk to you about lunch when it is time to eat, I promise. I will guide you well in food. So, but for the next 20 minutes, if you would pick up your piece of paper that Kate and Teresa and probably others lovingly put on your table during our break, you will find that at the top it says table conversations, group notes. This version is bordered in green. So that's our morning conversations. These are questions just to guide you as we start thinking, how do we move forward resiliency, and specifically, how do we move forward with community engagement and support of collective efforts across our state? So we need more information. You can take this and throw it out to the side if you get into conversation that's more meaningful. But what I am going to ask of you is two things. Number one, you have to come up with a team name. It says affinity group name. That's your goal. Just a name. I don't care if you call yourself table number X, but just come up with a name so that when we have a next conversation this afternoon, you also will be team number X, okay? And if someone will be your scribe and take notes for us, we'll come and get these probably during lunch. But we just want to hear back from you to know how we continue to move forward and support this work. Because we love this sort of gathering. We can't do this every week, unfortunately. But we love this and want to continue to support you as best possible. You will also see on your tables little half sheets. Those are what we call our take-home cards. So there's opportunity there for you to write connections that you make and you may not have met yet. You can write their name, their email. You can take a picture of their card, whatever makes you happy. And when you flip that over this afternoon, we're going to talk to you about kind of what the other side means as you walk out the door. So we are trying to do some things intentionally to connect us and to build us moving forward. Does that make sense? Pinky promise? All right, let me see. Did I get all the things? And Kate was going to come up here with me, and I don't see. There she is. Did I get all the things, Kate? Does anybody need a card at their table? Did we miss any tables? Perfect. And if you wouldn't mind, if you would put your actual names on your card, that way we know who was in the conversation, that would be phenomenal. All right, you're on your own, kids, for about 20 minutes. We'll come back and send you to lunch here shortly. All right, friends, I love all the chitter chatter. I don't know if that's technically a phrase, but I like it. Thank you for being willing to have conversation with your table mates, even if you didn't know them already. I appreciate that. We are moving very quickly towards lunch. Very exciting. So I want to let you know what's happening with lunch. We're very glad there are 2 tables you can choose to peruse, and you can go down both sides of the tables. So we have the breakfast table. They also set up the other table to the side. We're having sandwiches and salad and chips and cookies and fun things like that. Your options are ham and Swiss or turkey and cheddar. There is a vegetarian that has some hummus, lettuce, squash, pretty vegetables on it. That's all I got. It's a wrap. You'll know that one because it's a wrap. So my request is, if you are not like solely vegetarian, maybe leave that for the folks who don't eat meat at all. That would be awesome. And there's ranch and vinaigrette dressings. There's a chocolate chip cookie and a sugar cookie option for you. So that's our lunch. We're going to take a break from now until I think 1 o'clock is what the schedule says. So we'll take a break, give you time to kind of just chill out for a minute, continue the conversations. If you did take notes, you're my favorites, but don't tell the others, okay? But just leave that form on your table and we'll come around during lunch and pick those up from you. The other thing is we do have certificates of completion. I know some of you can get CEUs or just hour credit or something. We will give those out at the end of the day and ask that you wait until the end of the day because it says 5 hours on it, and so that's when we will be able to provide it for you. So I think that's all my notes on my handy dandy handwritten card. So feel free to grab some lunch. We'll get started back right around 1 o'clock.
and family. We'll get started in about 6 minutes. I'm going to make you look at your phones. Thank you for being here. We'll see you in about 6 minutes.
Alrighty, folks, we will go ahead and reconvene. According to my phone, it's 1:01, so want to be very mindful of everyone's time. First, I hope you guys were able to enjoy lunch and find something to keep you full for the afternoon. This morning when I was before you guys, I thanked a lot of people, and when I went and sat down, I realized that there are a whole group of folks that I need to thank that I did not. And that's the folks who really paid for everything for us to be able to be together today. So I want to thank our friends and partners at the Tennessee Department of Health who provided the funding to bring Dr. Bethel back to Nashville. Just an amazing partnership, so thank our friends at the Department of Health. I want to thank our friends and partners at the Department of Children's Services who paid for lunch today and who provided the funding for Jesse Kohler that you're going to hear a little bit later this afternoon. And then I also want to thank the amazing folks at Centerstone who provided the funding to bring Dr. Sege in. So as I said earlier, this truly is collaborative work, and I think the investment of those dollars speaks to that as well. So again, join me in thanking everyone who provided funding for today. So as we were fleshing out the agenda and we were making decisions about who was going to introduce which speaker, I kind of scanned through the list and I was like, yeah, I got Dr. Stewart. Let me have Dr. Stewart. And so as I was sitting at the table this morning, I thought, you know what, let me Google real quick to make sure that, what I'm remembering about her bio is truly what is her bio. So if you Google Dr. Altha Stewart, you know you've arrived when you have your own Wikipedia page. And so seriously, if you Google Dr. Altha Stewart, there's going to be this amazingly beautiful photograph, and it's going to say, Altha Jean Stewart is an American psychiatrist. In 2015, Stewart was recruited by the University of Tennessee Health Science Center to establish and direct the Center for Justice Involved Youth Health. I just lost my whole thing. But it goes on to talk about her education and her amazing accomplishments that in her role, and recently she completed a term being the first African American president of the American Psychiatric Association. And on top of all of those incredible accolades and skills, she's a Tennessean and from Memphis and still lives in Memphis. But even more, and selfishly, Dr. Stewart serves as one of the 21 members of the Commission on Children and Youth who helps guide the work that we do every single day. And so when I was just talking with Dr. Stewart, I said, do you want me to read the whole 7 pages of your bio? And she was like, oh, dear God, no. But one of the things that she did say that I could share is that several years ago at Children's Advocacy Days, Dr. Stewart was a speaker. And so that was the year that we had asked all of the speakers to kind of give us their theme song that we could play as they were coming on stage. And so Dr. Stewart, being the amazing person she is, chose the song In the Room Where It Happens from Hamilton. And so every time I see Dr. Stewart approaching a stage now, I hear that song happening in my head. But I want you all to join me in welcoming one of the smartest, one of the most effortlessly cool, one of the most genuinely kind people I have ever had the opportunity to know and work with, Dr. Altha Stewart.
See how Richard makes me act out. Thank you all for being here after lunch, not being outside walking in the warm. It's really cooler in the building today. Not being out there walking in the dark. And for Melissa, where are you? So I can say this knowing that you see and hear me. Thank you, Melissa, for making me the first speaker after lunch. As people are digesting their food, the blood is running from their head, and you really want just to close your eyes for like 10 minutes. I'm supposed to be up here sharing knowledge, as it were, and keeping you engaged was the orders I was given by the dear Melissa. So, in an effort to do what I'm told, which is rare, I'm going to try this afternoon as we kick off this, this part of the program. I'm going to try to share with you an experience that we've had in Memphis that I think will be useful for those of you in this period of transition from focus on ACEs to focus on resilience, from BSB to the Tennessee Resiliency Collaborative. And in addition to having a Wikipedia page, I am also someone who tries desperately to be authentic and to say my real truth. And so I will tell you that it is with somewhat of a heavy heart, and I didn't get a chance to share this with the commissioner this morning, but is Julie still here? Julie Rotella, are you still in the room? Because I want to say thank you to DCS. Since 2017, Shelby County, and specifically the University of Tennessee Health Science Center, has been graced with one of those grants, BSB grants. We are, for the first time since 2017, we will for the first time not have a DCS grant to do this work. And I'm thanking DCS because their willingness to let a big university be part of this cohort of people doing this work coming out of the gate gave us a chance to offer Memphis something that we think is now embedded well enough that we will be able to sustain. So I thank DCS for helping us to get started on our contribution to ACEs. And what I'm going to talk to you about today is how we are bridging the gap from where we were with BSB to where we as a city, as the university, and the Academic Medical Center in the city of Memphis are going as part of the Resilient Tennessee Collaborative. So that's my goal today, and I'm going to talk to you specifically focused on what we are doing and plan to do to give you a glimpse into what a big difference it can make to have this opportunity that we've had to basically transform child-serving systems in Memphis. So, is there, oh, here it is. There's a clicker. Let's see if I can, am I doing something wrong? It's the arrow, right? Tech guy. I have a Wikipedia page. Okay, here we are. This slide is here to remind us all that we are here today and for this week. I actually started on Saturday before the week officially began. We're here, in addition to everything we are doing here today, we are also here today because we are in the middle of Children's Mental Health Acceptance Week. And I am wearing green so that all of you will know how very much I support this national effort. And we do it big in Memphis, just in case you haven't been there during this week. Our bridge will be lit up green, the big bridge that symbolizes Memphis now. It looks like an M. That's going to be green a few nights this week. So if you have friends there and they say, oh, our bridge was green, remind them that we're celebrating Children's Mental Health Acceptance Week and tell them some facts that are available online, just as a part of our ongoing education on this effort. Don't make me say I got a Wikipedia page again. Okay, why is it not moving forward? Yesterday, am I doing this right, advancing the slides with the arrow left, arrow right? Okay, it's just on a delay, okay. I'm very impatient, my staff says. If my computer does not boot up, we hosted our own trauma summit in Memphis yesterday, and then I came up last night to be with you all today. But I show you this image of our program because the young man in the circle on the right there was our guest speaker, our keynote speaker. And in addition to speaking at the conference, the night before he met with a group of young men at our juvenile detention center to give them some to make some conversation with him about being part of the trauma impacted group in the detention center. And then last night he met with a group of young men and boys, male only, in the community to speak from a male perspective about his experience in mental health systems as a person living with bipolar. He showed a real straitjacket that he had once been in during one of his hospitalizations, and he talked to them about a life of big promise and challenges, because he was recruited to college in North Carolina, UNC Chapel Hill, to play football and run track on an academic scholarship, and wound up being recruited to play in both sports. So I show you this to share with you the magnitude of the work that we are doing in Memphis to bring the message of trauma does not have to end in negative outcomes, and that the morning speakers were really very inspirational to me and kind of validating, because what Dr. Bethel talked about, without us knowing about that program and act, we are putting pieces together which are part of how we will sustain our BSB work. We're putting the pieces together to make the shift in the state that the state is making to move to resiliency and promoting community resiliency building. And I'm sad that Wendy Ellis was not here. If you've ever heard her speak about building resilient communities, these are all people that have a lot to share in things that Tennessee can make use of, because as each of them has said, we're really out ahead on this whole understanding ACEs, doing trauma-informed therapy, incorporating trauma-informed practice into everything that we do throughout the child-serving and family support community. So I just wanted you to know that in addition to today's state summit, there was a local trauma summit framed in this same way in our hometown. This is a calendar of the events for the Children's Mental Health Awareness Acceptance Week. My staff every year says, can we just do a week? And every year they get the same answer, no, because there's so much to do around children's mental health and around acknowledging the issues that we face in working with kids who have mental health issues or trauma issues, and that this is our one opportunity to have everybody focus like a laser beam on children and what they need, and their families and what they need, in a way that we don't get to do outside of the month of May. So my staff suffers, and then everybody gets to go on vacation in June. This slide was actually added this morning. I watched the news, and there was a shooting incident here in Nashville, and 2 young people were somehow involved. I didn't hear the whole story, but the anchor, and I can't remember which of your channels it was, but the anchor started the story with 2 children were involved in a shooting. And I thought, yes! Y'all know I'm on a campaign to stop calling kids juvenile. Probably everybody in this room. Everybody in this room has heard me go off about the fact that we call other people's children juveniles, whether they are perpetrators of crime, victims of crime, or just innocent folks walking down the street caught in the crossfire. The lead is always juvenile, juvenile this, juvenile that. So I've been on this campaign for maybe 3-4 years now. And when I heard the anchor say children, I thought, yes, somebody at that TV station must have been in an audience and heard me say this. And I got so happy. They cut to the woman on the scene, the reporter on the scene, and her lead was 2 juveniles have been involved in a shooting incident. And I thought, dang. So I stopped everything. I added this slide to remind myself to say words matter. We have got to get on board with understanding that what we say to children is just as impactful in a traumatizing way. When we call them these names, I can't make the legislature change the wording in the law from juvenile justice or juvenile court or whatever. But I can say to all of you who I know share this belief fundamentally that if you didn't get up this morning calling your child a juvenile, we really shouldn't be calling other people's childs juvenile, no matter what they have done. no matter what has happened. We should not impose that image. Because what comes up in your mind when you hear juvenile? Hold my purse, lock my door, stay away because they're bad kids and they're up to no good. Let's not keep doing that. So I just wanted to remind myself, I will not stay on that. Richard talked about the year of the Child Advocacy Days when I was really into Hamilton. Every song had meaning, and the Alexander Hamilton song, if you are a fan of Hamilton and remember that song, remember it starts with born in the Caribbean, the father left the mother, mom died, he almost did, got adopted by a cousin who hung himself, and the people on the island surrounded him with love and support and gave him the money to come to America. Now that's fostering a positive experience. You know, we didn't talk as much about the positive experiences 4 or 5 years ago, but when I thought of that, that was kind of how I began that Child Advocacy Day presentation, and it is available thanks to TCCY. It's available on YouTube, and looking back on it now, I actually think I was ahead of my time in understanding the importance of words and music in the work that we do. This is my framing slide, because Frederick Douglass obviously understood ACEs to say this: easier to build strong children than repair broken men. That's the nature of what we do every day. We're trying to repair stuff that we should have prevented, because by the time they get to be grown folk, you know, we're climbing up a steep hill. So, and thanks to the Urban Child Institute, who I know are sponsoring some watch parties. Hi, Katie. Hi, Catherine. I know they're sponsoring some watch parties. But I lifted this off of their webpage as part of starting my conversation with you about what we have done and are doing in Memphis. Children aren't just small adults. In medicine, sometimes we forget that the fact that we can ratchet down dosages to accommodate differences in weight and size and other things doesn't translate into the fact that they're still children. It doesn't mean they're not still children. We've just learned through the history of medicine to accommodate by adjusting down certain things. That does not work when we're working with children who've been impacted by trauma, when we're working with children who've been impacted by some level of mental illness or serious mental disorder. We have to remember they are children. And within the systems that serve children and their families, we often forget that. Boy, this size must be older than he is. I can't tell you the number of times I've walked through the detention center and asked, how old is that? The kid is here. They've rolled up the legs of the pants and the sleeves, and they tell me he's 9 years old. Or the kid who is 16 and busting out of the jumpsuit, and they tell me he's only 15. And he's taller than me, you know, a couple 100 pounds easily, but he's only 15, which means he has a 15-year-old brain, which we all know means it is not fully developed, and which we know does not produce good decisions. I mean, the minute I tell a lie, stop me. Okay? There is a model that I used as the basis for the startup of my center. We started with the Center for Health and Justice Involved Youth. It is now called the Center for Youth Advocacy and Well-Being. But there was a model that we had in mind where what we wanted was a healthy child in development across their early childhood experience. And so that meant that we needed to have a cover that included strong communities and a healthy economy, because we all know what happens in households where there is poverty, unemployment, lack of education, a host of other issues, social, emotional issues that work against a child having a healthy development environment. And those pillars are the kinds of things that we saw as essential to whatever we were going to be able to do with that child and that family. We saw those as essential foundational pillars to hold up this stuff that we knew was a necessity in making this all happen. You've already seen this at least once today, and this is the one from Dr. Ellis's building, community resilience building site. And I won't go into detail because we know this backwards and forwards. But what is important that I will point out is the infertile underground, where the roots of that tree are. And I love Dr. Segay, his description of how the roots of the tree help each other. And my immediate, I don't know about you all, but my immediate association was Avatar. And the way all of that network, and it was brilliantly filmed, but the way all of that network communicated with each other and strengthened each other was my immediate association when he showed that picture. And I think of it often with this picture. There's also now an evolution in how we view ACEs. That we now understand that in addition to the things that happen in the house, the things that happen in the community, there are things outside the control of that child and family that we can loosely define as environmental impact issues, everything from disasters in the community that they are living in to increasing levels of violence and other things that are on the slide. This is the traditional ACEs pyramid that we have all come to know well. And it's a great graphic illustration of the science behind and the theory behind what we know about adverse childhood experiences. But I like this image better because when I'm out in the community talking, that pyramid doesn't get people interested and excited and aware. These kinds of pictures that they can relate to is what a parent or a community member or a church group will say, oh, I understand what that means. I know families where that stuff is going on. So that's what you're talking about. Because my goal at the end of a day or a meeting or a session is that people walk away with an understanding of what we're trying to help them appreciate as part of why things are happening. Behaviors in children, dysfunction in family, things that are going on in communities. I want them to carry a picture that they can share with somebody about this, why it's important that when the lady in the apartment next door, we know she's getting beat, this is why it's important that we support her. This is why it's important that we help with her kids. This is why it's important that these things are done on behalf of the people that we know these things are happening to. And then there is also this additional framing around including historical trauma that is on top of the current adverse childhood experiences that begins the process of trauma for this child that grows and grows and grows into their adulthood. And this is where issues like racism, structural racism, discrimination, sexism, and all of those things play a role in setting the stage for where people start with the experience of the today trauma. This is kind of, as a graphic illustration of talking about all of this stuff, what does it actually look like? And for me, this kind of cycle of there are these things that are occurring, and it results in certain behaviors, certain things we can observe in the kids and in their families. And this is just one example of what it might look like in school. Child comes in, they're having challenges either academically or behaviorally, and we make assumptions about what's going on as opposed to trying to get the backstory and understanding the family's story, their narrative of what life day to day is like. We see behaviors like hypervigilance in a child who, if you go to touch them, they jump, or if they're coming in after a traumatic evening at home, whether it's domestic violence, gunfire in the community, whatever it is, witnessing someone die, they may come in and just put their heads on the table. And we've had teachers tell us that their natural response is, get your head off the table, off your desk, sit up straight, pay attention. And after they begin to understand and frame this in the context of potentially an adverse childhood experience, or at least a traumatic experience that this child has been through, they can reframe their response. We've had teachers create and work with school administrators to create reset rooms in places where discipline had been the order of the day, where the school resource officer would be the first person they would involve, as opposed to going to the guidance counselor for something like snapping at me when I say, get your head off the table, I'm going to call the school resource officer. Now they think about, maybe I should get the school counselor involved. Maybe they should be the first person to contact. So there is a cycle that helps us to understand what it looks like so that we can better respond when we see it. I call it no wrong door, and I forget what Dr. Bethel calls it, through any door. And I think now we have a reframing for no wrong door, because this is my, things that stop the process and things that facilitate and move. Once you go through that door in the middle, which is our center, whether it's a behavior problem, whether it's something going on in the house, whether it's a mental health or physical health problem, whatever it is, school attendance, somewhere in going through that door, which represents my center, we have things, people, places, organizations that we connect you with immediately. These are not, call this number and get an appointment. These are specialists who interact with the family that brings in anything in those red circles, ovals, and gets them to the green oval and sticks with them in that oval until whatever is going on at least has begun to be worked on. Sometimes these are complicated issues and long-term issues, and so we don't always get the opportunity to stay with someone for 6 months, but there's always a follow-up. If we're releasing you to someone else's care, we're going to follow up within 30 days, 60 days, make sure things are going well. It's part of what the framing that we set up with our BSB grant was to intervene, assess, intervene, and follow up. And so that's part of why I thank them, because they helped us create this no wrong door model. But now it's going to be through any door. This is like halfway through, so I'm gonna take, that was the Building Strong Brains kind of foundation. And now we're gonna move to the Resilient Tennessee collaborative part of this. And I really like both images of the brain. The green is a better look for Children's Mental Health Acceptance Week, I think you will agree. But I like them both. And they both say something for any of the art therapists in the room or people who work with art therapists. We could have a couple of hours on the images in each of them and how they translate into what we expect people will do or have done in those programs. But that's for another day. Change the narrative. I started with words matter. Changing the narrative is the next big category. You heard this morning. It's not what's wrong with you, it's what's happened to you. Often, because I work in the juvenile justice space, often I hear people tell me that you're just making excuses for bad kids and they got to learn their lesson. There's a whole media blitz in Memphis that says every child who encounters law enforcement for one of these crimes ought to spend at least one night in detention to teach them a lesson. How many of you think detaining that child for one night is going to teach them a lesson? Raise your hand, please. Raise your hands. I can't, is there a hand back there? No. So we know that is not the way to teach the child a lesson. We know that's not going to work. What it does, in my experience, is give them an opportunity to get a graduate degree in criminal and delinquent behavior and to make some new friends that we really wish they didn't have, who have influence and power, and tell them with certainty, because they've already been through this, well, man, you just stay one night and then you out when you hook up with a brother. I got something for you. We know this is the course of action that goes on in these, whether it's a juvenile detention center, a residential treatment facility, even a long-term psychiatric hospital. Kids learn well how to tell us what they think we want to hear, to get out of there, to hook up and do some more stuff that doesn't make sense because their underdeveloped brain thinks it's a good idea. I end every sentence now with people who don't work in the field with, well, that child has an undeveloped brain, so any decision they make is suspect. I have a picture of that picture of the brains that I just showed you. I have one of those from an old New Yorker article where the brain, the image of the brain is this huge outsized thing with this tiny little area that says either learning or education or something. The rest of it is wide open for risky behavior, drug use, risky sexual behaviors, and there are these dangling cables that don't connect to anything because it's just flapping in the wind. That's the adolescent brain. In real terms, that is the adolescent brain. It connects to very little. When my mama used to say, there's nothing between your ears, I had no idea she was that smart. No idea at all that she understood even before I went to medical school. My mother, who was a librarian and read a lot, but I really don't think she read a book on child development and development of the brain. I really don't think she read that book. But she understood between these things, there is basically blank space. I mean, there's an organism that we call the brain, but the important part of the brain, as we all now know, because we've had 7 years of ACEs, right? We understand brain development, right? Is there anybody in here? Because I'm not hearing right. Okay, thank you. You know, I'm a Southern girl, raised in the church. I need a little call and response. Otherwise, I think y'all are asleep and just have your eyes open after lunch. Help me, please. But we now know that they were right. We now know our parents, well, for some of you who are very young, maybe your parents never said it, but I see a few people in here that I believe are my age or close. So we know they knew what they were talking about. We didn't want to believe it because we thought we were smart. We knew everything. This next one is, what if instead of relying on children to become more resilient, we were to create a world that was less traumatic and traumatizing? I'm not sure that we truly appreciate our role in creating the environment that leads to the traumas that result in the things that we are all working on. Because our speaker earlier, right before lunch, on policy, talked about some of the things that would fit into a prevention category. And if we get that far upstream to prevent things, we'll have less kids who've been traumatized. It will mean less work for us in the area of trauma-informed practice. But you're all smart people. You could learn a new skill. You know? It would be fun, I think, to learn something other than working with kids who have been traumatized through no fault of their own, that we are trying to repair instead of fixing. Before creating the environment that fixes it before it starts, that keeps it from starting, actually. And then the phrase I told you, I say most often, especially in the legal law enforcement community. Trauma, when I talk about trauma in a particular child or in children in general, this is not an excuse for any behavior. I recognize there are some children, some youth, some young people, adolescents, young adults, that no matter what our efforts, they are going to continue to be challenged, and as some people say, we may not save them. But every child deserves a chance to be saved. I'm a big believer that any system that touches a child ought to know this stuff, ought to screen for this stuff, and ought to understand how to provide access to treatment for this stuff. If asked in a TV interview by 60 Minutes, do I agree that universal screening for childhood trauma and adverse childhood experiences should be the law of the land? Trust me, my response to Leslie Stahl, Anderson Cooper, any of them, is going to be absolutely, positively yes. Absolutely, positively. Wherever the through any door model means consider that every child and family that you interact with, wherever you are on the social human services spectrum of services, assume when they walk through the door that you've got somebody or somebodies who've been traumatized. Living in America today is traumatic for me. And I don't mean that to be anti-American, but you turn on the TV, you walk down the street. I heard a young person here in Nashville on the news. I got to stop watching the news. Here on Nashville, who's one of the protesters apparently down at the Capitol, talk about, I can't feel safe going to the mall with my friends. I can't feel safe going to school. I can't feel safe in church. I can't feel safe in my community. It shouldn't be like this. That means to me that all of the kids who've been exposed to everything that's been going on, let's just say within the last, 3 months, are now kids who've been exposed to trauma. No matter what life they had before this, no matter how their families helped them interpret what was happening, we now know that our children, wherever they enter through any door, are now being challenged. This is the slide, and it's actually busy, but there are about 12 other things that could be on that slide. I don't have any of my hospital partners. I don't have specific faith partners, and I don't have all of the parts of the school, the Memphis and Shelby County school system that we partner with on different things. But this is just a sampling of how we approach the care that we believe leads to resilience in these families. That we can talk directly to groups like the United Way of the Mid-South Drive and the DREAM program, which hosts over 200 social and human services organizations on a single platform, kind of like what Dr. Bethel was talking about with the ENACT program. On a single platform, we can get access on behalf of a family to any of the services they might need. Everything from utility assistance to rent assistance to legal assistance. These people are a part of their network, and now we are part of their network as well. And with a few clicks, we can make a referral online to someone who gets all of their information and spits out an appointment. I love technology. I don't understand it, but I love technology. Some of the others, obviously the juvenile court, the sheriff's office, DCS, our partners in the schools, our mental health partners. We have a growing relationship as our community of people who primarily speak Spanish, our growing network of organizations that serve a Spanish-speaking population has grown. Beyond what it was 5 years ago. We have expanded to incorporate primary care, pediatric health care, COVID work in the aftermath of the pandemic, and with the emergency authorization ending tomorrow, we have ramped up that work for those communities, primarily racial and ethnic minority, underserved, and impoverished communities, to help spread the message. It is not too late to get a vaccination. It is not too late to order home test kits. It is not too late to get more information to make a decision about whether you want to now 3 years in with the variants that are arising that are more transmissible. So we've expanded beyond the mental health trauma focus that we started with to incorporate the whole person and the whole family, which warms the cockles of my heart. But in addition to that, we've identified some areas that are represented here that we can actually do some things to create positive experiences for children. Everything from working directly with families on understanding parenting in a way that many of our parents never understood. People raise kids based on how they were raised. That's a pretty well-known social certainty, in fact, truth. And so, as one of my moms told me in my first system of care program, wonderful, we created a rule named after her, and she gave me permission to call it by her name, the Hudson Rule. Dr. Stewart, she told me 2 things that I will never forget. Dr. Stewart, you seem like a smart lady. You're really nice. I really like you. But sometimes you start talking and I don't know what you're talking about. I don't understand them words. You got to break it down. Yes, ma'am, Miss Hudson. That became the Hudson Rule. And today in Memphis, anybody who knows me in a community setting and says Hudson Rule, everything stops. Everything stops. And whoever just said something that they may not have understood now has to go back and break it down. The other thing she told me was, we really didn't understand. We didn't know When we were at the end of a component of a training with parents, the moms, and it's mostly moms, unfortunately, the moms would look and say, we didn't know any better. When we know better, we do better. So those are two things, two lessons I learned from listening to people about how they understood creating more positive experiences for their children to remove some of the stuff that was causing them challenges. This is the 5-finger, what I can do, providing concrete support in times of need. And it's just your hand. It's like I lived in Detroit for a while, and everyone represented Detroit this way with the thumb being, that area, and then everything else up here being northern Michigan and the UP. So think of your hand as one way to begin considering how to build resiliency in families and communities and people, providing concrete support in times of need, building parent and caregiver resilience, and there are strategies and practices and things that we know or can learn about building resiliency in individuals. Establishing and helping them to establish and enable access to support social networks. A lot of people are living in isolation, sometimes because the issue that they are dealing with is stigmatized, that they're embarrassed, that they're off by themselves because they've been rejected, perhaps by family, friends, neighbors. So helping people to understand how to build a social network. You know, when we did our first system of care program in Memphis, it was the first time some families understood that a child and family team meeting called by DCS meant that they could bring other people. They thought it was, I come and I get spoken badly to. And because that was all they'd ever known. They didn't understand how to advocate. They didn't understand what the rules were. When we began to help them understand their rights and where we fit in their support network, and that it might be the lady next door who sometimes pitched in and helped take care of the kids because mom had a late shift. It might be some estranged family member who cared about the kids but was tired of mom not controlling them, who would do things for the kids but wouldn't talk to the mom. And that building and rebuilding and starting to figure out who needed to be in that network might extend to, if it was a boy of a certain age, the uncle or cousin, older cousin who lived in another city that we could connect via the computer to be a part of that meeting. That these were all possibilities in helping them to understand how to create a network that helped them become resilient. Helping people understand what child development means. People hear your brain isn't developed till 26, but they expect a 12-year-old to make good decisions. So there's a disconnect there somewhere that we can help people overcome. And then finally, helping kids develop that social emotional competence. Someone asked me yesterday, what is SEL? What is social emotional learning? And I said, well, it's kind of self-explanatory. The social part means if I don't know how to interact socially, I'm going to overreact or do something that is antisocial because I never learned how to do it. Kids who don't know how to play together without fighting, kids who have to demand doing things in a way that is their way and don't tolerate anything else, have never had the experience of having to learn to negotiate, of having to understand things don't always go your way. The kid who, in the middle of the supermarket, sitting in the basket, slaps their mother, is a child desperately in need of social emotional learning, in addition to some other things. But definitely some social emotional learning, which means helping mom learn to deal with those things and create the environment where she helps her child to become better at social interactions. The emotional stuff is basically regulation. When we see kids who have been traumatized that we describe as dysregulated, they never learned to regulate. They didn't even know regulation was a possibility because in their world, this is how I see people solve problems. This is how I'm allowed to deal with my problems. No one stops me. And so you step on my foot, I hit you in the face. You take my thing, I'm going to take something from you, and then I'm going to hit you in the face. You know, these are things that we have to teach kids who are developing so that they embed them, integrate them, incorporate whatever word works for you into how they behave and how they respond emotionally when things sometimes don't go their way. I've already told you I'm a universal screener proponent. I think everybody who works with kids has to be trained across the board to understand the role of culture in how we engage and serve people, that one size does not fit all, and that sometimes what we call non-compliant is our own inability to understand how to properly engage someone. And then finally, we have to really accept the fact that despite our best efforts, despite our intent, we are not the only people that these folks interact with sometimes. And that bad experience in just one agency transfers over to all of us at some point. People assume that because I'm black, that people who come in who are black are going to just naturally be inclined to want to work with me. I wish that were so. In fact, many people are inclined not to want to work with me because of the way they've been treated by someone who looks like me. And a lot of my white colleagues assume it's only them that people just don't want to deal with. And when I tell these stories, they say, oh, no, you're so nice. I'm sure everybody loves you. They walk in and say, can I see her? I said, no. What they walk in and say, do I have to see her? Because somewhere down the line, they've interacted with someone who set the stage for them not to want to interact with anybody else. And there's some people in this room who know I'm telling the truth, and they don't want to say it, but they know I'm telling the truth. And it's okay. Because the lesson here is that we can all learn. There are programs, there are trainings. The class standards is a good start because those are federal guidelines. And if you adhere to the class standards around language, around cultural adaptability of programs and practices, then you're at least halfway down the field to having the kind of engaging interaction with someone that has a shot at having a positive outcome. These are all of the things that we have learned through our programs, our BSB program and a few others, about what the impact of doing these kinds of things is in the life of a child or family. And these are pretty good measures and outcomes as far as I'm concerned. Fewer kids committing suicide at a time when kids are committing suicide or threatening or thinking about suicide being at a higher rate than ever before in the history of the world. And these other things. These are important things and steps along the way to promoting resiliency in our children. Dr. Segay mentioned Carl Bell, and I told him before he left that Carl was also one of my mentors. And this is a picture of me and Carl at my presidential reception when I was elected president of the APA. And what Carl is saying, I wish this was video, because what Carl is saying, he's leaned over, looked at me and smiled and there's a whole story behind Carl Bell that I won't share. But he's looking at me saying, I guess you did okay. That is high praise. That was high praise from Carl. Unfortunately, he is gone from us. But this is something that he drilled into my brain, that Dr. Segay talked a little bit about. Risk factors are not predictive factors due to protective factors. And we are the protective factors. Dr. Bethel said we are the medicine. Same thing. We are the protective factors in the lives of these children. I actually feel like today is kind of making a quilt. We're piecing together things that if you cover yourself with, you will have everything in your toolkit that you need to do good work with children and families experiencing the things we're talking about and helping them get to a point of resiliency in their lives, in their functioning, in their community, wherever they want to be. But this is a mantra I would encourage everyone to remind themselves of when you're working in a setting where it seems kind of desperate and people aren't seeming to get it and do what they need to do. Risk factors are not predictive factors due to protective factors. Consider yourself a protective factor. Consider yourself the medicine, in the words of Dr. Bethel. And Because I love Carl so dearly, and he was a great mentor and teacher and teaser, we actually shared a birthday, and every year on our birthday, he would say, I don't know you. I don't know why you say you're born on my birthday. I don't know you. But he was that kind of guy, psychiatrist, south side of Chicago for 30, 40 years. Use his rules. These are his rules. Use a strengths-based approach to support kids. Thinking of us as the protective factor, we're the village that they need. The services, treatment, support, advocacy, building skills related to them becoming advocates for themselves, being empowered, and bringing those skills to bear as part of their resiliency building. The family, these are words that you've already heard today. Family-centered, youth-focused supports include everybody who touches a child, school, any agency. We utilize a wraparound approach, a trauma-informed, wraparound approach to work with kids and their family. And for the system of care people in the room, I have incorporated wraparound into everything we do. Every one of our programs, Carrie, has a wraparound focus. And people talk about wraparound services. I'm not sure I know what that means. What I do know is a wraparound approach, because that brings in a host of other aspects and components of the system, including families who work in the system as family support specialists, including youth who get trained to be peer supports for their fellow students, including training for teachers and pediatricians and anybody else in a child-serving agency, organization, system that needs to have that. And most importantly, working from a needs base, as opposed to only identifying problems, deficit, and deficiency in that child family, which in essence is saying, you're the problem. You don't have something you need, and you need to get it. We can't continue to do that, and creating goals, again, that are created by the family. The name of the United Way program is Driving the Dream, and somebody better tell me about time. And so we believe that that's the kind of approach that people are involved in setting up the goals for themselves. I won't go through all of this, because I think, and this is not me, by the way. Someone thought this was a picture of me, but it's not. I do like the quote, every child deserves a champion. That adult who will never give up on them, who understands the power of connection and insists they become the best they can possibly be. I loved it. Rita Pearson, I've never met her. I didn't Google her, so she may have a Wikipedia page. I don't know. But I think she captures the spirit of what we all want. Kids don't have developed brains. They're gonna make bad decisions. They're gonna do risky things. They're gonna get into trouble. It doesn't mean that we stop caring about them, stop helping them, stop working on their behalf for them to be the best they can possibly be. I heard a story this week of a young man who got into trouble, but before he got into trouble, the first time that he had ever been in trouble, before he got into trouble, he got a scholarship, a very prestigious scholarship, to a program that spoke to his passion and his hopes for a future career. And despite having gotten into trouble, people using a wraparound approach helped the family learn to communicate what had happened, and also helped him to understand that having made this mistake and made it the worst day of his life, and that there would be consequences, they were able to navigate well enough that he has not lost his scholarship. Now, yeah, give him a hand. I usually don't predict we won't see people again. But in this case, I think because everyone was focused on doing the thing that they could do to make it better for him to become the best he could possibly be, his undeveloped brain said, I may not know everything, but I better straighten up. And in my heart, that's really all well, it's not all that matters. I would have preferred him not being in trouble in the first place, but that makes me happy. That what we do makes an impact. Oh, I got Frederick in there twice. I'm sorry. I'm going to run through real quickly. We have 8 programs in the University of Tennessee Center for Youth Advocacy and Wellbeing. On top, of course, is our BSB program, which will be ending this year. But we have a program we call GIFTS, which is strictly gang intervention. We got into that because of the increasing community violence that was being attributed to young people. So we got into that and received some federal funding, and you'll have the slide, so you'll see all of the people that we partner with and all of that. Our integrated care for child well-being, for child wellness, came about as a result, actually, of a question that I was asked about kids, the psychological needs of kids with chronic illness. And so we wrote a grant to create this program. But on the heels of that, there was this significant increase in the number of kids experiencing traumatic injuries, gunshots, stabbings, serious assaults, car accidents, and other stuff, who were not being connected well enough with the services in the community. So we wrote a grant for this program, and it's been funded. And we're about to incorporate some of the school mental health, school nurses, and other things into this program as part of our work with another grant I'm going to tell you about. Impact is another one of our gang intervention programs, but it's for a younger age group. The young kids in the family who look up to the big brother or uncle or cousin who is in a gang, and you see them on Facebook with their gang signs and their colors and everything, this program is targeted at them in a very specific area of Memphis where there's a lot of gang interactions. Our Shelby Connects Network is our new system of care program, which sponsors a lot of educational things, uses that wraparound approach, and has incorporated trauma-informed practice into the system of care model. And I'd love to talk more about each of these. We were funded, thank you TCCY, to create a pilot youth reentry program which had never existed in Memphis. We have every other aspect of the justice system for young people, but we didn't have a reentry program. So with support from TCCY, we created one, and that led us to submit an application to OJJDP to create a citywide program, the first ever in the city, which is coming online soon. And then finally, our Project Rare grant with our school partners allows us to participate in their newly developed evening wellness centers, which operate so that families can make use of the school mental health system without having to leave work or, do fantastic things to get downtown before 5. So they'll be operating in 3 areas. We'll be working with them directly as their contact in the community to keep that linkage solid so that there is no question that they can get into the system through any door. I like that language. I'm sorry I missed telling her that. And then finally, just about every decision these days. One of the things in my bio that I did not ask Richard to say is that I spent time in South Africa with the South African Society of Psychiatrists and was made an honorary member, and one of them gave me a book, Leading Like Madiba. And so on the long flight back, I read it, and I decided that I needed to embrace a leadership style that was clearly successful if he could unite South Africa after apartheid. And that maybe there was something to be learned from Madiba. So this is my favorite quote. I've got 5 T-shirts with it on there. I wear them proudly. It always seems impossible until it is done. So I guess my message is, we can do this. We can move from understanding of adverse childhood experiences to embracing and embedding into everything that we do positive childhood experiences that will lead us and our families and children to a state of resiliency that will allow them to thrive instead of just survive. This is our contact information. We are on the UT website. You can find us. If you're in the need of referrals, we are currently doing some work that has allowed us to actually place kids in services in Madison County and Hamilton County. So we are beyond the boundaries of Shelby County. And if you've got kids out there who happen to be in places and you need help with services in the West Tennessee area, as we are exploring options for resources elsewhere, please give us a call. Look us up. Look at our track record, and feel free to give me a call. Thank you. I don't know what my time is, so I'm not sure I have any time for questions. Or throw rotten tomatoes. Thank you all for staying awake.
Well, good afternoon, and thank you guys for staying awake. Melissa Roberts joined Appalachian Promise Alliance in August 2019 as the Adverse Childhood Experience and Trauma Informed Care Coordinator, as well as Bristol Connect Coordinator. She has been serving as Executive Director since September 2021, with over 20 years of nonprofit experience in a wide variety of roles, from volunteer to Executive Director, board member, and consultant. Community service is in her DNA. She is a member of Bristol's Noon Rotary Club, the Regional Diversity, Equity, and Inclusion Alliance, Virginia Organizing, National Campaign for Trauma-Informed Policy and Practices, and state of TNBR-FSS stakeholders, just to name a few. So let's welcome Melissa Roberts.
Good afternoon. So I'm going to ask that you all stay awake just a wee bit longer, if that's all right with you all. That is a hard act to follow. Dr. Stewart did a great job, and then what we had this morning. So again, my name is Melissa Roberts. I serve as the Executive Director for Appalachian Promise Alliance, formerly Bristol's Promise. We are in the process of undergoing a name change to better reflect our geographic footprint. But our mission is to mobilize the communities we serve around issues facing children, youth, and families. And our program aligns with the 5 promises that were outlined by America's Promise. And you heard this morning when they talked about the developmental assets at the Search Institute. Those 5 promises are boiled down from those developmental assets, and they're what children need to thrive. Caring involved adults, safe spaces, healthy starts, effective educations, and opportunities to serve the community. And what we have found in further research is this is exactly what adults need to thrive as well. So today we're going to talk about collective impact. There we go. And how many of you are familiar with the term collective impact? I'm so glad to hear that, because Tennessee Commission on Children and Youth had Melissa Umer with FSG do a 4-part series that is available on their YouTube channel and is amazing. So if you are not familiar with collective impact or want to do a deeper dive, I encourage you to go to their website. So I do want to start with a level set to make sure that we're all on the same page about what collective impact is and what it isn't, and then look at a progression of collective impact models from a local level all the way up to the national level, and how one feeds into another. So collective impact was a term that was coined by John Kanya and Mark Kramer in a seminal paper that was in the Stanford Social Innovation Review in 2011, and it was the Waters of Systems Change. But in 2021, the Collective Impact Forum, which is a partnership between FSG, which was started by John Kanya, or Mark Kramer, and the Aspen Institute, they revised that definition. And so the definition that's listed here is the current accepted definition for collective impact. Collective impact is a network of community members, organizations, and institutions who advance equity by learning together, aligning and integrating their actions to achieve population and systems level change. This definition identifies equity as the North Star for why and how collective impact work takes place. It also specifically names community members and key actors along with other collaborators and colleagues, and it emphasizes the importance of systems change in the work that we're doing. So this short video, it's about a 2-minute video from the Collective Impact Forum, does a great job of the high-level overview of what collective impact is and how it can create impact. And I am going to just hit the next button, tech guy, so that did work.
The number and complexity of challenges facing our world can be overwhelming. When individual organizations attempt to tackle the most daunting problems, success stories are all too rare. Many innovative approaches have been tried, too few have worked. However, when organizations work together under the right conditions, they can accomplish great things. One particularly effective means of collaboration is collective impact. Using the collective impact approach, a number of complex social challenges have been addressed and some remarkable results have been achieved. Youth incarcerations dropped by 45% in just 3 years, with no change in public safety, improving the lives of thousands of youths. 6,000 public housing residents were placed in new jobs during the recession. More than 1,000 acres were restored and over 280 million pounds of pollution voluntarily reduced to conserve and restore a river. Organizations utilizing a collective impact approach do the following. Agree to a common goal. Agree to track progress in the same way, which allows for continuous improvement. Do what each does best while identifying new ways to work together. Have consistent communication. And finally, have skilled and dedicated resources to support ongoing efforts. The world's toughest challenges aren't going away. In fact, many experts predict they will continue to grow in both number and complexity. Solving these problems requires a range of expertise from a number of diverse organizations. Collective impact is a proven approach, helping organizations work together to move mountains.
So, like I said, that video does a really great job of a high-level overview. The key takeaways are those 5 conditions for collective impact. It is the core and the backbone of what collective impact is. It includes that common agenda, making sure that everybody's on the same page trying to accomplish those same long-term goals. Shared measurements, if you're not measuring what you're doing, how do you know if it's effective or if it needs to be adjusted? But making sure that we're comparing apples to apples across the board and across organizations. Mutually reinforcing activities. This doesn't mean duplication of services, this doesn't mean duplication of activities, but it means walking together towards that common agenda. Continuous communication, and I'm gonna say here, if you all are like me, that does not mean more. That does not mean more emails, more phone calls, but it does mean that making sure that everybody understands what's going on and that there is communication. And then backbone support. So those are those 5, and you can use a collective impact model when you're trying to address complex social issues. So it's really not intended for when you are trying to support one person, but when you're trying to do systems change work. And it moves us away from that more traditional siloed approach towards a unified model of collective work. And with a unified model that moves each part of the collective towards the same direction of that ultimate goal. But I will say that collective impact is not always the best approach. And we hear about collective impact a lot. We hear about how it's great and it's perfect and it's wonderful. But I wanted to share with you today when collective impact approach is not appropriate. So if you have limited time, say that you have a grant that's due in 2 weeks and you need to have some partners on that grant, collective impact is not how you get that done. That's picking up the phone and making a phone call. In some of our collective impact work that we've done in our region and across the state lines, it's taken 2 years of what we like to call herding cats before people are like, oh, this is that common agenda. This is how we're working together, because it really does take time and a sustained effort to do that. Also, lack of capacity. Studies have shown that if there is not somebody who is focused on the collective impact from the time they wake up in the morning until the time they leave work or go to bed at night, that can create a failure in the system, and it can cause people to abandon the system and the model. Pride of place and lack of servant leadership are a little bit of the same thing. Pride of place is what one of my coworkers likes to call the minosaurs, right? We all know those people. They are the people that, this is mine, you can't have it, I'm not sharing it. Well, we call those minosaurs, and that's pride of place, and there really is no room for that in a collective impact model. Lack of servant leadership kind of goes along with that. It takes a specific type of leadership to work within a collective impact model. And that's because all of the wins are shared, all of the losses are shared, all of the information is shared. And so if you don't have people doing that, if they're too pride of, I have to claim this win, that's not going to work. Or if you have people who are not willing to take the time to listen to the collective, that's also not going to work. And we've all met the people who come into a meeting and say, this is how it's going to be, it's my way, you don't get to choose. That's really not the servant leadership that is needed within a collective impact model. So let's look at various levels and types of collective impact. And it's interesting because a lot of the partners on these are in the room today or have been in the room today. And so I'm sure that they're, hopefully going to be okay with this. So this is the upper 8 counties of Northeast Tennessee. It is an 8-county map, and this is the area that is served by the Northeast Tennessee Resilience Network, or Trauma-Informed Care Network, but we've moved that to a Resilience Network. And this network is held in trust by Appalachian Promise Alliance. And you'll notice that I didn't say that we own it, or it's a program of ours. We simply keep the network at the forefront of our minds and provide that guidance, information, communication, convening, and recording of what others are doing. And Appalachian Promise Alliance is a partner on these. But even when you pare it down to 8 counties in Tennessee, and we know Tennessee has 95 counties, it can feel like a really large area. To get from the top corner of Johnson County, which is the blue one in the top right, to either the far corner in Greene County or the far corner in Hancock County, over in Clear Creek Mill, it takes 3 hours, and it is not a direct route. And so trying to bring all of this together can be challenging. But also, these counties, these localities are doing great work around building resilience and identifying ACEs and mitigating ACEs. And it's Appalachian Promise Alliance's job to bring all of the work and worries that are being done, are being vocalized into that 8-county region. So we looked at this and had conversation with each of these localities, and this is the model that we came up with. This is the Northeast Tennessee Resilience Network model. You can see what we did is we start with an executive steering committee. These are the champions within each of those areas, each of those counties, coming together, having conversation, and they all have a seat at the table of the executive steering committee. You can see that's color coordinated by district. So we broke this up into 3 different districts. The first district, as you can see, is Carter, Johnson, and Unicoi County. These counties are similar in demographics, they're similar in size, they're similar in location. The next one is Washington and Sullivan County. The third one is Greene, Hawkins, and Hancock County, again, similar demographics. And then 2 spaces for at large. And those might be members who are serving multiple counties or serving across the state, but representing Northeast Tennessee. So we broke that down into those districts. Again, they each have equal seats at the table for the executive steering committee. And then you have the work groups that feed into that. The important thing to remember is you can see that information is flowing, but there is specifically a reason that there are arrows on both sides of all of those lines. That information has to feed both ways. It has to feed from the steering committee to the executive committee, from the executive committee to the steering committee, to the work groups and back up. And then it also feeds across that. So we have what we call all county calls every other month, which is held via Zoom so that people don't have to make that 3-hour trip or 2.5-hour trip or however far it takes them to get there and across multiple state lines. But that is important to understand that works both ways. Some of those work groups are focused on things like transportation, education, childcare. We have a lot of childcare deserts. That's not something that is, uncommon across the country for us. But the local collective impact work feeds into the regional collective impact work that has a similar, although a little bit more lofty agenda. So our regional collective impact model is by our strong accountable care community. And STRONG stands for Striving Towards Resilience and Opportunity for the Next Generation. The Strong Accountable Care Community, or STRONG ACC, which is why I stumble over it a little bit, was initiated to create a region where people and communities are connected, and we've heard a lot this morning about connection, where they're valued and engaged and everyone is healthy and thriving. And this is really leading into those social determinants or social drivers of health, which generally are where people work, play, and live, and you'll see that, you've seen it already today. So the STRONG ACC serves as the backbone for 23 counties in Northeast Tennessee and Southwest Virginia. And you can see the map there on the left. And these are the 6 areas that they are focused on regionally. Great beginnings, thriving at 5, early grade success, supported and connected youth, workforce ready, college-bound graduates, and economically independent young adults. So if you think back to the local collective impact model where we're talking about childcare and transportation, our work aligns with those same areas of focus on a more local level. So childcare deserts are a real issue, like we talked about. The work towards childcare supports goals 2, 3, and 4. Transportation impacts goals 4, 5, and 6. Housing impacts all of those goals. And so the STRONG ACC works as the backbone for multiple more local collective impact models and aligns them with those regional goals and frameworks. So you can start to see how the local work that's being done gets fed into a larger regional model. And even at that regional collective impact model level, we have work groups. This is just one work group of which both Appalachian Promise Alliance, who holds in trust the Northeast Tennessee Resilience Network, and the United Way of Southwest Virginia, who holds in trust the Southwest Virginia. They call them TICINs. So they hold that in trust. We co-chair what we call the Regional Resilience Work Group. This is a group that you can see the other partners on this work group, and all of whom take a 30,000-foot level, so you can see disseminating information, socializing leaders, equipping communities, and that feeds into those larger goals. Backbone partners to the STRONG ACC are Ballad Health, which originally created the STRONG ACC, and then United Way of Southwest Virginia. Included in the regional work and holding in trust that knowledge base for resilience work is the Ballad Health Strong Brain Institute at East Tennessee State University. We just call them the SBI. And they are the ones who have certifications. They're the ones who kind of hold in trust who's doing training, making sure that trainings are provided. So these are the groups tasked with feeding to and from, because remember those arrows go both ways, to and from those social determinants of health that we've talked about. And when you pull together all of the partners at all of the levels, there are nearly 1,000 organizations directly involved and another several hundred who are partnered in other ways. And what I mean by partnered in other ways, so for instance, our First Tennessee Development District is more directly focused on workforce-related issues, but they're aware of how ACEs impact our workforce. Therefore, they partnered with the STRONG ACC to find grants to further the work of the collective impact model. And all of that feeds into these social determinants of health, which you all have seen. You all have kind of selected that. So let's talk about what this can look like in a multi-state collective impact model. I just want to touch briefly on this. I don't want to spend a lot of time, but the West Virginia Jobs Network is working to support young people in employment in West Virginia, Kentucky, and Virginia in the Central Appalachian region. The organizations listed here serve as the backbone for a multi-state model, with High Rocks taking the lead within that backbone group. And so each of these backbone organizations bring a specific set of skills, talents, and connections to the table to create good jobs that retain young people in Central Appalachia. And this is a pilot program that's supported by the Appalachian Regional Commission and the Build Back Better Regional Awards Challenge. And then this, again, talking about social determinants of health, feeds into a national model which doesn't talk specifically about being a collective impact model, but the Campaign for Trauma-Informed Policy and Practice is a national organization that works with state, regional, and local organizations as well as individuals to advocate for and build trauma-informed, resilient practices. But Jesse Kohler is here. I know he had to step out for a meeting at 2 o'clock, so I'm not going to talk too terribly much about the amazing work that they're doing. I'll let him speak for himself. But hopefully you start to see there can be multiple collective impact models. Just because there is one collective impact model that's focusing on resilience doesn't mean that there can't be another collective impact model that's focusing on, say, workforce development, and they work together to feed into larger collective impact model, because really what we're doing here is systems change. And if we're not working on systems change, then in 20 years, we're going to be doing the same thing that we're doing today. We're going to be talking about the same issues. So I'm happy to answer any questions that you all have. So if I pop quiz you, you'll make 100? Maybe? Thank you all for your time.
Look, you know we're getting to the serious part of the day when I have on my Birkenstocks, right? All right, friends, we are going to take a break. I think it's right about 2:25. Did I make that up? 2:22. Look at that. We are almost on schedule. So let's take like a 7-minute break, which you probably learned this morning might look like 9, but just pray about it and get back to me. We will get up here right after break, and we will hear from our friends April Scott and Kimberly Ladd, and we will also hear from Jesse Kohler and have a little more discussion time. There are a few snacks still back on the snack table. There are sandwiches. Eat them, take them home. Have them, whatever you need, but have them soon, because they're going to go away if you don't have them.
Hello, everyone. It's time to get started again. It is 2:30. We're going to keep this bus a-rolling. Okay, we're going to go ahead and get started. For the ones that are here, once you get your snacks, you're welcome to sit down, and we're going to get started. So I have the pleasure of introducing two young ladies from the South Central area that's doing some great work there with resiliency. Miss April Scott has been with Centerstone for 18 years, developing prenatal, infant, and early childhood services and systems in 34 counties throughout Tennessee with multi-generational approach to promote equitable positive childhood experiences that can prevent and mitigate adverse childhood experiences and how intergenerational cycles of trauma. She has also, I'm sorry, I lost my spot. She has been a part of the resiliency project Backbone by Centerstone and a collective impact initiative that provides community education and supports on hope framework to increase protective factors and equitable access to services that promote positive childhood experiences throughout Tennessee. So you can tell that she's doing some great work in her area. So Miss Kimberly Ladd, who's also doing great work in the South Central area, is with Aligned Hope, is an advocate for child and family whole being, a facilitator of the healthy outcomes from positive experiences framework, a certified prevention specialist. She uses the parable, the river, and challenges systems and communities and faith-based organizations to reflect when engaging with families and children by prioritizing prevention with shared vision for hope and community resilience. So I present Ms. Kimberly Ladd and Ms. April Scott.
Thank you, Carla. We appreciate the introduction, and we love the opportunity to get to work with Carla down in the South Central region with the Commission on Children and Youth. I'm April Scott, as she said, and also joining me today is Kimberly Ladd with Aligned Hope. Not sure how to use this. So we were asked to come share today about our collective impact work using the Healthy Outcomes from Positive Experiences framework that Dr. Sege shared about this morning. And I wanted to start off by just telling you a little bit about Centerstone as the organization that is backboning a lot of this work in the South Central, Upper Cumberland, and Mid-Cumberland region. And Centerstone is the largest nonprofit behavioral health care organization in the nation, and just about everything that we do at Centerstone, from our community work with children and family services to our housing programs to our behavioral health care services and our evaluation teams with Centerstone Research Institute, we're working to prevent and mitigate adverse childhood experiences and promote healthy outcomes with hopefully positive childhood experiences being at the table. We have about over 3,500 staff nationwide and 1,200 military network therapists across our network. We served 126,836 people in 2021 and provided about 2,832,578 services in 2021. 32,500 of those were children, and we had about 750 school partners in 2021. We started our journey of hope back in 2006. We already had our early childhood network, which was focusing on birth to third grade with a system of care approach. And so we thought we would broaden that to that birth to 21 population. And that was when I had transitioned from working with adults to really focus on building systems of care that would be more focused on prevention. And as many of you know, you've heard about systems of care today, and that spectrum and that community-based approach. We're working to build those meaningful partnerships across that system of care. So after we kind of got into that 5-year project, we realized, oh, we were on the right track with the Early Childhood Network. We've got to get to these kids earlier. We need to step back and really put our efforts on this birth to 3rd grade population. And then from there, we realized that we need to get them even earlier. So we narrowed it down to birth to 5. Then we began providing services for evidence-based home visiting in 2011 because we thought we need to get to these kids before they're ever even born. And so we used the Healthy Families America model with the multi-generational approach to preventing and mitigating adverse childhood experiences and promoting positive childhood experiences for children prenatally up to age 3. Then we thought, you know, it'd be even better if we could get them preconception. And so we went full circle all the way around to preconception and started working on implementing the Healthy Start Tennessee services. And it goes from preconception, prenatal, all the way up to 18 months postpartum, which that was the point that really led us to continue our systems of care work in a different way, to really work on that collective impact approach that Melissa was sharing so much about prior to me coming to talk to you guys. And so we really made that shift to that collective impact piece, and keeping in mind that no wrong door approach and that family voice that was so important to us in our system of care work. And I'm not going to talk too much about collective impact because Melissa did a very good job summarizing that, and so many of you are already doing this work. But I would like to say that her work is a really good example of a well-funded backbone support that we would hope to have in place. I can't say that we have that, but we do have the support of those funders like Tennessee Department of Health and Tennessee Department of Mental Health and Substance Abuse Services and so many of the other partners at the table that do fund many of our grants that we use to provide direct services. The money that we use, it's not earmarked for this collective impact work to build positive childhood experiences, but they are fully in support of us laying our frameworks over those programs, so we appreciate them for that. We started in 2014 a community action network, and we looked at shared goals, gaps and disparities, what was going well in our communities and the South Central region, and from there we really worked to develop our goals. And some of our goals were safe sleep, where we educated authorities at the Housing Authority, OBGYNs, community partners. We provided safe sleep space for people who didn't have it, like pack and plays, and we had a breastfeeding action team that last count had enlisted 136 businesses who committed to posting the Breastfeeding Welcome Here logos, which basically meaning that customers or employees have a safe private place to breastfeed or pump. They have a newsletter that many of you have probably seen that goes out to Tennessee called Memos and Milk to support breastfeeding and educate people about the rights of families that are breastfeeding and also educate providers. We had community education campaigns around screening pregnant females for depression, anxiety, intimate partner violence, and prenatal alcohol use to promote alcohol-free pregnancies. And many of you have attended our racial and ethnic equity trainings that we hosted throughout the state and virtually to really focus on promoting equity. And some of those that some of you may have gone to were historical trauma and epigenetics, attachment and intergenerational trauma, equity as the path to equality, moving forward in collective trauma, the diversity-informed tenets. And we really use that in working with those infants, children, and families. And I believe that Aim High Tennessee is now an endorser of those tenets, so thank you for supporting that work. And we also supported Black Mamas Matter, Martin Luther King Jr. celebrations, faith-based collaborations, and pretty much anybody who was willing to come to the table to look at the disparity data and use parents as our guide to move forward. All of you who are Building Strong Brains, Resilient Tennessee trainers have seen this before, and we like to share this when we're talking about our Adverse Childhood Experiences Knowledge Mobilization Teamwork. We worked with TCCY to form the Adverse Childhood Experiences Mobilization Team in the South Central region to prevent and mitigate ACEs through community education and various events. And we also worked on an action team that worked to prevent substance use. And this is a good example of a group that was working, and then we learned of the Maury County Prevention Coalition, who was also trying to reduce neonatal abstinence syndrome. And so we're always looking for opportunities not to duplicate our efforts and maximize our resources. So at that point, we pulled in Kimberly Ladd, who was the executive director of Maury County Prevention Coalition at the time, and worked together and just joined our teams to focus on neonatal abstinence syndrome prevention. And from that relationship, Kimberly Ladd had introduced me to Science of the Positive of Montana Institute in 2020 with Dr. Jeff Linkenbach and all his wonderful work. And that is when I started digging deeper, and I found the HOPE framework, which is infused with Science of the Positive, and Dr. Sege and Dr. Linkenbach had worked together on that research and so much of that framework development. And so I felt like we had finally found that game frame that we'd been looking for that really celebrated the strengths of families in our community while transforming systems to provide and promote those positive childhood experiences. Because since 2011, we had been talking about adverse childhood experiences and all these risk factors and, maybe mentioning, oh, this isn't destiny, but where was the proof in all that, and what's next, and what are we going to do about this? And so I really felt like this healthy outcomes from positive experiences framework was the way to say what's next, and here's what we're going to do about it. And you can lay it over any framework. We're using it in so many different arenas, and it really can be applied to any program or models that you're already using. Oops. So from there, we had dissolved our ACEs Knowledge Mobilization Team because our awesome, fearless leader, Sean Noblet, had made a transition out of TCCY at the time, and we're so glad that he's back with TCCY. But we had dissolved that, and we were thinking about how to move forward. And so we combined the members of our ACEs Knowledge Mobilization Team and our Racial and Ethnic Equity Team and our NAS teams to the idea of shifting our focus towards growing what was going well in our communities and building strategic plans and promoting those positive childhood experiences and keeping that parallel process so that we could really apply this work at the individual level for our services, at the community level, and state and system level. And currently, this is our mission that we developed when we formed, and in response to the latest brain science on adverse childhood experiences, we want to grow upstream wellness by cultivating healthy outcomes from positive experiences for Tennesseans through collective impact and community engagement. Currently, our goals right now that we're working on, number one, obviously, is community education. And we talk about hope everywhere we go, and those of you who are in meetings with us regularly may be tired of hearing about it, but we're going to keep on talking about it. And we're also looking to educate people about positive childhood experiences that you've heard so much about today, and the Building Strong Brains, Resilient Tennessee. We're still providing those trainings that they developed and getting those out there because, yes, we want to build those positive childhood experiences and give that hope to others, but we also realize that we need to touch on the concern, so hope and concern. And so we've really been going out and, starting with ACEs and, here's the risk factors, here's the science, and then here's what you can do about it by sharing about the healthy outcomes from positive experiences framework. We've also, our number 2 goal is equitable promotion of protective factors to increase positive childhood experiences using a family-centered approach. And our 3rd goal that we're currently working on is to increase equitable access to services that promote positive childhood experiences. And I wanted to take just a moment. I see a few of you here. If you are a member of the Resiliency Project, or if you have attended one of our HOPE trainings, would you mind standing up just so we can kind of have an idea? And I'm sorry for those of you joining virtually or at the watch parties. Thank you, guys. We really appreciate you. And of those people that stood up, I see 1, 2, 3 people who have gone through the process to be trained as HOPE facilitators, and we were lucky enough to be able to sponsor them to get that certification so that they can continue sharing about this and hopefully bring this information to you and your organizations. In 2021, we had all our staff trained in the HOPE framework, and we also trained 6 of our staff and 3 community partners in the Resiliency Project as HOPE facilitators, in addition to training 2 HOPE champions. And the HOPE champion designation really just means that you can provide technical assistance to other collective impact groups or organizations around implementing that. And we also, early last year, we started integrating the HOPE framework into our Centerstone prenatal and infant and early childhood services, which includes evidence-based home visiting. And I know we had someone from Nurture the Next ask how that may be integrated, and we're doing it right now with the Healthy Outcomes from Positive Experiences framework, and we're using it in that evidence-based home visiting through Healthy Families America. We also integrated it into our regional intervention program, our fatherhood engagement, our Healthy Start services, our therapy and care coordination services. And since then, we have started offering HOPE trainings to those who have received our Building Strong Brains, as I said, or Resilient Tennessee training, I think we're calling it now. Since last year when we started this, we've trained 536 residents of the jail, 1,485 clients, 1,859 people in A&D rehabilitation centers, and 183 community partners on HOPE and how they can go about integrating that into their work. And for families, it looks a little different. We do that adverse childhood experience screening that Dr. Stewart was stressing is so important on the front end, but we also do the positive childhood experience screening to see what positive childhood experiences those parents may have had that's also going to contribute to their resilience as we're guiding their treatment. And then sharing with them ways that they can promote that in their own families. And we created a HOPE-informed peer support specialist position to support prenatal parents and parents of children up to age 3 to come together in an environment that really values the parent voice to improve the health of families. For so long, we had this requirement, our rule was you have to have 25% of program participants or community parents at the table. And so we have them here at the table. So what are we doing so that we can hear their voice and look to them as the experts in our community? And that's what we're really hoping to achieve through this Parent Leadership Action Team. And in April, we took the facilitation piece of that parent-led effort and we placed it with Aligned Hope, who is now backboning that parent leadership piece. And of course, we're still at the table partnering, as are all the other organizations that are a part of our collective impact team. But Kimberly Ladd, the executive director at Aligned Hope, is now the one that is really heading up all that work. We also shifted towards using the HOPE Ambassadors approach, which was developed by the HOPE National Resource Center and Dr. Sege's team. And we're really hoping that in partnership with Aligned Hope that we can reach quite a few more parents and really build up that support system in Tennessee. So I'm going to pass it off now to Kimberly Ladd, and I'm not sure where the rest of the slides went or what I have done, to talk to you just a little bit about Aligned Hope and that parent-led work.
All right, let's see, check, it's on. Hey everybody. I'm Kimberly Ladd. It's so good to be here. I'd like to echo something that Amanda from the Hope National Resource Center, she says frequently, and I like to piggyback when she says it. She says, hope is the so what to the now what, in addressing the challenges and celebrating the successes that positive childhood experiences can help with all of our work. So thanks, April. Again, I'm Kimberly Ladd, and I get to work with parents and communities to connect and grow hope-informed resources and supports to aid resilience and recovery across our state. As April mentioned, our friendship and our partnership formed as a result of a shared passion and shared goals to prevent NAS, neonatal abstinence syndrome, and connect mothers with prenatal substance use to strength-based resources and community-based wraparound supports in 2021. My advocacy efforts began in 2018 when my daughter needed treatment for prenatal substance use disorder, and I'm always happy to report that she continues to do very well in her recovery. We actually just celebrated 5 years of sobriety with her. Thank you. And we also recently celebrated my granddaughter's 5th birthday. Thank you. We want more families to have the opportunity to celebrate recovery and access to pathways that we've talked about, these pathways to resilience. Then in 2019, I had the great honor of working in my hometown of Murray County to organize the local prevention efforts there through the Murray County Prevention Coalition, which actually continues today through the leadership of Ms. Carla Walker, who you heard from earlier, and also a school board member, Michael Fulbright. And when I think about prevention, and I think that this is so across the board, a significant challenge that we face with prevention work is that we can often get so focused on what we want to prevent that we can lose sight of the things that we want to grow. So in my search for an asset-based approach to prevention and community organizing, I found the work of Dr. Jeff Linkenbach and the Montana Institute, which is home of the Science of the Positive that founds and grounds the HOPE framework. The Science of the Positive specifically is the study for how positive factors impact culture and experience. And it's how we discover, grow, and measure the good that we know already exists in our communities. Dr. Jeff refers to these opportunities affectionately as hugs, hidden, untold goodness that's there for us to uncover and discover together. But it's also a philosophy for living, and it's a blueprint for cultivating community that helps us develop soul in our leadership. And I like to say it's an effective North Star for integrating our prevention efforts. And here I'd also like to mention, we recently had a report published by the Montana Institute on specifically how positive childhood experiences mitigate adult substance use. I'll make sure, if that's okay with Melissa and everyone else, we can link that into our presentation so everybody can take a look at that research there. It's good stuff. Let's see, did I progress through 2 slides? Sorry about that. But through Aligned Hope, I get to work alongside a growing group of parents, as April mentioned, to promote family voice and choice through hope-centered advocacy, education, and community engagement to inspire upward mobility and multi-generational well-being for all Tennesseans. And by committing to a shared vision for hope in our state, together we absolutely can create the conditions for all kids in our communities to thrive and for all families to flourish. And to echo the words of Dr. Bethel, we are the medicine. To accomplish this, as Lizzie mentioned with Pathways to Resilience, she noted, Parents must be actively and meaningfully involved at all levels of policy and decision making. So therefore, we partner with communities to align and connect care that really emphasizes the role that hope plays in our health and well-being. As Dr. Sege mentioned, in the past 6 months, Aligned Hope, along with Centerstone and the Appalachian Promise Alliance and other family and child-serving organizations from communities across the nation, have partnered with the Hope National Resource Center to implement hope in our own organizations. And it's really through analyzing our own policy and practices that's really helped to promote this internal paradigm shift away again from that deficit perspective towards a strength-based approach. And this is how together we feel that we can best work to mitigate the outcomes of ACEs, reduce health inequities, and connect our families in meaningful ways. Through Aligned Hope, we have 3 primary focus areas. The first is, first and foremost, is to engage families by linking and referring them to local resources and supports and providing opportunities to grow advocacy and leadership skills. A little side note here, I put flyers on all of the tables. Every 4th Tuesday of the month, we host an online parent-led peer support and advocacy group. Would love if you would connect parents that you work with to that group. We would love to see that group expand even more. Then we also provide training on the HOPE framework as well as additional technical assistance. April mentioned this already, but we also have a growing group of HOPE ambassadors. And HOPE ambassadors are parents with lived experience who also have a desire to work with other parents and advocate and give back by connecting others to hope within their schools, faith-based organizations, and larger communities. And we also get to work with coalitions and collective impact networks to effectively implement hope-informed strategies that promote primary prevention and community-level resilience. This has been echoed, but it's a quote that it's actually attributed to several people. I was trying to look to see who is the originator of it. Maybe somebody can tell me. But it's a quote that says, "No one can do everything. We can all do something, and together we can do great things." There is a piece of paper on everyone's table that gives a prompt for how you might implement these strategies going home. And that's really my prompt to you as well. How can you take what you've learned today and grow hope and grow pathways to resilience in your own community? Thank you so much. Does anybody have questions for April or me? You're right. I know, it's so bright. Okay.
I'm going to barge in on your space. I will send out PDFs of all the slideshows as permitted, and I think they've given me permission to send as well. Oh, that's my. Oh, her folder. Oh. I know what she wants. And yeah. We got this, guys. We got it. Whew, right? You're doing awesome. Look at you. You're the tried and the true. Your friends have abandoned ship, but we're still going to love them. You're doing great, though. Thank you for hanging with us. You're not going to be disappointed for the rest of the afternoon. I can promise you that. We're going to take about 15 minutes to do another little round of table conversations. If you find yourself at a table and feeling a little lonely, feel free to join another table and I give you permission to invade their space. Introduce yourself, and there should be a new card on your table that has a blue edge to it. Don't forget to put your team name on there, and then we'll collect those in about 15 minutes. Don't leave. Jesse's a rock star. You want to hear him. And we have a closing challenge when you do get ready to go. So hang with us. We will see you in about 15.
folks. We know you guys are still knee-deep in your table conversations, and we hate to rush you along, but we know that there will never be enough time for us to allow for you to talk about all of the things that are so critical to the work that you guys are doing. So rounding out our Resilient Tennessee Collaborative Summit, I am so excited to welcome our next speaker back to Nashville. Our next speaker, Jesse Kohler, is the Executive Director of the Campaign for Trauma-Informed Policy and Practice. And so I can tell you all kinds of amazing things about Jesse and all of his professional experience, which I swear you would think I was lying because I think he's like 22 years old, but has really accomplished some incredible things in his life. But I think that what I really want to leave you with is on his bio, the last paragraph is what's the most important. So Jesse lives in Washington, D.C., with the love of his life, their hamster named Hamuel, and a guinea pig, Bryce, stuffed animals, and many plants. Besides working, Jesse enjoys time with friends and family, playing and watching sports, exercising, reading, and serving as a sous chef when the love of his life has time to cook. So I want you guys to help me join Jesse Kohler with Campaign for Trauma Informed. I always get my P's mixed up. CTIP, Jesse.
Richard's introductions go a lot longer when you have a Wikipedia page. So maybe someday I'll be able to. We're just going to test this out really quickly. It's a pleasure to be here with you all. This is the first time that I've ever been introduced back to a place that I once spoke. So I sort of have this canned speech that you heard if you were here at Child Advocacy Days last time. You heard that. I didn't want to give the same speech, and so I am trying a new speech. So forgive me in advance if it doesn't go well, and wonderful if it does, but I feel safe with all of you. We like to start with some pads, predictions, acknowledgments, and disclaimers, and so you all can read. If at any point some of these discussions get to be too much, please feel free to do what you need to take care of yourselves. Not going to take that personally. While there is a tremendous amount of pain in this world, which we cannot avoid, there is also so much strength. And though there is disheartening information, I hope that we'll all leave here with a renewed sense of energy and purpose as we continue to move the great work in the state of Tennessee forward. And I know that it's been a difficult year in Tennessee, particularly in terms of the legislative session, a lot of stuff that's happened since I left just 2 months ago for Child Advocacy Days. There's been a lot of things that I've heard in the news, and I have been thinking of all of you. But again, I know that there is so much strength in this room, and I am well aware that this is the last presentation of the day. Our brains are probably feeling pretty full right now, and so hopefully what this will do is more than anything just synthesize the main points of everything that you've already heard so far today and let us move forward from there. The world is not in the best place right now. We have a youth mental health crisis. We have opioid-related deaths on the rise. Homicide, suicide rates are out of control. Extreme weather events are mounting. There is a debt ceiling that is being pushed, and we continue to have mounting debt, and sometimes it can feel so hopeless. And in the state of Tennessee, we have the second highest drug overdose mortality rate in the United States, the 22nd highest suicide mortality rate, and the 8th highest homicide mortality rate. The information from the CDC that I could find is all from 2021, so I can't speak to 2022 or 2023. This is not because of the work of all of you. This is just the reality of what we are facing as we think about what we are trying to build with a resilient Tennessee and as we build strong brains. And what that oil slick on the right, which is not the most graphically appealing image in the world, is that we know that so many of these problems are preventable and are related to adverse childhood experiences. So for instance, 67% of alcoholism and 78% of IV drug use, the population attributable risk for that comes from adverse childhood experiences. So if we reduced ACEs, we would reduce the various problematic outcomes that you see on the screen right there. At the federal level, at the state level, we know from the Sycamore Institute that the adverse childhood experiences, I believe that this study was done in 2017, cost the state $5.2 billion annually. $5.2 billion. At the federal level in 2017, we also had from the World Health Organization that ACEs cost the United States $748 billion annually in lost productivity and disability-associated life years, so pretty much healthcare and workforce costs, as you see with these numbers here. These are conservative estimates for a number of reasons when we talk about trauma and promoting resiliency, because adverse childhood experiences cover 10 specific experiences, and we know that there are many different population attributable risk factors beyond just the ones that you see on the screen there. So we are not just talking about a moral and human issue here, because I know that when we go to the legislature, we make those claims, and we will continue to, that this is what we need to do for our people. At the same year as that 2017 data came out, about $748 billion to the annual budget, the Department of Defense budget for that entire year, to put that into perspective, was $738 billion. So ACEs cost us more than the entire Department of Defense that year. And we did independent research on the population attributable risk data and found that it also cost us 650,000 lives based on CDC mortality information. And so there is a human cost, but there is also a very real economic cost. So what we are talking about when we go and discuss policy and creating conditions for all individuals, families, and communities to have the opportunities and supports necessary to thrive, it is the best investment that we can make in our present day and in our future across generations. The status quo, though, is simply not working. I won't just read these off the slide, but the last one that I will focus on is that too frequently we try to fit into a one-size-fits-all model of what's going to work for every community. And even within Tennessee, from Nashville to Memphis, everywhere in between across the great state, you heard from Appalachian Promise, what each community's population's needs, resources, desires are and look like will be different. And what policy can do at its best is create conditions that allow for innovation to occur at the community level. And I will talk again in a bit about a model that showed us the economic impact of being able to do just that. Very quickly, I wanted to define trauma and trauma-informed care. Trauma-informed care doesn't have a great definition. I heard one the other day that I put in here. Trauma, we have the 3 E's, an event series of events or circumstances that are experienced and that have lasting adverse effects. That's SAMHSA's 3 E's definition. Resma Manicum, who is a wonderful social worker, talks about trauma being a thing or series of things that happen too much, too soon, too fast, or for too long without something reparative or restorative coming in and being able to support us. And then Dr. Robert Roten, stripped him of his doctor title, please don't tell him that, says that trauma-informed care is the intentional application of compassion coupled with a strong belief in human potential, which I loved, because as we struggle for a good definition of trauma-informed care, I think that it's that human-centered aspect of the work that we do that is so important, and that intentional application of compassion that we bring into systems. There are 4 R's. We realize, recognize, respond, and resist re-traumatization for trauma in trauma-informed systems, and the 6 principles that I'm sure that everybody here knows so well: safety, trust and transparency, peer support, collaboration, empowerment of voice and choice, and cultural, historical, and gender issues. How many people think that the state of Tennessee has embraced all 6 of these values so far? We still have more work to do. And when we talk about cultural, historical, and gender issues, sometimes this gets into conversations around just DEIJ, which gets us into like those people versus, other people sort of issue. But this responds and encapsulates all communities. To use Appalachia, for example, which is a predominantly white community, There are historical issues that we need to take into consideration when we deal with the opioid epidemic because of the way that the Sackler family targeted communities that had been stripped of their economies and were dealing with pain, and that opioids could be differently prescribed because, sorry, I have a lozenge, and so I'm just spitting all over the place to try not to cough too much, if you can see that. I am so sorry to whoever has to clean up the stage, and so glad that no one's speaking after me. But, we need to recognize all that has happened in Appalachia as we look for responses to the opioid epidemic. So it's not just a black versus white issue, this is all of us. And similar to that, I will share in my description of neurosciences, because I know that I talked about neurosciences last time, I'll try to embed my own story throughout my description of neurosciences, and just want to acknowledge the fact that I come from an upper middle class family that loved me tremendously, and I have a lot of privileges in my life, the greatest privilege of which is how much I was loved. But in that, with all of that, I have experienced tremendous trauma, and again, it is not an us versus them problem. Trauma, stress, adversity impact everyone. It is just part of the human condition and the price that we pay for this beautiful life that we get to live. And so we talk about hope is near. You heard from Dr. Sege. No one better to tell you about what hope is from. I know that Kimberly Ladd was just telling you as well. But we talk about how healthy outcomes from positive experiences is neuroscience, epigenetics, ACEs, and resilience. To describe the neurobiology of stress, this is a Dr. Bruce Perry slide. Our brains are built from the bottom up and from the inside out, which is why Dr. Stewart's mom was so smart when she said that there may not have been too much in between those ears when she was growing up. When I was 13, I went through a choking incident where I choked on a piece of food and I could not eat solid food for 4 months. There was what we call adversity adapted physiology, to where every time that food was near my mouth, I would have a visceral reaction, an incredible anxiety attack and stress response that kept me from being able to swallow solid foods. It didn't matter that I knew that that would, in the long term, kill me. My body, in the attempt to save myself from what had caused me so much harm, was inadvertently causing me more harm than I would have otherwise experienced. I survived off of Ensures, if you know those like Pedialyte type of drinks, which now I have my own visceral response to. But we need to be able to recognize when folks are in that part of their brain that they are not in the cortex, which is where complex and abstract thought, the things that breed academic success, workforce success, the quote-unquote soft skills, which I think are the hardest skills that we can possibly build, having worked in education, that's where we want for people to be. But I was not physiologically able to be there because of my own interpretation of an event and the way that my body responded. Some people may choke on a piece of food and be totally fine and take the next bite as soon as they get the Heimlich. I struggled for the next 4 months. And so we need to recognize that different people have different reactions and may interpret their own experiences differently. And that's why universal precautions are so important, bringing about compassion instead of judgment and support instead of shame. So what we want to be able to do and recognize is that when I was 13 and in school, it was 7th grade at the time, when I was afraid to swallow my own saliva, when I was not getting food in my body, I was not able to learn. And what was worse is that too frequently the response to all of that was for my teachers to try to tell me what I should have been doing, but that isn't the part of my brain that I was in. That is one specific traumatic episode and one specific response. But the 3 R's are a beautiful tool that I like to tell everybody while I'm here, because if someone had just helped me regulate, and the people that did the best to help me regulate, and then related with me and said, that sounds so scary, then I was more open to reasoning, and that is what brought about healing. But not trauma-informed systems too frequently don't recognize the brain architecture, the way that neuroscience can actually support the way that we regulate, relate, and then reason to help people reach their full potential. which is the real goal. I think that there is a bit in my own background as a Jewish American of the epigenetic changes that my grandparents, my great-grandparents had experienced through the anti-Semitism of the Holocaust, their move to the United States, and anti-Semitism that they had faced that may have impacted that. It's very complex. It gets into a nature versus nurture argument, but we need to recognize the ways in which we carry on the legacy of our ancestors through epigenetic changes, which are more or less on and off switches to how we encode our own DNA. So there's DNA and epigenetics that also gets into the intergenerational cycles of trauma, in addition to the way that our own stress and adversity then manifests itself to the way that we rear our own children, support each other in communities, et cetera, that's a valuable part of this conversation. We all know about ACEs. You all could probably teach me more than I know about ACEs, so I won't do too much to try and teach you, but we know that that early childhood adversity has lifelong consequences. One thing that I want to uplift very quickly, though, is that my ACEs score is 0. Like I said, I am incredibly privileged, incredibly lucky, but I had other complex adversities and trauma that existed. Those 10 ACE categories that are so commonly experienced across our society are a small and finite portion of the infinite complexity of what can be traumatic in our lives, and that is just important to recognize that while these 10 are incredibly powerful and that they are, because they are finite, we can measure them. Because they are finite, we are able to create that Sycamore Institute $5.2 billion figure because we can actually measure those things. But to recognize that when we deal with an individual, they bring with them a lifetime of experiences that may or may not have been traumatic or may or may not have been positive. We talked about the ways in which it's not just adverse childhood experiences, it's adverse community environments that impact us as well. We're not just the trees, but the soil that we are nurtured and growed in impacts us as well. And I think that starts to get into the policy conversation a lot. Excuse me. And then we also know, I don't know if anybody's heard of the 4 realms of ACEs, but there's also atrocious cultural experiences that can be taken into perspective, as well as adverse climate experiences, which I know many in Tennessee are all too familiar with, that we can take in. And then no one better to talk about positive childhood experiences than Dr. Christy Bethel, so I will not go into these. But I will say that while I was struggling, baseball was the thing that got me through. For me, baseball, my coaches, and being able to have a space where I could just actually forget about all of the fears and anxieties that I brought in the world with me saved my life more times than not. Having those opportunities through the arts, through music, through sports, through connections, whatever it may be, is so important to create conditions so that all children have the opportunities to thrive, as well as adults. We all need positive experiences as we continue to move through in the world. And finally, the R of near resilience. We have a capacity to develop strength to combat the adversity that we face, and that healthy relationships are the greatest buffer that we have to stress and adversity as human beings. Now, I also want to recognize that while all of that was said at an individual level, when we talk about policy, we need to, and practice, frankly, we need to recognize the way the practice is implemented is focused on an individual, but we can't just put the onus and burden for trauma and resilience at the individual level. We have traumatized systems that perpetuate stress and adversity that then disproportionately impact marginalized communities that perpetuate or create the outcomes that we see at the individual, family, and community level that policymakers need to be able to deal with. So if we are just being trauma-informed and helping individuals build resilience to oppressive systems that perpetuate trauma without also addressing the systems themselves, then we are doing a disservice to the movement that, in the full honor of the 6 principles that we saw and the 4 R's of what truly trauma-informed systems are, it is incomplete. And we need to realize, again, that policy creates conditions for communities. Far too frequently, we have policies that are creating conditions that hurt communities and harm individuals. But just as easily, we can have policies that create conditions so that way all individuals, families, and communities have the opportunities and supports necessary to thrive. If you hear me say that line over and over again, that's our mission statement, so I'll just keep leaning back on that. I think that being mission-oriented is very important. Similar to that, we have a public health approach where right now we have such a treatment-first approach to the way that we heal folks, or think about healing people, I should say. We wait for people to become so dysregulated too frequently when there are off-ramps throughout. This is not the same as when Dr. Bethel said that we are all the medicine. That is the greatest illustration of the public health approach that I've ever heard. But we need a more systematic approach that I know all of you are working through to help create. We need to promote primary prevention, secondary prevention, early intervention, and then get to treatment, because right now, how many folks in the audience are social workers? How many folks that are social workers have friends that were also social workers that have burned out and left the field of social work? All the same hands for those who are facing me, which I appreciate very much. But we know that because of that treatment-first approach, we've created a bottleneck that is burdening the workforce and not allowing for people to do the full jobs that they want to. And so we need to create a different approach, because there's also systematic disincentives to even becoming a social worker. For all of the people who are social workers or teachers, I say thank you. But the reality of doing that in the 21st century, having graduated college in 2016, is that you need to go through 4 years of undergraduate experiences, 2 years of a master's degree, all of which accumulates debt, while in the master's degree doing unpaid internship hours, and then getting, if you want to become a clinical social worker, then getting supervised clinical hours, which sometimes you have to pay for, all of which to get a job that doesn't allow for you to pay off the debt and have a cost of living that allows for you to, there are serious systemic problems that we have to understand and deal with to be able to truly treat the needs. And so we need to flip the incentives of our system toward prevention. And we need to recognize that in order to do that, trauma underlies so many of the social outcomes that we want to overcome and work to create a thriving society against. And so there's so many more that come off of this. This is called a syndemic slide. The term syndemic, much more palatable, following the pandemic, same root, but essentially means that it is an underlying root cause to a link of different social outcomes that have that same root cause. And what we see with trauma at an individual level is a fragmentation of a narrative at an individual level that we need to heal to create a coherent narrative and vision. What we see in traumatized systems is a fragmentation of systems and a lack of coordination across those systems. And so similarly, what I think is a therapeutic approach at a systems level is to create integration, so that way all of these different services are able to communicate and coordinate, and we reweave the social fabric that allows for people to better get the services that they need. And at CTIP, what we're doing is that we shape policy, we work to empower advocates, and we amplify community voice. Because again, there can't be a one-size-fits-all approach. I invite everybody to join our community advocacy network, to join or look at our Ideas Lab pages, and we will continue to promote more and more work. I'll get into our final piece, press on, at the end of my speech here. But there are two main policies that I just want to share that we're working toward this year that were introduced last week. The Rise from Trauma Act creates a new grant program for cross-sector community coalitions, and then also creates training to reduce hospital readmission rates, create stronger law enforcement supports, and then other supports and training for frontline service providers. And then the Community Mental Wellness and Resilience Act again creates grant program for cross-sector community coalitions to take a systemic approach to moving in front of extreme weather events. Too frequently right now, the response to cascading extreme weather events, which again, I know has impacted many of us in Tennessee and beyond, is that we come in after a dysregulating event has already come in, and then we try to deal with the problem. But these issues are mounting. Community violence is growing as well. They are becoming almost predictable. And so what the Community Mental Wellness and Resilience Act is doing is trying to move upstream, build connection and capacities and resources and skills at the community level, so that way, if and when a dysregulating event comes in, we have those strengths to lean back on and are able to rebuild more quickly and more effectively and better to be able to move forward from, instead of just responding after the fact. And there are a tremendous number of resources, our advocacy series, that I hope you will all lean on to become, to support you as you continue to do work at the local, state, and federal levels, and for those of you that do work at the tribal levels, at the tribal level as well. We've seen tremendous outcomes from home visiting. 8-to-1 return on investment is the best economic science that I've seen, but 56% reduction in emergency room visits. Trauma-informed schools have shown a tremendous amount of promise, but like I did last time, I'm going to focus really quickly in on that middle number right there on a 35x return on investment, where the state of Washington, through the Family Policy Council, what's now called the Self-Healing Communities Model Report, generated what they call general community capacity that then allowed for communities to innovate. It was across 42 different communities in the state, and they built leadership across the community, went from what's wrong with you to what happened to you, to what's strong with you, to how will you lead, was the way that they interpreted that, that transformation of understanding. They focused on how stress and adversity impacts the human mind, body, and spirit. They collected data very intentionally across 7 categories, and they educated widely to develop community conversations. They taught regulation skills. At CTIP, we talk about democracy being the antidote to trauma, because in a truly democratic system, not necessarily what the United States currently has today, but in a truly democratic system, we have input from all aspects of that system. And to be able to truly do that, we need to be able to remain regulated, because people see the world differently. We have different experiences that we need to be able to be mindful of. And so to teach those regulation skills that allow for us to have those conversations and then get to a root cause that we all agree on, to be able to address the deepest needs within our communities, proved to be very cost effective. And on the other side of the screen, you'll see that in one county, they reduced youth suicide and suicide attempts by 98%. They increased graduation rates by 50%. And what it looked like long term is that case management, the workload, the actual necessity for governmental services reduced significantly. And over the lifespan of the 17 years of the project, they saved $1.1 billion for the state. That changed when in 2011 they decided to focus all of their investment on the first 3 years of life. And while it is incredibly important, 0 to 3 does incredible work that shows the importance of investment on the first 3 years of life, if we are also not supporting parents in that work, if we are not also meeting the needs of teens who go through tremendous adversity at various stages through their adolescence and development, it can be very difficult. And so we need to look at trauma as a lifespan issue. And while I know that it has been, this is like where it's very new, and I've never talked publicly about this, so pardon me if this just is getting way too wonky. But I have become frustrated with the political process. I'm 29, I'm impatient, and I don't want to continue to wait for government to need to do the right thing. I will remain hopeful and remain dedicated to my advocacy to push forward the legislation that allows for us to build capacity. But in the meantime, I'm developing what I call full capital. You'll see 8 forms of capital. I think that there's more than that. But where I think that we get capitalism wrong in this capitalist nation of ours is that we focus so much on economic capital. We spend economic capital to build more economic capital, and we forget about social capital, cultural capital, linguistic capital, et cetera, et cetera. And if we were to invest in the full pie, what we would really see is that the entire pie grows, including the economic capital, and that everyone who currently has can have more, and those who do not have, we can start to invest more in so that everybody has their opportunities to thrive. I think that while government is dragging its feet, there is an opportunity to actually make a lot of money to then reinvest. And so what you'll see in that graph, which I'll try to explain, again, I'm sorry if this is just not well done, Dr. Stewart isn't here to tell me about the Hudson effect anymore, but of like having to take a pause. And I recognize we're at the end of the day, so won't be able to do that. I would welcome being able to come back again in 2 months and continue to come to Nashville or wherever in Tennessee. But so essentially, it takes a while to mitigate against the costs of where we currently are. But when we do, it may take 5, 8, 10 years to do so. We start to see a return on investment that would occur within the 2 years of an elected official's terms. So we can initiate the cost and the investment in building community capacity to reduce the caseloads that we saw in Washington State's model that have a proven cost-benefit analysis. And quickly, I developed this with, Richard talked about the love of my life, Tina. She's an attorney that works with private equity firms. And we actually came up with this together while we were eating lunch during COVID. And, you know, I hear her talking about building oil pipelines, which she no longer does. And I was trying to beg for like a few $1,000s, you know, to do what I personally believe is far more important work. And, you know, it was just very, very frustrating. So we were troubleshooting that. And essentially the way that oil fields get built is that you invest in the development of a pipeline, the rig itself, with associated costs and potential losses if there's a spill or anything like that, for how much oil will be pumped out over 30 years, which then creates massive wealth for everybody on the back end of that deal. The people who initially invest, the people that work on the pipelines, there is money all throughout that. If we were to invest in community capacity through a similar model, and I know that was oversimplified and I'm like way missing things, the beauty of that is that the return on investment would never end. What we see on that shape there, where we reach that asymptote, likely 7+ generations in the future. But all along the line, as we reduce the rates of intergenerational transmission of trauma, we would continue to see a return on investment and a better thriving community where we reduce the need for caseloads to even be there in the first place. We are reducing the need for government to be involved in so much of our lives, which, by the way, is an incredibly conservative argument for why trauma-informed care is necessary. And so while we continue to promote policies, I think that there is an economic opportunity through full capital to invest in all forms of human capital that allow for us to build general community capacity and reduce ACE prevalence. What is so exciting about this to me in Tennessee and speaking with all of you today, and the reason that I tried to piece this together in some sort of, you know, a logical statement, I don't know how well I did, but is that you all have been doing this work for 13 years. You all have laid the groundwork throughout the state, and that there is buy-in at the community level, at the state level, in varying degrees, that allow for this to continue to promote. And the wealthiest person in the state of Tennessee, I forget his name off the top of my head and won't name it out even if I did, out of respect to him, is worth $4.8 billion and got his money off of hospital systems. And so if we can get investment from that individual or that family to be able to build community capacity, we reduce that reliance on hospital systems and create a counter-cyclical wealth sort of stream where as people get healthier, as we prevent the need for systems and hospital involvement in the first place, we are able to actually generate wealth when people get sick as well as by preventing in the first place. And I think that that is an awful good call to action for any investor. And so I think that there is an opportunity, whether from him or others in Tennessee, with the groundwork that is laid in so many communities here, to leverage public and private investment. And then long-term, this would come about through a partnership with county and state governments to collect data and hopefully bring about the right policies when we mitigate against the costs that are associated with the initial investment in community capacity to develop those comprehensive strategies that allow for us to reduce ACE prevalence, which again will have plenty of economic benefits in the intermediate term, but the long-term benefits as we reduce intergenerational transmission and build more hope and promise for future generations, I think is so hopeful. And so I come here today, again, trying not to give the same speech that I gave last time, but also humbled by the opportunity that exists in this state to generate a model that allows for us to while there are frustrating state legislative experiences, and I hope that we continue to advocate for good policy to create conditions, that there are other strategies that we are trying to build as well, because no matter what, we are going to continue to try to create community-led, trauma-informed, prevention-oriented, resilience-focused, and healing-centered systems. I come to this through another nonprofit that I run called the Change Campaign, which was my rebuilding almost of myself in college, which is now another nonprofit that I run that allows for me to loan out to CTIP. And the gentleman that you see on screen, similar to what Dr. Stewart did, his name's Dan Press, and he was a mentor of mine. He was one of the main founders of CTIP. And when I met him on my 24th birthday, and he was a policy guy. He represented Native American tribes all over the country as an attorney for his career. And when he was 70 years old, he found out about ACEs and intergenerational trauma. And despite all that he did to create conditions so that way tribal communities could thrive, he started a second career and said, I missed the boat and wish that I could do more. And he took me under his wing, and as much as I shared with you about my understanding of neurosciences, at the end of the day, I am no expert. I'm not a scientist. I didn't study this in school. I had those relationships and positive experiences that allowed for me to heal. I come to you with lived experiences of suicidality and substance use, and Dan never cared. Dan didn't see that in me. He always saw something more. He saw the promise of a young man with a vision for a better future. And he invested his time and resources and energies into me. And unfortunately, he passed away in October after a long battle with lung cancer. But through that relationship, he built someone who is able to come up and speak to you on stage, not just once, but now twice, and hopefully 3 times and many more times in the future. And it is not that I am so special, because I don't think that I am. I'm just a person. I graduated with a 2.6 GPA, so I'm definitely no genius. But he saw something special, and every single human, every single child deserves someone that doesn't see them for all the bad things that they've done in their lives, but sees them for the promises that they hold in their future and invests in that. And that's what we're trying to build at the end of the day. I love that man. I wish that he was able to be here. Melissa, how are we doing on time? We got like 2 minutes? I don't know that that's true, but Dan, as he was getting more and more sick, the last thing I believe that I will leave you with today is that Dan created this vision of what we can do as CTIP, because my background is not as a policy guy. I worked at a Philadelphia high school and at a community center as the director of development, and then got pulled up into CTIP for various reasons that are a much longer story than, despite Melissa's words there, I have time to explain. But we know that the power of this work lies in the grassroots of this country, throughout the grassroots. The power of this work is in that 13-year-old kid that is going through an impossible amount of adversity, trying to figure out how to manage through life when he's afraid to eat food, for instance. And there is an adult that gives him an opportunity to heal by building a relationship that helps buffer that stress. We need to manage in the grassroots, but we as a national organization, the folks at TCCY, Resilient Tennessee, and others that do work at the state level, we can create conditions that allow for those relationships to occur. And that's what the vision really holds. That's where promise lies in the future. And so what we hope to do as a national organization through, again, his name was Dan Press, so Press On carries on his legacy and vision for the future, is that we create relationships with every state that then creates relationships with every community, through which we are able to educate and create relationships with individuals that develop relationships with each other, that remend and reweave the social fabric that has frayed far too much and that far too many people fall through. So that way we are continuing to create relationships, and through this relationship and infrastructure, we develop a bi-directional flow of information from which we're able to learn from the innovation that occurs in communities, that communities come up with that far too frequently right now does not get communicated to other communities and sort of falls into just that community by itself. And we can then communicate that information with others, as well as mobilize groups of individuals or groups of people, instead of just as individual advocates, to promote the perpetuation of a movement moving forward and propel the movement to prevent trauma and foster resilience long term. And so that is the importance of our community advocacy network. That is the importance of Press On as we continue to build out this framework. One of the first activities I was just presenting to Kentucky that had a similarly frustrating legislative session. I'm now sitting here with you, and I was on the phone with Iowa earlier today as well. And so bringing you all together to come up with a coordinated strategy as to how, where there are currently supermajorities that are pushing against a lot of the values that we believe in, how do we come up with a coordinated strategy that allows for our values to emerge strong in future legislative sessions, learning from what just happened here in 2023 and where politics has been going, will be an early initiative of Press On. But as we build out all of these frameworks, I just want to leave you all by saying that for everybody that develops a relationship or builds power and brings trauma-informed care and healing-centered engagement into whatever your locus of control is, those that are doing work at the grassroots need more support, and we can continue to build that. But I want to thank all of you because I've learned so much from the other presenters here today and continue to learn more from all of you that do this work here in the great state of Tennessee as we build a hopeful future for ourselves, for our children, and for those that are yet to come that we may never meet. And that's the promise of this work and the importance of everything that we do. And so despite the frustrations, I hope that we remain committed to the long process of systemic transformation to create a better future for everybody. And with that, I'll finally stop talking. I hope that that made some amount of sense. Please don't hesitate to reach out. And again, I thank you. Thank you so much.
I mean, I just think Jesse's kind of cool, right? He's got a passion that, like, at 29, I can promise you I didn't even know existed. And I think at 29, I might have still been a dietitian. So who even knew, right? Here we are. But thank you, Jesse, for hanging. Thanks to all of you for hanging with us through the end of the day. We're so thankful that you're here. Here's your goal, okay? Before I let Richard tell you goodbye and you run away, here's your goal. If my friends would put that QR code up, if you'll scan this QR code, there's 3 questions. They're not hard, just 3 questions. If you'll take a chance to scan it, answer those questions, you'll be my favorite, but don't tell anybody else, okay? You also, don't forget your cards. If you've been able to make contacts and need to write it down, you have a place to write it down here. On the back side, we're asking you to think about what is your next step in a month, in 3 months, in 6 months. What does it look like for you? Who inspired you today? What piece of today did you think, I need to read more about that? What is he talking about, the 8 pieces of capital? You know, it's not just economic capital. Things like that. This is for you to take with you. If you want some lifesavers, those are for you to take with you as well. And I just want to say thank you to you all. You are why we do this. We appreciate you taking time to come and be with us today here. I know everybody wanted a virtual option. We want this community piece, the networking, the conversation, so we don't take lightly that you took time to be with us here. And to our watch parties, we're so thankful for you guys. You rock. We had watch parties in Chattanooga, Knoxville, and Memphis. And Richard thanks to all of our friends at Urban Child Institute and McNabb Center and all the cool kids that helped facilitate those. And I think that's what I know, Richard.
Yeah. So,
all right.
A couple of other thanks and then just a couple of thoughts as we close out. I would be terribly remiss if I did not ask you all to join me in thanking Melissa McGee, who is the director of the Resilient Tennessee Collaborative and who does all of the work, and especially today, to bring us together. Also, I will argue all day long that the staff at the Commission on Children and Youth are the absolute best staff in state government and any other organization. So join me in thanking all of the Commission staff who helped with check-in and airport runs and things like that as well. So, You know, I was thinking about kind of how I wanted us to wrap up today, and so there are kind of two thoughts that I have. And so when we think about all of the work that's happening, sometimes it's still easy to get very overwhelmed with what more we want to do and with the speed at which we want to do things. And so at about this time last year, I will tell you all, I am a native Tennessean, born, raised, and educated, and except for a few years when I lost my mind living in New Orleans, I've always lived here. And so about this time last year, I had the opportunity to be in Jackson at an event that was really spearheaded and brought together by Matt Marshall, who some of you know is the president and CEO of the United Way in that part of the state. And it was really kind of a response to some county profiles that the commission had developed. And so he told a story that I had never heard before in my entire life living in Tennessee. And so I did not want to mess up the story, so I'm going to read a little bit of an online article that I promise is going to make sense. So how many of you have been to Chattanooga? Yeah. So I was in Chattanooga just day before yesterday for a real quick in-out trip, and it is a beautiful city. And when I kind of round the corner and see the water and start coming into the city and all of that, I'm always just taken aback at how beautiful it is. But I did not know that Chattanooga, Tennessee was once so choked with smog and pollution that, as reported by NBC, people had to drive with their headlights on all day. The federal organization that would become the Environmental Protection Agency declared the city the most polluted in America, with dangerously dirty air full of ozone particulates and other toxins. That was 1969. Today, this city of hills and hollows, nestled at the foot of the Appalachian Mountains, is a mecca for green technology. Outside Magazine has twice voted Chattanooga the #1 spot for outdoor activities, from canoeing to triathlons and rock climbing. And the city was recently ranked number 12 among the top 15 metro areas in the U.S. for seeing the most improvement in air quality. And when I think about things that can be accomplished during the last year especially, that story is stuck in my mind. And it's stuck in my mind for a couple of reasons. Because I was born in 1969, and in my lifespan, I have seen Chattanooga become this beautiful, amazing city. And so I think to myself, those folks that were decision makers, those folks that were partners, just like you all, at that moment in time came together and said, we are going to change this, and we're going to change this through big and small ways, consistently every single day. And I think to myself often with this work, when it is overwhelming, and when things are challenging, when I am dead and gone and someone stands where I'm standing now and says, there was a point in time where Tennessee was ranked 36th in child well-being, and there was a moment in time when our mental health, our children's mental health were in real challenges, and we had high rates of suicide and suicidal thoughts and things like that. And I want that person to say, I am so thankful for people that sat in a room 54 years ago and said, we're going to change this. And those are you people who are sitting in this room right now. So thank you very much with that. The next thing that I want to circle back to is the same way that I started. So when we were talking about the summit, we had the goals. And so I want you to help me realize if we met any of these. So we said again, the summit will inspire community connectedness, strengthen understanding of community engagement, resilience, and positive childhood experiences, and further cross-sector collaboration with local, regional, and statewide partners to address challenges and improve outcomes for children, youth, and families across Tennessee. So did we meet any of that? Yes or no? Okay. Hope so. So what I will tell you is a little bit of a story in that I live in East Nashville, and my backyard, there is a fence that's in my backyard that separates my neighbors, my backyard neighbors from me. And so it's not because I have bad neighbors, it's just because they have this amazing pool and they're, being safe and all things like that. So Kevin, the dad of the house, built this tree house type structure that has a slide that goes into the pool for the kids. So there are two little ones that live back there. There's a beautiful little girl named Gabby who is probably 8 now, and Miles who is 6. And Miles is the most talkative child I have ever seen in my life. And so every evening, Miles will come out and will climb up into the treehouse structure, which overlooks the backyard. And regardless of what I'm doing, he's going to tell me about his day. He's gonna oftentimes bring out his dinner and sit there and eat it while we're talking. And so Miles informed me a couple of days ago that this coming weekend they are going to visit his grandparents, and he's going to be out of town. And so he said, Mr. Richard, he said, I know it's going to be hard that I'm gone, and I hope that you don't miss me too much. And so after I assured Miles that I was indeed not going to miss him too much while he was gone for a couple of days, it really made me start thinking about you guys as well. So we are not going to give you an opportunity to miss us too much because with the work of Melissa and the work of the commission, we are going to keep bringing you all together in a myriad of ways so that you can learn from each other, so we can build on successes that are happening in other parts or across the state in really ways that we can amplify our voice to make Tennessee the state that we want it to be, that it deserves to be for the children and youth and families now and for those that come after us. So thank you all so very much. I hope today's been meaningful. We wish you safe travels on your way home, and please know we'll be in touch with you soon. Thank you.